Can we start, Venu?
Yeah.
We can start now.
Dr. Kalpesh, sir, you can start. Thank you.
Yes, sir. Ashwini,
Yes, sir.
I think I have gone through your e-paper, that is the management of acquired single-sided deafness.
Yes, sir.
This was due to the cholesteatoma.
Yes,
And you treated with patient with the bone bridge.
yes, sir. Correct, sir.
Okay, so just I have a query. You have a single case report,
Yes,
right?
sir. Yes,
So what was the outcome? Means what was the subjective and objective analysis of the patient in that year when you compare on the opposite normal side?
Sir, in this case, sir, the normal side has a good bone conduction, but there was an inactive perforation. So there was a conductive loss on the left side. Right side, when we implanted the bone bridge, the patient has a 8 weeks post-op, like when we put a SAMA processor and we assess the patient on a HISQI score of that has a good score of 120 out of 130, sir. And we also subjective assessment was done with the SSQ score. So the patient had a good speech and a spatial and a quality of sound. The only problem, the low score was on the spatial, because patient was not able to make out the sound, where the sound was coming from which side and all. That was the problem with the patient. Apart from that, the quality and the speech was good, sir. And the disability was more because of the left side mild conductive loss. So the outcome of the patient was much more, sir, actually.
Sorry, dear, I was again with Dr. Gaurav. Okay, that's fine. So what was the problem you met while performing this surgery?
Sir, it was a pre-operated case, sir. So the surgery, we had done a subtotal petrosectomy. So the finding a good thickness of the bone was a problem we met. But we managed to find, do in a retrosigmoid area. We did a AutoPlan software to find the thickness of the bone. And then we did the surgery on intraoperatively. We saw the area and then we did a good bone bridge implantation, sir.
Okay, so you did a complete total petrosectomy, but there is still there are chances of recurrence of the disease in that year, right?
Yes, sir. But we managed to do a complete removal and did a blind sac closure, sir. And the patient is doing well till now, sir. So we'll follow the patient in the future also, and we'll document that, sir.
So how often you will ask for the follow-up with the patient?
The patient is currently residing in Nepal. So every 6 months, we'll just ask them to come for a follow-up for a 1 year, sir.
Okay, right. But there is a issue. You must have put some fat material and everything to get it close, right? And there is a metal. So with which modality you will assess the patient for the recurrence of the disease?
Sir, we do a imaging, sir. The fat suppression MRI we can do, sir, just to find out the disease recurrence and all.
Okay. Okay, fine. Good. Thank you, dear.
Thank you, sir. Have a great day, sir. Thank you.
Okay.
I would like to thank CIGICON, and a special thanks to my Professor Dr. Amit Kishore and Nimita Narayan for supporting me and giving me an opportunity to present this case. Thank you, sir.
Okay. Thank you.
Thank you, sir.
Hello.
Yeah, Dr. Good morning,
Yeah.
Dr. Gaurav.
Hello. Hi, Gaurav. Yeah, we have finished.
Yeah,
finally you are with us.
yeah.
Okay. Okay. We have gone through the case presentation of Ashwini Kumar.
Okay.
Okay, we have done through. So we are going for the second candidate.
So is that was on the bone bridge, no?
Yeah, that was for the bone bridge. Yeah.
Good morning, Gaurav, sir.
You have questions?
Yeah, I think I should ask a couple of questions.
Yeah.
Good morning, Ashwini, Dr. Ashwini.
Good morning, sir.
I just want to ask, what is the basic concept of bone bridge?
So bone bridge works through a bone conduction technique. So it collects the sound and transmit the sound to the better cochlea. So in a single-sided deafness, when you have a complete in this patient, there was a cochlea was fully eroded. So there was no it was a cochlear implant was out of the question. So we thought of doing a bone bridge in this patient.
Okay. And what was the cost?
So cost was somewhat around 5 to 6 lakhs.
Okay. Okay. And what do you think? The bone bridge is not very popular in India right now. What can be the cause behind it?
So first is the cost is the main issue, sir, and
Okay.
second is awareness among the patients. Like we have not
Okay.
done.
Okay. Thank you. Thank you. Thank you, Dr. Kalpesh.
Thank you.
Thank
Okay.
I think, sir, we can move on to second.
Second, yeah.
Dr. Sandhya D. Can you unmute yourself on your video? Yeah.
Good morning, sir.
Hi, good morning.
Yeah. So can you show your slide?
Just a minute, sir.
Hi.
I'll screen share my.
Yeah. Sandhya, you are talking about the challenges you met during your implantation for the Jervell and Nielsen syndrome.
Yes.
Yeah. Can you tell us what was the issue with the cochlea?
So the cochlea was we had ours is a newly recognized center, sir. So we have a very limited experience with cochlear implantation as such. But very early in our experience itself, we came across two patients while we were evaluating for candidacy for cochlear implantation, a routine ECG was done in them, and we saw that the QT interval was prolonged in them. But a CT and MRI was done in both the patients as is required for the preoperative evaluation, but the cochlea was perfectly normal, except for the fact that the children had a prolonged QT interval in both the cases. There was no other issue as such. And the first case which we there was no particular history that was pertaining to any syncopal attacks or any family history as such. But in the second child, upon probing more with the parents, they told that the patient did have an episode of syncopal attack sometime about at the age of 6 months or so. And then, but we also did the evaluation of the parents, and none of the parents had any such history as such. Their ECGs were also perfectly normal. So, based on the clinical evaluation, we made a diagnosis of Jervell and Lange-Nielsen syndrome in these patients, although a genetic evaluation was not performed because of financial constraints in them. And the second child also had microcytic hypochromic anemia, which has also been explained as part of the JLN syndrome itself. So in both these children, we had to send them to a pediatric cardiologist, and we had to put them on beta blockers. The second child, however, the QT interval didn't seem to come down. It in fact increased further from an initial of 583. It went on to 620 odd, and then we had to wait for a longer period of time before we could bring it down and then actually take up the child for the surgery.
Okay. Can you let me know what was the challenges for the anesthetist team? Okay,
Yes,
for the surgeons it was fine, but for the anesthesia, what were the precautions they made?
Yes, sir. So basically, in case of Jervell and Lange-Nielsen syndrome, the dreaded complication or what we expect is fatal arrhythmias that can occur on slightest stimulation, sympathetic stimulation that can occur. So it was very essential for us to make sure that the induction and the maintenance of anesthesia was smooth. The child was pain-free throughout, and they had to avoid certain induction agents like sevoflurane. The drug that was used was propofol. So an induction and maintenance was made with propofol in these in both these children.
Dr. Sandhya,
Uh,
just I think we have lack of time. So just last question, just tell me, did you observe lower cap and surge score in comparison to the normal implanted childs?
So in the second child, because the first child we didn't have any major problems, the habilitation went on well, and we didn't notice any lower cap and surge scores. Whereas in the second child, the child developed further syncopal attacks after we implanted the child. So in that case, we were not very sure about how to go about it. We had to discontinue for some time. We had to reduce we had to make some alterations in the current levels that were given, and hence there was a slight delay in that child, and so probably the cap and surge scores were low in the second child. But after that, the child is picking up now and is still doing fine. So both the children are with us for follow-up still.
Okay, thank you.
Okay, fine, thank you.
Thank you.
I think we can go to the next participant, then Dr. Anshu Singh. Dr. Anshu, can you hear us?
Hello, good morning, sir.
Yeah,
Hi,
good
good morning.
So I'm going to start sharing.
Yeah.
Meanwhile, can you just describe your technique in brief? I think you are going to speak on this management of cochlear implant with bacterial biofilm infection.
Yes, sir.
Just a very brief about your technique.
Basically, the first thing we have to do is we counsel the patient for any infection post-operatively, because in the study of 5 patients, we noticed that the patient who came to us as early as soon as possible after infection, and we manage it properly. So the first thing we did.
Just the technical part, everyone.
So if the patient is not responding to antibiotics, we didn't wait till other antibiotics and everything. We took the patient for surgical debridement. We opened the wound. We did the vigorous hydrogen peroxide, and we used polyhexane and betaine instead of costly antiseptics and other things. And we removed the magnet, and we treated the magnet separately. And by that time, they were soaked for half an hour during the surgery in polyhexane and betaine solution. By the time, we also took out the tissue seal in the cochleostomy site, and we also changed the cochleostomy tissue seal. We again made a bed and tunnel for the implant.
So you
and
could
then
salvage, sorry to interrupt, you could salvage 4 out of 5. You have written.
Yes, sir.
So
Yes,
your
sir.
results seem substantially greater than the previous studies. So what can be the cause of your so good results?
So actually, we cannot say one patient, because the patient showed up after 1 month of infection and he was treating somewhere else. If the patient showed up within 1 to 2 weeks of infection, starting of infection, and we did a surgical debridement earlier, we can salvage the implant. That is the main thing in it.
Kalpesh, you want to ask something?
Yeah, Anshu, during the surgery, how was the necrotic tissue you come across?
So the necrotic tissues, so actually there were pale tissues. There were in few cases it was pus. In few cases it was just a collection with pale tissue covering the implant, which was removed.
Okay.
And when we give to histopathology, it comes out chronic inflammation. Nothing else come in this histopathology.
Okay. Last questions. The 4 implant you have salvaged. So do you think if you have started antibiotics for a prolonged period, then you do not have to do any kind of surgery in that 4 patient?
Sir, it could be, and it could also, when the infection could also have spread, because we were suspecting biofilms here. So
Okay.
biofilms had a very large concentration, needs a very large concentration, which doesn't go by just by giving antibiotics.
Okay, fine. Thank you. Can we move for the next speaker?
Yeah. Dr. Fazli Latif. Dr. Fazli, can you hear us?
Yes, sir.
Yeah.
1 second, sir.
Yeah.
Show my share screen.
Yeah.
Stop sharing. I'm not able to share the screen, sir.
Anshu Singh has to stop sharing screen. Yes, should be. Morning, Gaurav and Kalpesh.
Good morning,
Thank you
sir.
for being there right up in the morning and starting for us. Very kind of you.
Thank you very much, sir. Okay. We can see the video now. Dr. Kalpesh, sir.
Share, no?
Yeah.
Share. Slide share.
So, Dr. Fendi, you have revisited the endoscopic anatomy of Prusak space.
Yes, sir.
You have revisited the endoscopic anatomy of Prusak space. Yeah.
Yes, sir.
So, what are the clinical implications of your study?
Sir, mainly we are looking for because mainly the epitympanic space, Prusak space is the most common space for the site of cholesteatoma, sir. So, like for a clinician, like for a surgeon, it is very much important to know the entire the surgical landmarks and the three-dimensional orientation. So, like to go for the better surgical improvement, sir.
Okay. So do you think the endoscope is better managed than the microscope?
No, sir, it's not like that, sir. We are using microscope only, sir. But microscopically, what is the problem is we will not be able to identify the three-dimensional orientation. And with the intact tympanic membrane, we will not be able to visualize the entire boundaries like proper with intact tympanic membrane. And for with the this is just for the orientation of the surgeon, sir. So in this endoscopically, if you do, sir, with the intact tympanic membrane, we will be able to visualize the entire boundaries of the Prusak space. Also, sir, we can see the more zoomed portion without losing illumination also, sir. So it is basically for getting the idea exact orientation, three-dimension of the Prusak space. Even actually we can go for other etic space also, but we are concentrating right now only in the Prusak space to get a proper orientation, sir, and to see whether any anatomical variation is there or not.
So,
When you're approaching the surgery, sir, it is always better to do in a microscope because both the hands will be free, sir.
Yeah.
Okay.
That we understand. But when will you recommend it during the surgery that endoscopy is needed for this particular step? That will help for the smooth outcome of the surgery.
Sir, in case if it is a difficult area, if you are approaching and the surgeon is not able to approach properly, then like for a guidance, we can have a use of endoscope, sir.
Okay. Fine. Gaurav, do you have any question?
Yeah, just so what new things you have observed about the Prusak space anatomy in comparison to the existing knowledge of Prusak space? Did you experience any anatomical variation or
No
so?
anatomical variation was observed, sir.
Okay. Okay.
Thank you.
So I think we can move on to the next part. So yeah, that's Dr.
Sai Benser.
Yeah.
Top sheet.
Dr. Sai, can you please share your screen? Can you hear us, Dr. Sai?
Is Dr. Sai now? Afternoon.
Is not
Dr.
there?
Sai, but sorry. No, I don't think so. I think the rest of the e-posters and surgery would be lunchtime.
At 1:30. Yeah.
At lunchtime, yeah. So we'll bring you back at that time. And yes, thank you so much, both of you, Gaurav Gupta and Kalpesh Patel, for waking up so early in the morning. Third day, this is a Sunday, and
It's a pleasure, sir.
we have started off really well. First of the e-poster sections, and we're running 3 parallel sessions live in surgery, audiology, and rehabilitation. And in about 3 minutes, we will start oral papers presentations. And incidentally, I need to let you know about 30 of these were ratified. You know, the presenters in both e-posters and oral presentations were ratified as CG members last night in the general body meeting. And so congratulations to
Yeah.
CG members. And thank you so much. So
Thank
we'll
you, sir.
go now, Gaurav and Kalpesh.
Welcome,
Yes,
sir.
I'll be back a little later.
Yeah, thank you, sir. Thank you very much.
Okay, sir. See you later. Bye.
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 Bye. Dr. Arindam Das.
Yes, sir.
Good morning. Mute yourself for now.
Yes, sir.
Just mute yourself for now. Sangeeta, good morning. Good morning. A very good morning. A good Sunday morning. Thank you so much. Just waiting for Dr. Rambabu. There he is. Okay. Wonderful. How many speakers? Yeah. So we've had the first section. Morning, Rambabu Garu.
Hi, good morning.
Yeah. So we have the first section of the oral papers in surgery already presented on Friday. So this is the second section. And incidentally, all these presenters today have been ratified as CG members yesterday in the general body meeting. And hearty congratulations to all of them. And welcome to the Cochlear Implant Group of India. So I think we are just 3 or 4 minutes ahead, but the fact that we have most of the presenters here, I think it's good to get started because there's a little more question and answer time. So it's in the order of the list there, Sangeeta and Rambabu. Go ahead and start your moderation.
Dr. Arindam Das.
Yes, madam. Good morning.
You can start.
Yes. Hello, madam. Can you see the screen?
Yeah,
Yes,
we
sir.
can see.
Yes. So now can I start, sir?
Yeah, sure. Go ahead.
Yes. Good morning, everybody. It's my pleasure to present this article in front of this august audience and the panel of judges. My topic of discussion is cochlear implantation radiological assessment score, the SkyDAS, a novel scoring system to predict the difficult round window insertion. The cochlear implantation is the one of the best inventions in recent times of medical history, and that can be minimal benefit from the conventional amplification. There are various techniques for cochlear implantation, but we have used the study in the posterior tympanotomy with the round window insertion for the uniformity of the statistical parameters. Now, the aims of the study are fourfold: to investigate the internal validity of the proposed scoring system and to determine the cutoff score. We have to establish also the between the scoring system and the interoperability difficulties, provide a basic structural checklist to the surgeons and the radiologists for preoperative analysis and record. Now, the materials and method. This is a double-blinded prospective analytical study done between 2017 January to 2021 January with 52 patients in a panel tertiary care government hospital. So we have included the prelingual deaf child whose age being less than 5 years, who have fulfilled all the audiological and the psychological criteria, having normal inner ear anatomy, and all the surgeries done through the facial recess approaches. Those surgeries have been done through the revision cases, and the alternate techniques like varia or endoscopic or subtotal petrosectomy we have excluded from our study. Now, the surgery has been divided into the 4 key surgical steps: the cortical mastoidectomy, the posterior tympanotomy, the round window niche identification, and round window insertion for our statistical calculation further. Now, all surgeries performed by the same surgical team to remove the observer bias. We have formed 3 groups for the data analysis. The group A for image analysis done by a ENT surgeon and radiologist. Group B, the interoperative finding analysis done by ENT surgeon, mentor, and the senior ENT surgeon. The group C for the statistical analysis, and the group B or C, they don't know the previous result of the other groups. Now, we have done HSCT temporal bone with a fixed criteria for all the patients having 0.6 millimeter slice thickness and a 512 by 512 image matrix, and all the scans have been seen in the standard bone window setting, having window width 4000 and window level 700 in the Horus software using the macOS or iPadOS. Now come to the proper scoring system. We have used 6 parameter of the HSCT according to the existing literature and our experience and knowledge to get this scoring system. Each parameters have 2 options. If the favorable anatomy, then we have scored 1. If there is not favorable, then this is scored 2. Now, here we can have a maximum score of 12 and minimum score of 6. Come to the every point, the mastoid pneumatization. This is the score 1 when this is pneumatized. If this is sclerotic, then this is score 2. Then marrow cell. If the marrow cell is present, then there is a chances of bleeding. So that may be produce some difficult situation. So I have scored 2. Next, the sigmoid sinus position is judged by the lateral extension of the posterior semicircular canal line. If this is antipose, then this is score 2, and is normal situation, this is score 1. Then the facial recess sentinel cell we have used to identify the facial recess cell. If it is present, it can lead the surgeon easily inside the middle ear without any problem. So this is the score 1. If this is not present, this is score 2. Now, the round window niche visibility has been identified using 2 lines: the EAC line according to inclination of the exploratory canal, and the second line drawn from the posterior part of the round window niche to anterior part of the facial nerve. If these lines are parallel, this is a good visibility, so this is 1. And if they transect, then this is the visibility may be poor, so this is grade 2. And round window membrane accessibility, it is done by the two lines, one from the carotid and second from the basal turn of cochlea. Same thing, if this is parallel, this is the cochlea is in normal position, so this is score 1. If this is transecting each other, then it is score 2, and this is the cochlea is rotated. Now some intraoperative pictures, you can see this marrow cell is present, there is chances of bleeding, there is a sentinel cell present here, and now the posterior tympanotomy has been done, and the good round window visibility, we can find the round window membrane actually, and then the electrode has been inserted through the soft insertion technique, and the surgery has been done. And this is the normal cases. In the good visibility is seen when the score is less, and if the score is more, then the visibility is very difficult inside the middle ear. Now, results were analyzed in the 3 parameters, the easy to difficult surgery according to the opinion, next to the time taken for the surgery and the extra instrumentation. We have used the ROC analysis with the Uden index and the AUC to determine the validity of the score, and Pearson's coefficient and the Spearman coefficient for the non-parametric variable for the correlation between the surgical parameter. So this is the ROC analysis. The ROC analysis has the marvelous statistical demonstration, and it can see a test whether it is useful or not. So this is a ROC plot is the trade-off between the sensitivity and the 1 minus specificity, and there is a chance line. If we have above the chance line and have a greater AUC, that means the score is validated. Now for our study, we have a Uden index 0.45 associated with score more than 8, and the specificity was 93.1%. This is the high specificity of the scores. And if we see the AUC, this is 0.8.28, that means it is a very accurate test to perform. We have done the Pearson's coefficient test and the Spearman coefficient test, and both are statistically significant. So there is a correlation between the time taken for the surgery and the total score and the extra instrumentation. Here we have graphically plotted these things. When the Kairos is more than 8, there is a drastic increase in the time taken for the surgery. Now, before conclusion, we have to say some discussion. First is the cochlear implantation via posterior tympanotomy is one of the most accepted approach worldwide and most commonly done by the surgeons. And this is the era for soft technique insertion. So soft insertion is very useful to preserve the residual hearing of the child. And this is one of the most important part to be taken care by the surgeon. And the numerous studies previously done, they have tried different radiological parameters to get this score and predict the interpretive situation, but they are mostly radiological dependent. They have the various difficult calculations to make out this score, but we have used very simple parameters that can predict the intraoperative difficulty as well as the situation and correlated with the sound statistical analysis. Now the optimal visualization of the optical axis, this is very important, and this is the basis for this scoring system. When we the surgeon see from outside inside the middle ear, we have to go to the straight visual axis. If this is obstructed by any structure in between or any anatomical problem, then we can find a difficult situation. Now, every study have some limitations. Thus, we have this small sample size of 52 is definitely a negative point, and the score applicable only the posterior tympanotomy. So, next publications should be take this consideration, this account. Now, the Kairos or cochlear implant radiological score is definitely easy to perform, and as well as its accuracy and internal validity had been proved by a sound ROC or receiver operated analysis, and at the same time it can so rightly predict the Kairos score is more than 8, then the surgery is going to difficult and the surgical team may be prepared beforehand. So we propose that Kairos can be accepted as a universal screening system for the radiologist and as well as for the surgeon for every cochlear implantation surgery to make it safe and make it better for the patient. Thank you. This is my all the presentation, and now we can go for question answer, if you permit me. Thank you, sir.
Judge's note, he stuck to time. He was well within his 8 minutes. Dr. Rambabu.
Yeah, very good presentation, Arindam. Congratulations.
Thank you, sir.
Very good. You have done a great work. And what was your average score in your small sample of study?
Sir, our average score was between 5 to 7. It's 6 to 8 mainly. The most of the patient, more than 60%. And when it is above 8, this is 20 to 30%. And very rare cases we have found more than 10 or 10 to 12 score.
And what was the average time that you were telling that it could be reduced?
Sir,
in the
our average time was 110 to 12 minutes. So it is around 105 minutes, and for it has a range for 92 to 34 minutes. But this time is taken only from the bone drilling whenever we started and up to the insertion has been done. So all the soft tissue part has been removed from this calculation.
All were complete insertions?
Yes, sir. All cases were complete insertion. Actually, we have taken 55 patients, and there was one cases that was a difficult insertion, and the halfway we have to leave, and 2 cases we have to do a cochleostomy, and these 3 cases have been excluded from our study. So the actual sample size become 52.
What was the reason? I couldn't get for the difficult.
Sir, I think that was a very narrow round window niche area, and it was not visible actually the round window membrane in spite of every thing we have done, like the anterior transposition of the canal wall, skeletonization of the facial nerve. But in spite of this, is a very narrow space, and we have to go further anterior for the cochleostomy.
Is there a discrepancy between your intra pictures and your radiological analysis? Like now you just said that you had a very round window niche. Did you know that was it similar on your intra and radiology?
Yes, ma'am. We have this part. We know the score was high, but actually, according to this is a double-blinded study. So the surgeon doesn't know, or surgical team doesn't know how the parameter was, what is the preoperative score, and afterwards we have seen the video to the surgeons and get this whether the surgery was easy or not. So in spite of being the high score, when we tried to do the surgery through the posterior tympanotomy and the round window insertion, the situation was very tricky. And according to our mentor, we have to go for the cochleostomy approach.
Has it ever happened that your score was high and the surgery was simple?
Yes, madam. In one cases, this was a situation. Because there is this surgery, this code has a more than 90% specificity, so there is a 10% chance that we may be false. But this is one or two situation I can think that we think this was a very difficult surgery, but it doesn't happen. It was a smooth and easy insertion as it is.
Okay, thank you. Very good presentation.
Thank you, ma'am.
Okay, I think we can go ahead with the next presentation.
Okay, sir. Then I can off the screen share.
Yes.
Thanks, Dr. Arindam.
Thank you. Thank you all.
Yes. Next is Dr. Baisakhi Bakat, who will speak on intraoperative challenges in cochlear implantation. Dr. Baisakhi, share your screen and start.
Yes, sir. So am I audible?
Yes.
Okay. So my screen is visible?
Yes, on slideshow.
Okay.
Yes, go ahead.
Okay. Thank you. Good morning, everyone. Today I'm going to speak on intraoperative challenges in cochlear implantation. Cochlear implantation is the most recommended auditory rehabilitation nowadays for children and young adults with profound sensory neural hearing loss. Expanding CI programs have led more and more surgeons to pick up this surgery as passion. But besides passion, this surgery also needs skill and determination to traverse the challenges in the steep learning curve of this surgery. Now, there were very few studies, or rather no studies describing these challenges. So we picked up this study to throw some light on these and also to devise plans to avoid and tackle these challenges. Now, this was a retrospective case note study where 200 years were included without any cochlear malformations. Now, this is a table showing the challenges that we have faced in our series at a glance. This is the anatomical challenge, this is the surgical challenge. Now, starting from raising the flap may be thick and thin, which has its own pros and cons. Dealing with a huge emissary vein at the beginning of the surgery can seriously lead to slowing the pace of the surgery also and the pace of the surgeon also. A forwardly lying sinus always obstruct our path and our view to posterior tympanotomy and round window. Along with that, the thickness of the cortical bone should always be kept in mind while we are assessing the radiology when we are planning the implant bed. A great amount of experience is needed to decide the exact thickness of the bridge while making a tie-down hole. A partially fibrous cochlear duct is also an anatomical challenge which can only be excluded in a good quality MRI. Along with thick and thin flap, short flap is also a challenge, a surgical challenge that we have faced in our series. Coming to results, the most common surgical challenge that we have faced was difficult insertion of 15 cases, out of which 12 cases were due to an overhanging round window niche. The second most common challenge was unsatisfactory anatomy. In 8 cases, we had perilymphatic gusher, and in 1 case, we found an acute corofacial angle. Now, as I said, the most common challenge was difficult insertion, and it is most commonly due to difficult anatomy of the round window. So this is the view which we get after completion of our posterior tympanotomy, where we can see the round window is peeping a little. And this is the view which we want just before the insertion. So the journey from this view to this view needs good radiology assessment, good mentorship, and lots of cadaver dissection. Now, how to deal with it? Apart from radiology and cadaver dissection, efficient use of contra-angle drill and skeeter drill is needed. Controlled fracture of posterior canal wall, as seen in this video, is also needed, where you can see the posterior canal wall is made paper thin, and then how it is being manipulated to increase the view also and to increase the space also to work. Now, in one case, we had sudden entry of broken tip of the pick into the cochlea. The lesson learned from that episode was no jerky movements after round window has been opened and careful use of micro instruments. Now, by manual handling of pre-curved electrodes, it dictates strict maintenance of hemostasis just before you are inserting the electrode. Otherwise, a slight trickle of blood into the cochlea and there will be a mess. There will be an incoordination, there will be premature coiling of the electrode array outside the cochlea only. Life has sometimes many surprises. So there may be difficult insertion without any obvious cause. So at that time, what we have to follow is the basic principle of proper handling of electrode. So the electrode has to be held in the specified location with the specified instruments. Only manufacturer recommended instruments need to be used, and the principle of slow insertion is to be kept in mind. What is it, the principle? So when the electrode is being introduced, it should be introduced only by soft insertion. As you have introduced, you have to wait, let the perilymph ooze out and to avoid any perilymph splash or gusher. Again, introduce further, take your time, relax, introduce further and take it to the last string slowly. Unsatisfactory NRT was the second most common challenge that we have faced. It may be due to a higher impedance, which is usually due to blood entry, due to air entry, maybe due to partial insertion, or sometimes due to manhandling of the electrode. Sometimes the electrode may stay in the open circuit also. So the trick is to achieve strict hemostasis before insertion. Remove any cell line, any blood, any bone chips around the insertion site before you are starting the insertion. Use dexamethasone or RS solution or Hyalase solution to irrigate. And equally important is securing the ball electrode below the temporalis muscle. Now, in some syndromal babies, we do expect perilymphatic gusher. It has to be excluded radiologically also. But if it happens intra-op, you don't have to panic. You just, after introduction of the electrode, you have to seal the site with periosteum and muscle to stabilize the electrode area. Avoid any ear with jugular malformation. Next, facial nerve sheath exposure is a very common condition. It's not a crime. It may happen, but what you have to know is how to deal with it once it happens. So immediately you have to change your bud to a tapering shoulderless bud so that it doesn't touches the facial nerve while you're working around the round window. And do not use any raw adrenaline over facial nerve. In one case, we had acute caudofacial angle. So what happens in this situation, the anatomy is very restricted to introduce your bulb to drill. So you can step up to some advanced procedures like extended posterior tympanotomy, extended round window approach, or you may sacrifice the cauda tympani nerve if it suffices the situation. So cadaver dissection is a necessary step which should be done before surgery as it increases the confidence of the surgeon while traversing the steps of learning curve. Nowadays, manufacturer companies are providing simulation models which can be done, used before surgery. And apart from these two, some organized module-based mentorship is also being conducted in our institute for all these years, where each surgeon is expected to perform a fixed number of surgery in each module and then progressing up to the next module, and thus reaching the final module and giving a successful outcome. Thank you. Hello.
Good presentation, Dr. Baisakhi Bhagat.
Yeah, thank you, sir.
Yeah, good. You have covered almost all the things. I mean, is it a prospective study you have done, this one?
So this was a retrospective study.
Okay, okay. So how many that you have any this thing like in difficult introduction of the insertion, how many extended round window or cochleostomy that you have to do intraoperative decision?
So only in my this thing till I am here in this study, only in one case I saw extended round window approach they had to do.
Okay. Okay, thank you.
Saki, nice presentation. Did you do any other, suppose you had a very difficult to do a posterior tympanotomy. You had any cases where you had a forward lying sinus or low lying dura and you are not able to do a posterior tympanotomy. So what other approaches you can use?
Ma'am, actually in our institute we do only by this technique. But sometimes I have seen.
If you had, I know posterior tympanotomy approach, but suppose you had a very contracted mastoid, very forward lying sinus. So what would you like to do like in such cases?
Well, maybe some other approaches which have been described like Varia technique or transcanal procedures or endoscopic procedure which needs less exposure and less this thing to do.
Have you ever heard about like remove the posterior canal wall and again keep it?
Ma'am, we have done here in this in our this thing. We have fractured. Yeah, we have. Yes, ma'am. Yes, ma'am. I have shown this video where we have fractured and then again kept it before closing in and then packing the ear canal very nice tightly so that it stays in place. That we have done.
Probably you can think of doing a anterior approach like elevating the canal wall. Assisting through the posterior tympanotomy. Maybe that way any contracted or anteriorly placed sigmoid sinus
can be done.
Yeah. Thank you, Dr. Baisakhi.
Thank you, sir. Thank you, ma'am.
Thank you, Dr. Baisakhi. And,
yes, sir.
can I call upon our next speaker, Dr. Ganga J. Kamath to start sharing her screen.
Sure, sir. Give me a moment. Yeah, so good morning, one and all. So, yes, so my topic is surgery for simultaneous ipsilateral hearing restoration in lateral skull-based surgeries, the way forward.
Can you make slideshow? Thank you.
Yeah, so are you not able to see my screen?
Screen is visible. Can you make slideshow? It's in the present.
Yes, sir. It's on slideshow itself.
No, it's not visible for us.
Okay, I'll do a new share. Is it visible now, sir?
Yes, please go.
Yes, so bilateral profound hearing loss and single-sided deafness can result from various skull-based pathologies and also from lateral skull-based surgeries. So various implantable hearing solutions are provided, that's BAHA, cochlear implants, ossia, and auditory brainstem implants as well. So audiological outcomes and surgical implications for implantable hearing restoration needs to be considered. So coming to my study, it's a study with 30 subjects, and it's a retrospective study where the candidates with various skull-based pathologies requiring hearing rehabilitation post-lateral skull-based surgery were included. And the results were 30 of them, among the 30 patients, 21 were male and 9 were female, with age group of 22 to 74 years. And in that, we had 3 cochlear implantation, 3 ossia, and 24 osseo-integrated hearing implants. So coming to the indications for surgery, most of our cases were skull-based osteomyelitis, and we had extensive Petersbone cholesteatoma, 2 vestibular schwannoma cases, 5 tympanojugular paragangliomas, 3 temporal bone malignancies, 2 epidermoid CPA epidermoid cysts, 1 facial nerve schwannoma, and 1 capillary hemangioma of temporal bone, and 1 Meniere's disease. So the surgeries performed were the most common surgery performed was subtotal petrosectomy, then followed by infratemporal fossa approach type A and translabyrinthine approach, and subtotal temporal bone resections, transcochlear, transotic, and the translabyrinthine approach. So out of the 3 CI, 2 were single staged and 1 was planned as ipsilateral simultaneous CI as a second stage operation. So I'll be discussing about it in detail in later presentation. So out of the 24 osseo-integrated implants, 2 were single-stage BAHA and 1 was second stage. All remaining had ipsilateral simultaneous BI300 implant. So 3 osseas were single-staged. In that, the other one was planned for second stage. Coming to the surgical procedure, the initial steps were planning and marking the position of the components of skin, and the postoral skin flaps were developed in subcutaneous and musculoperiosteal plane with the surgical clearance of the disease. And then ipsilateral simultaneous hearing restoration was planned accordingly. Then the post-surgery abdominal fat was harvested and placed in the cavity, and wound closure was done in layers. So how do we do it? So coming to the cochlear implantation, the first case I would like to discuss is a case of bilateral skull-based osteomyelitis. So this case we decided as a simultaneous ipsilateral CI for the first, that's the left ear itself, but we had to abandon because there was extensive granulations over the dura. So we decided to give 1 month of IV antibiotics and go ahead with the right side. And the right side, the challenge was the right ear had post-oral fistula. So we were not sure whether the CI would be placed in the right side itself, or we're going to do a second stage left ear. But since IV antibiotics we had given based on the culture sensitivity report, as you can see here, the skin was perfectly fine. The post-oral wound had healed well. So we decided to go ahead with the right-sided ipsilateral simultaneous CI. So the marking was done, as you can see here. So this is the marking incision for the subtotal petrosectomy, and the behind the ear template is placed, and the implant template is marked, and methylene blue dye is placed for the bed to be drilled later. So proceeding with the surgery, as we proceeded, we made sure that there was complete disease clearance. As you can see here, there's absolute disease clearance, and we decided to go ahead with the CI on same side. So this is a subtotal petrosectomy done, and the template marking for the exit array is kept, and we made sure that there's a adequate subperiosteal pocket created, and the bony recess is marked and drilled well. So we make sure that a good bony depth is made for the well, and a good subperiosteal, tight subperiosteal pocket is created. We don't suture the implant. So once that's done, and we confirmed it and went ahead with the implant, where the ground electrode is placed under the temporalis muscle and secured with the gel foam. And coming to the, since it's a wide cavity and the round window membrane is evidently visible, so we went ahead with the round window membrane insertion. In this case, extended round window approach was planned, and the electrodes were inserted, and then periosteum harvested was sealed to it. And this is the final output where the extra electrodes were secured with the bone wax. And also we had confirmed it with the neural response telemetry and impedance audiometry in TROP. And the cavity is filled with the abdominal fat, as you can see here. And finally, check X-ray with modified Stenver's view was done and confirmed the electrode placement. And the second case was again a skull-based osteomyelitis due to hearing mold insertion. It's a foreign body SBO, where we went ahead with subtotal petrosectomy and simultaneous CI. So you can see that the foreign body is there lying along the petrous carotid. So finally, total disease clearance was achieved. And since the round window membrane was evidently seen, a concentric slit was done, and we went ahead with the electrode insertion. So the patient is doing fine now. And this is the stage CI in bilateral SBO. Also, I would like to mention that this was a case of BAHA candidate initially. So the patient didn't follow up for a year, and then after a year, he wanted hearing rehabilitation. And when we repeated the audiological investigation, we found that he was a candidate for CI. So we planned for a CI. This patient already had a BI300 implant on the other side. So we went ahead with the CI, abandoning the BAHA. So this is the incision what we planned. And as you can see here, once the musculoperiosteal flap is raised, the abdominal fat, fat is seen. And once the round window membrane is open as usual, and the bony area is marked here. And
Dr. Ganga, you have a minute to wrap up. That was the bell.
So coming to ossia, this is a case of a Peter's bone cholesteatoma transcochlear approach. So as you can see here, the marking, it's ossia marking is done. And this was a first Asia-Pacific ossia on a skull-based surgery. So the transaortic approach was done, and the bony bed was done. So most important here is bone bed indicator, where it should rotate freely 360 degree. And once that is done, the actuator is placed, and the challenge here was to retain retract the muscular periosteal flap because already it's a wide operated cavity. It was very challenging to pull the muscle behind to create space for the procedure. So the next surgery, it was a translap surgery. We decided to go with the second. So finish the surgery, close the operated cavity and go behind and proceed with the surgery. So that's what we have done here. We have done the opened up and placed the place the implant and then bone bed indicator and the implant is placed. So both the patients are doing perfectly fine. And this is a case of bilateral lesbio staged ossia where we were not sure whether Baha 5 superpower would go or ossia implant would go. So the challenge was the marking as to for ossia it is at the level of ear canal and for Baha it is 45 degree. So we decided to go midpoint of both and finally ossia was planned for the patient. So this is the staged procedure for a Peters bone cholesteatoma patient. 6 months later, we planned Baha and skin depth markings are done. And the conical guide drill is drilled and then widening drill is done after seeing the dura, if the dura is exposed or no. Then once the widening drill is done, this patient went for a single immediate abutment and then for the processor. So the abutment is placed. And following which, this is a case of capillary hemangioma where we did subtotal peterectomy with simultaneous ipsilateral.
Dr. Ganga, your time is up.
So this is how we did in a subtotal peterectomy Baha. So the conclusion is the lateral skull base pathology is an extensive surgical approach which mandates hearing rehabilitation. It has to be considered and not to be neglected. Thank you.
That was a real fast wrap-up.
Yes, sir. I had lots to tell. I couldn't, and the time was short.
Anyway, done a good job. Anyway, I mean, a good study. I mean, a lot of inputs for a lateral skull base surgery, the options that are available, you have discussed very well. Good job. Only thing is that how did you ensure that the skull base osteomyelitis is a very troublesome condition? And how do you ensure that there is no residual infection into some pockets somewhere around the skull base? Because we do have a lot of recurrences in spite of doing extensive surgery.
So again,
we are putting in a simultaneous implant with a lot of risk in it.
Yes, sir.
Yeah.
So we go ahead with the surgery only if we are sure that there is total disease clearance. Total as in we can't assure that, macroscopically whatever possible disease clearance we can do, we are sure. And then we have a protocol. So we have a series which we'll be publishing in a while. So this hearing rehabilitation we've started after we have treated about 80 cases of skull base osteomyelitis with the mortality rate very less, so around 93% success rate we have. So also with the remaining 7 cases, the death per se happened because of other, like due to MI or any stroke or any other complication, not per se because of the disease. So seeing our series, so we know that our result success rate is high. So based on that we do, and we have also followed up with these patients. So they with repeated CT or MRI based on that. And we also have a protocol. So in our institute where we give 1 month of IV injection and 3 months of oral antibiotics. So it's extensive medical management post-surgery also. So based on that results, we are sure that disease clearance is good. So then we decided when we are very sure that the patient disease clearance is good, why not consider hearing rehabilitation? Why not give them an option of, because their quality of life also improves post-surgery, and why not do it in the same sitting? Because again, one more surgery would also result. One is again cost effective it will be, and also extra the surgical complications will be more. So I had lots to discuss also in that second stage, what and all we had gone through. At the shortage of time, I couldn't convey everything. So based on these results, we have decided, and we are promoting and we're telling the world that yes, if you're sure, again the caveat is, if you're sure of the disease clearance, only then we can go for simultaneous. Like in my one case, I told you we had planned for CI on left side. And then we saw that the disease was very extensive and adherent to dura as well. So in those cases, though we had planned, we didn't go ahead with that because we were not sure of disease clearance. So we staged it. So this is how we do it.
Thank you. Thank you.
Ganga, nice presentation, but you were not able to give your conclusions properly. But I still feel that in skull-based osteomyelitis, I think you have to be very careful about putting an implant in an infected ear. I don't think you. What was your follow-up for all these patients? Maybe it's a short duration. Like, did you?
No, ma'am. It's see, like I showed you in my third CI, that patient was followed up 1 year later. So the third CI, and when you can see that operated cavity, when we opened, there's no evidence of disease at all. So it's a 1 year follow patient. So we have done this only after extensive clearance or like extensive series of case studies.
Telling you, it's little. I don't agree with the simultaneous. Okay, that you said after 1 year when you repeated the scans and there was a disease-free area, then putting an implant is okay. But the same time, I'm not sure. Even if you are, how can in an skull-based osteomyelitis, how can you know that you are disease-free?
Ma'am, as I said, we have been following up. So so now again, I told you, so it's only thing is we'll get to know with
all the research also doesn't say even if you have an acute cholesteatoma, everything I think all are doing second stage. I cannot allow. I don't agree with the science.
Okay, that was a buzzer for the judges too, because we have only 2 minutes for questioning. That was very nice, Ganga. But what we need to keep in mind is these are competitive sections where timekeeping carries a lot of marking. Very well done. Let's move on to the next presenter.
She needs wrap up in the question answers also.
Dr. Jatin Verma will speak implantation in Meniere's disease, a South Indian perspective. Dr. Jatin Verma. Yes. Because we're taking time with the changeover, sharing screen and whatnot.
Good morning, everyone. It's a great honor to be presenting in CIGICON 2021. Today, I am going to share our experience with cochlear implantation in Meniere's disease. As we all know, Meniere's is a chronic debilitating disease affecting the inner ear. It is an idiopathic disorder that is characterized by recurrent spontaneous vertigo along with fluctuating or progressive sensorineural hearing loss, tinnitus, and oral fullness in affected ear. The incidence of sensorineural hearing loss that is profound is almost 1 to 6%. In Meniere's disease, the patients with severe hearing loss and poor dynamic range along with poor balance are the candidates for cochlear implantation. The possible scenarios that we can have in Meniere's disease are burnt out Meniere's disease in which there is no labyrinthine stimulation. In those candidates, we go for CI alone. If the patients have progressive Meniere's disease, that is, they have active labyrinth and they are having intractable vertigo, they are the candidates for CI along with osseous labyrinthectomy. This presentation highlights our 2 decades of experience with cochlear implantation in patients with advanced Meniere's disease at our CI clinic in Chennai. This is a cross section of cochlea, which is showing the cochlear implant in situ along with the collapsed saccule that we get most commonly after the cochlear implantation. Coming to materials and methods, this study was done at our tertiary ENT care center and premier CI clinic in Chennai between January 98 to June 2019. The sample size was 17. The patients were treated medically for an average of 10 years before they were taken for the cochlear implant. As per the inclusion criteria, the adults with burnt out Meniere's disease having dead ear, and adults with advanced Meniere's disease refractory to medical management having severe to profound hearing loss were taken up for the cochlear implant, while the Meniere's disease patients with residual hearing aidable by conventional hearing aids and responsive to medical management were excluded from the study. Preoperatively, they underwent audiological and vestibular workup along with imaging of the inner ear. The patient-reported outcome measures were used to assess the outcomes. Vestibular handicap index for giddiness, tinnitus handicap index for tinnitus, while categories of auditory performance were used to assess benefit for the hearing. The cochlear implantation and labyrinthectomy was done by the same surgeon. The switch on was done 3 weeks post surgery. 3 months rehabilitation was done to make these patients accustomed to the device. The outcomes were assessed at the end of the first year. In first image, we can see the labyrinthectomy being done. In the second image, we can see the cochlear implant in situ in the same patient. Now coming to results, we had 17 patients in all. 4 patients had unilateral disease, while 13 patients had bilateral disease. Out of 13, 5 were having bilateral dead ear, while 8 were having bilateral asymmetric disease. Male to female ratio was 11:6. The age range was 35 to 55 years, with maximum 9 patients between 45 to 50 years. All the 17 patients underwent cochlear implantation. 7 patients also had a simultaneous osseous labyrinthectomy. There were no surgical complications. They were followed up for at least 12 months after cochlear implantation. Results were measured by objective and subjective parameters as shown. First, coming to the objective parameters, 7 patients had hypoactive caloric response and abnormal VAMP response preoperatively. In the immediate post-operative period, 6 patients also showed similar findings, but however, in the long term, none of the patients experienced vertigo. That is statistically significant. According to VHI, 7 patients had moderate to severe handicap index preoperatively, while in post-operative period, only 2 patients had moderate handicap index. That is statistically significant. CI also helped in resolution of the tinnitus. 6 patients who had moderate to severe handicap preoperatively improved, and only 1 patient experienced tinnitus in the post-operative period. The mean CAP score was 1, which improved to 1.92 at 6 months and finally 4.88 at 12 months. That is statistically significant, and it proves that CI is beneficial in improving hearing in Meniere's disease. The CI-aided audiometry had pre-op threshold of 88.73 decibel in the patients, while it improved to 34.2 decibel after 1 year. That is also statistically significant. Coming to discussion, significant hearing improvement occurs with CI. Blood fluctuation in hearing may occur during the acute attack. That can be overcome by reprogramming, and it really helps. Simultaneous labyrinthectomy and cochlear implantation, they help in elevation of both auditory and balance symptoms. The implantation doesn't really alter the natural history of Meniere's disease. We had significant improvements in hearing, vertigo, and tinnitus following implantation in Meniere's disease patients without any complications, which is comparable to world literature. Now I'll conclude. Cochlear implantation is effective in hearing restoration and reduction of tinnitus in patients with Meniere's disease. The patients with intractable vertigo may need simultaneous labyrinthectomy and cochlear implantation. Transient vestibular imbalance is noted in patients who have a cochlear implant due to saccular stimulation. Vestibular compensation and rehabilitation may be required until adaptation and central compensation occurs. Meticulous selection criteria for CI and good perioperative counseling and vestibular therapy are really important for achieving realistic outcomes. Before I end my presentation, I would like to open up some gray zones in the expert forum for interesting comments. In bilateral intractable Meniere's disease, is bilateral CI warranted? Which side would you choose? Can we do bilateral labyrinthectomy with cochlear implantation? Is there any role of vestibular implant? Future combination of cochlear implant and vestibular implant? These are my references. Thanks for your patient listening.
Yeah, thank you, Dr. Jatin. It was a good presentation. We usually have complaints with the Meniere's disease is the more than the hearing loss, it is the vertigo as well as the tinnitus. What is your observation on tinnitus, improvement or deterioration, or it's the same status quo on the levels of the tinnitus? And was there any observations done in the measurement of that scores? Number two, what about the vertiginous attacks? And
Yes.
how much period that it took for them to stabilize? I mean, was there any significant, you said a significant thing is there. So
Yes,
was there
sir.
any score to it, or it is just observation? And how much time later that you could say that anyway, there was an improvement in the vertiginous attack? These two questions.
Sir, coming to your first question, tinnitus, you're asking what was our experience with how much time, how did it improve post-operatively?
Improved, no improvement?
Sir, it did improve post-operatively. And in fact, because of the auditory deprivation that these patients were having for a long time, and since we gave the implant, it gradually improved. As I have mentioned in my presentation, immediately post-op, still 90% patients did have that tinnitus, but 6 months down the line, only 2 patients had moderate, only 1 patient had a moderate handicap. So almost 90%, 90 to 95% resolution occurred. Only 5% patients, it was still there. And coming to the vertiginous attacks, you are saying it was not an observation, it was a questionnaire we have assessed subjectively as well as objectively. We have used that questionnaire. In fact, patient has given the responses. Some around 6 months, we didn't really have only 2 patients, they were complaining like symptoms, but they also had only that moderate handicap. No patient was there in the severe handicap category. And objectively also on caloric test, we didn't have any response, and there were no abnormal VEMP responses also, sir.
Thank you.
That histopathology slide which you showed.
Yes, ma'am.
Any reference for that? Is it your patient or?
Oh, no, ma'am. It has, ma'am, that slide we have taken, ma'am.
Give a reference for such.
Yeah, yes, ma'am. It has been taken from Hansel Neurotology, ma'am, actually, ma'am.
Okay. You should always write one small caption there. Okay?
Yes, ma'am. Yes, ma'am.
One more thing, I just wanted to again know.
Yes, ma'am.
Labyrinthectomy was done. So labyrinthectomy was done in your Meniere's patient.
In my which patient, ma'am?
Yeah,
Pardon, ma'am.
No, labyrinthectomy was done in how many patients? I just wanted to know your total number of patients.
Total number 7 patients we did labyrinthectomy, ma'am.
Okay. Okay, what was the indications for that? Means,
ma'am, intractable vertigo, despite our maximal medical management and patients being treated for 10 years, they didn't have really control over the attack. Still they were really dizzy, and their quality of life was really hampered, ma'am.
So after the cochlear implant, they were absolutely fine. All the 7 patients.
Yes, ma'am. They are absolutely fine. They still come to our outpatient department. They're absolutely fine, ma'am.
Okay. Okay.
Okay, we'll move on to the next presenter. This would be Dr. Lakshmi Ranjit, who will speak on cochlear implantation in far advanced autosclerosis. Dr. Lakshmi Ranjit, please share your screen and start.
Yes, sir.
Hello.
Yeah, good morning.
Good morning, sir. Good morning, ma'am. I'm starting sharing the screen. So today I'm going to present our experience of cochlear implantation
Sir,
in
is
the
it
patient with Mondini dysplasia. Hello.
Now Dr. Lakshmi will present. After Lakshmi, Dr. Anshu.
Sorry.
Okay, thank you. Lakshmi, you can share your screen and start.
So can you see my screen now?
No, ma'am.
No.
Just one second. Yeah, now, sir?
Yes.
Please make the slide show, man.
Good morning, everyone. It's a great honor to be presenting in CIGICON 2021. My topic for today is cochlear implantation in far advanced autosclerosis, our experience. So autosclerosis basically is a disease of the aortic capsule, which is characterized by disordered resorption and deposition of the bone. And ossification of the cochlea may increase with the course of the disease, and it leads to progressive sensorineural or mixed hearing loss, which is mostly because of reduction in hair cells or reduction in spiral ganglion cells with mostly intact auditory nerve cells. Now, when we classify the patient as far advanced autosclerosis, when the speech discrimination comes down less than 30%, and the patient has sensorineural hearing loss of more than 85 decibels. So such patients, the treatment options that we can give them are either powerful hearing aids or stepidotomy, followed by hearing aids and cochlear implants. So our study basically tries to outline the perspective of a surgeon in choosing patients of far advanced autosclerosis to offer them cochlear implantation either as a primary modality of treatment or after failure of conventional methods like stepidotomy. Ours was a retrospective study performed in our CI center between 1997 and 2017. Our sample size was 43. Inclusion criteria, we included patients based on candidacy according to the Merkus et al. Paper, which based candidacy on speech discrimination scores, Simons and Fanning CT grading, and airborne gap on Purton audiogram. We excluded all patients who had hearing loss due to who had profound hearing loss due to causes other than autosclerosis. Investigations included the basic battery of audiometry tests and CT and MRI imaging. So this is how we made the decision in case whether the patient had to be implanted. Patients with a speech discrimination score less than 30% were chosen for implant primarily. Patients who had a speech discrimination score between 30 and 50%, their CT grading was seen, and if the CT grading was between 2C to 3, they were also offered an implant. Those who had no HRCT findings, no significant HRCT findings that is, and had an airborne gap of more than 30 decibel, they were offered stepidotomy. Those who had an airborne gap of less than 30, again, these patients were also offered a cochlear implant. Finally, patients who had a good speech discrimination score between 50 and 70%, but still had an HRCT grading between 2C or 3, they were offered a cochlear implant. Those with no HRCT findings and a good airborne gap were offered the stepidotomy. With a poor airborne gap were offered hearing aids primarily. Now, all our candidates underwent cochlear implantation. They were implanted by the same senior surgeon, and the standard technique of round window or cochleostomy was followed. All implants were manufactured by the same company, and we used a facial nerve monitor in all our patients. All patients underwent regular auditory verbal rehabilitation. Evaluation of hearing-related quality of life was done using CAP scores and the Glasgow Benefit Inventory Questionnaire. These are our results. We had 43 postlingual adults, 21 were males, 22 were females. Age range is between 35 to 78 years. 22 patients had unilaterally advanced otosclerosis and they were offered cochlear implantation as the primary modality of treatment. 21 had bilateral progressive. Of these, 7 patients were initially offered a stepidotomy. Once that failed, we offered them an implant. 14 were offered implant primary. This was a CT grading of our cohort of patients. Of the 43 patients, 31 had only fenestral, that is grade 1 grading according to Simons and Fanning grading of 2005. 11 patients had grade 2, while only 1 patient had a diffuse cochlear involvement. And out of the 43 patients, 39 we could implant, the insertion was complete, and only 4 patients we had a partial insertion. None of the patients had a scalar vestibular insertion. No misplacement of electrode array was done in any of our patients. We did not encounter any CSF gusher. The surgical outcomes were satisfactory in keeping with the complication rate of less than 5%. Facial nerve stimulation was seen in 5 of our patients, which was mostly in 7, 8, 9 electrodes. So in 2 patients, we had to turn off the 6th and the 7th electrode. In another 2 patients, we had to keep 6 and 7, the charge unit of the 6th and 7th electrode lower. In a single patient, we had to switch off the 7th and keep the charge units on the 6th and the 8th electrode lower than the others. CAP scores were measured for patients of bilateral otosclerosis preoperatively and 1 year post-op, and there was statistically significant improvement in both CAP scores and the Glasgow Benefit Inventory Hearing score. So coming to the discussion, expanding indications of cochlear implantation, we need to include patients of advanced otosclerosis because of 2 reasons. One, they have this acoustic baffle, that is higher order sound processing gets affected due to certain dead regions in the cochlea, and it is more common above 70 decibels. These patients also have problems with hearing aids like poor internal attenuation, sound localization, and music appreciation. Radiology is a very essential pre-surgical evaluation tool in such patients because we can evaluate the extent of lesion and cochlear patency. The surgical issues that we encounter can be, we need extra drilling to overcome the ossification. There could be misplacement of electrode array with the implant being inserted into a false lumen. False passages into the eustachian tube or internal auditory meatus can be seen. There could be also a higher risk of CSF gusher. Programming can pose some challenges in otosclerotic patients because of progression of the disease. So we can have a post-operative failure of implants. There's also a higher risk of facial nerve stimulation due to the otospongiotic bone. So in such patients, sometimes the audiologists need to give a higher charge because of lack of hair and spiral ganglion cells. So these higher charges can cause other non-auditory stimulations like otalgia or dizziness. In conclusion, we want to propose a rational protocol for surgical management for these patients. So that's what we have to try to highlight with our study. These patients also need meticulous counseling regarding possibility of complications, and the expectations have to be explained to the patient. It is, in our perspective, it is better to offer cochlear implant to these patients at an early stage when there is lesser ossification, there is more presence of residual hearing, and there is denser bone around the facial nerve so that stimulation can be kept to the minimal. Certain gray zones that we need to address with cochlear implant in otosclerosis is regarding tinnitus and vertigo. These patients may have worsening of tinnitus after surgery, both tinnitus and vertigo. So extensive preoperative counseling is mandatory. Outcome assessment with bimodal binaural stimulation needs to be done because certain patients who are using hearing aid in 1 year and implant in the other, integration of sound may be something difficult, and patients may need the extensive therapy for this. Patients with coexisting presbycusis and otosclerosis may be a difficult cohort again because of the difference in nature of the hearing loss. Auditory benefits in patients between patients who had a drill out and patients with a patent lumen may be difficult to judge because patients with a drill out may have a lesser spiral ganglion population as well. And progress of otosclerosis around the implant is another thing that we need to consider because as the disease progresses, the implant may fail at a later stage. So that was my presentation. Thank you all for the patient listening.
Yeah, Dr. Lakshmi, very good presentation. I have only one question.
Yes, sir.
What was your the youngest age patient?
So youngest age was 40 years, sir.
So how many years he is under follow-up now? It's a progressive disease. So and how the follow-up is going on with him?
Sir, as of now, sir, he's been followed up for 3 years, sir. So till now, he's doing well.
And the tinnitus that you mentioned, the worsening cases, how was the auditory gain that they are finding useful, discrimination and all that with the tinnitus increase?
So gain has gone up in most patients. The CAP scores have increased, but very few, like 1 or 2 patients are complaining of tinnitus even after their speech perception is better, but tinnitus, they are not very happy with the outcome.
Okay, thank you.
Nice, thank you.
Nice presentation. All were scalar tympani insertion?
No, yes, ma'am. All were scalar tympani insertion, ma'am.
So you never had a chance of scalar vestibular or any?
No, ma'am. We did not need to insert scalar vestibular.
Thank you.
Thank you, ma'am.
Okay, that was well within time, both the presenter and the judges in the Q&A section. Well done.
You have to give us marks.
We will give you marks too. Okay, the last presenter of this section and hence oral paper is Dr. Anshu Singh on cochlear implantation in children with Mondini dysplasia, our experience. Anshu Singh, go ahead and share your screen.
Good morning, sir and ma'am. Sorry for the glitch. Good morning. Today I'm going to present cochlear implantation in Mondini's dysplasia patient, our experience. So, as we know, Mondini's dysplasia is one of the commonest cochlear abnormality encountered in cochlear implant surgery.
Excuse me,
it is a hello.
Can you make slideshow? Thank you.
Hello.
Can you make your presentation slideshow?
Click on the slideshow button. At the bottom is a slideshow button.
Can you see it now?
Okay, go ahead. Go ahead and present it. Just go.
Mondini dysplasia is a radiological diagnosis. It is a triad of malformation. As you can see in this CT, there is a cystic appearance of cochlear apex due to loss of interscalary septa. There is mild dilation of vestibule and enlarged vestibular aqueduct. Rest the cochlear dimensions are same. So the study was aimed to evaluate the intraoperative challenge encountered in cochlear implantation in these Mondini dysplasia patient, as well as we assess the development of auditory and verbal skills in Mondini dysplasia patient and compared them with a cohort of cochlear implant patient with normal, radiologically normal ear. And we did it for 3 years. So this is a retrospective study, and our sample size was 338 patients implanted in that period. All the patients underwent the same preoperative evaluation of audiometry, radiology, and evaluation, and all were having a hearing aid trial with no significant benefit. We diagnosed 27 patients of classical Mondini dysplasia by radiological examination. For the sake of statistical purpose, we divided them in 2 groups. A group A was the patient with cochlear implantation having normal radiology, and the patient B was Mondini dysplasia patient. So every patient was operated by transmastoid posterior tympanotomy approach with the same straight electrode. Intraoperative NRT, impedance, and CMA imaging was done, and all the surgical steps were recorded. So all patients underwent post-operatively for audio-verbal training, speech and language training, with CAP, SIR, and MAS were recorded pre-implantation.
Anshu, your slides are not changing for me. It's the first slide only I could see. Yeah, now I missed all the other slides.
Is it changing now?
Now it's there. Why didn't you put it on the presentation mode? It is in the slide mode.
Sir, wait a minute. So is it changing now?
No.
Sorry, sir, I'm having a technical glitch.
Dr. Anshu, just stop share your screen and then.
Can you see it now, sir?
Make it slideshow, ma'am. There is a bottom, there is a fourth button.
Sir, I already did that.
No, it's not visible for us.
Sir, I'm logging with a different app, this thing, sir. I'm logging with the tab.
No, so Anshu, the other
Yes,
thing you can do is you have the slides on this side, right? One by one on the slide pane on
Yes,
the left-hand side. If you
Yes, sir.
clicking on each slide there, we will see the next slide, correct?
Can you see this, sir?
Yes, we can. We are on material. So just keep moving those slides.
Okay,
but we missed a lot of the initial slides.
Go back.
I will just, yes, sir. So,
Probably we can give her some more time.
Yes, we can. Just.
Thank you, sir. Sir, I was telling in the HRCT the triad of malformation in the Mondini's dysplasia, the cystic capex due to lack of interstellar septa, the enlarged vestibular aqueduct, and mild dilation in the vestibule, which was diagnosed in CT. So how we diagnose the Mondini's dysplasia patient, and this study was aimed for to evaluate the intraoperative challenge for CI in Mondini dysplasia, and also for assess the development of skills in these Mondini patient as compared to patient with radiologically normal ear in CI. So it was done in 338 patients of cochlear implantation. All the patients underwent the same preoperative evaluations, and hearing aid trial was given with no significant benefit. 27 patients of classical Mondini dysplasia were confirmed radiologically, and for the sake of statistical purpose, we divided them into group A, which was radiologically normal ear, and group B was Mondini dysplasia patient. So our all patients underwent transmastoid posterior tympanic approach only with the same straight electrode, and interoperative testing, NRT, impedance, CM imaging was done with all the surgical steps recorded and challenges were recorded. So in post-operatively, all patients underwent the regular auditory verbal training, speech language training, and they were assessed by CAPS and Myers, pre-implantation as well as post-implantation 3, 6, 9 month, 1 year, 2 year, up to 3 years. So the results are, among the 338 patients who were implanted, 82 patients were presented with inner ear abnormalities. Among them, 27 patients had classical Mondini dysplasia. So, hello. So among them, the most important intraoperative challenge we faced was CSF gusher or ooze. 14 patients of group B, which is Mondini patient, have CSF leak at the site of cochlear site. But among them, 12 patients had gentle flow and 2 patients have CSF gusher. So as you can see, what we did in CSF leak or gusher, the first thing we did was elevate the head to 30 degrees and wait for 20 minutes patiently, which is very important thing, because after that the CSF start pulsating and it is manageable. During this time, we harvested a fascia of 1 to 2 centimeter, and we made a hole in this fascia and passed the electrode through it. After that, the electrode was introduced into scalar tympani, and the fascia was packed with 2/3 fascia being inside and 1/3 being outside. So even after this, we had one case in which it was believed that the gusher was adequately controlled. But 24 hours later, the patient presented it, and we suspected that the seal has been displaced after 24 hours. So we decided to take the patient for further exploration. So this is a post-operative CT in which the flute is seen in middle ear and mastoid. During further exploration, the electrodes were found partially extruded. So we replaced the electrode And this time, the cochleostomy was packed with facial art and tissue was applied to the CV, along with the usual measures of head elevation, absolute bed rest, and acetazolamide was given. This patient was further uneventful. So at this time, I want to stress upon it that these modular defects in Mondini patient are supposed to be due to high CSF pressure transmission in the inner ear through enlarged vestibular aqueduct. As CSF leak is much more common in congenital anomalies, the Mondini malformation should be considered high risk for leak. And there are publications who are telling that the CSF gusher and leaks are 40 to 50% in anomalies. We have to differentiate whether it is a gusher, whether it is a leak. Because in our study, among 27 patients, 14 patients has leak, but only 2 patients, which is 7% only, has gusher. So size of cochleostomy is also an important thing to notice, because there are recommendations that it should be small and so that the electrode can partially block it. There are recommendations it should be large to easy flow. But what we think the important is the sealing of cochleostomy site important, and the packing should be strong enough to break down, not to break down later. We prefer large cochleostomy site for the ease of the packing. There were no further complications in our study. For the audiological result, although cochlear implant is the only surgery where the result speaks for themselves, but in our study, we noticed that there was significant difference in the normal patient and the Mondini patient in first 9 months, as you can see in the graphs. But after 1 year, these patients, both patients were at the same level of caps in and miles. So it can be explained that the spiral ganglia in Mondini patients are reported to be far less than normal cochlea, although it is enough to trigger the neural response. So therefore, we don't find any significant difference after 1 year of implantation. So in conclusion, I want to conclude that CSF gusher and ooze should be anticipated in Mondini patient and should be managed appropriately. But at the same time, Mondini dysplasia patient required slightly longer time to attain the appropriate auditory skills. And therefore, the more attention should be paid in their first post-operative period. And the message I want to give from this thing is there should be an early intervention. CSF gusher should not be afraid of, but managed properly. And first year of rehabilitation is important. And normally children have different learning curve than the radiologically normal child. So the training must be tailored accordingly rather than being a fixed training post-operatively. These are my references. Thank you.
Judges?
Yeah. Good presentation, Dr. Anshu. Was there any incidence of meningitis post-operatively in your series?
No, sir. No, sir. We haven't seen it yet.
And all gushers were also controlled post-operatively?
So one gusher wasn't able to control because we thought that it was controlled, but we have to open the child after 1.5 days after the initial operation.
Thank you.
Sangeeta? Sangeeta, any questions? Probably not. So with that, we'll conclude this section of oral papers in surgery. Let me thank profusely Dr. Rambabu and Dr. Sangeeta Varti for taking time out on both Friday and this morning very early on a Sunday morning, and all the presenters, and a hearty congratulations to all the presenters, especially this morning, because they've all been just now, just last night, inducted in as members of the CG. The GBM ratified you as CG members. We've just crossed 700 members in CG. Thank you so much, each one of you, and thank you, judges, as well. And we'll move on to the next section today. Scoring for the judges if it can be done and emailed to anil@avyaya.com, we would appreciate that as soon as you're ready. Some housekeeping announcements. Please make sure you attend you click on the hotspot on the exhibition hall, and please visit our strategic partner Medel, visit our diamond sponsors, the gold educational partners as well. Please show them your support. I think there's also a photo booth option right at the top of your panel in the delegate experience. You can click a picture of yourself as you have attended this conference. So the background is of CIGICON 2021, and I think that is very nice to have with you. With that, we'll come to this common platform for surgery, audiology, and habilitation, and this is an extremely interesting component of GCI, which we have incorporated into CIGICON. World Cafe moderator sessions. So as you know, a pre-conference World Cafe session where a group of experts, I would call them luminaries in these fields, got together, 10 to 12 of them in these 7 streams, 7 topics that had controversies, and they've deliberated for 2 to 3 hours in some instances on Monday, Tuesday, and Wednesday this last week. And the moderators of these sessions are available just now to summarize the World Cafe deliberations for you. And they will present in the order that it appears here. And they have about 12 minutes to present. We don't have question and answers in this session. What will typically happen is we will put all this together into publications. We are hoping this will be published in peer-reviewed journals as recommended clinical practice guidelines. So wish us well for this exercise and this effort. Let me very quickly introduce all the moderators, all the World Cafe moderators. Anil, if you can share the screen. Amit Kishore will go first. Amit is a very dear friend, the past secretary of CG. He works at Apollo, New Delhi, and he's performed more than 1,500 cochlear implant surgeries. He's with several NGOs, and Amit's going to summarize CI, ABI, and cochlear nerve hypoplasia. We next have Nivita Narayan. Nivita is an audiologist and speech and language pathologist, again with more than 25 years of experience in the field. She's always been with CG, a very valuable member of CG, and her experience is very wide in this area, also with electrophysiology and with auditory brainstem implant systems. One of the very few CI audiologists who has experience with the ABI. She will summarize electroacoustic stimulation, which was one of the World Cafes. We next have Dr. N. Bhanumati. Bhanu is from PGI Chandigarh, a premier institute of teaching in the country, and she's an associate professor at PGI Chandigarh. And Bhanu has won so many prizes in CG, we had to stop her from competing anymore because she was taking away all the prizes. Bhanu managed to very nicely put together, the feedback we got was very good on the World Cafe she put together on multilingualism and cochlear implantation, which she will summarize for us. Next, we have Dr. Munish Grover. This is one of those youngest surgeons in the who doesn't need an introduction. Munish has been extremely dynamic and flamboyant and a maverick of sorts, and he's played a pioneering role in the state of Rajasthan and impressed upon the governments to help with the cochlear implant systems and also with universal neonatal hearing screening in Rajasthan. just as has been in Kerala. So currently, Monish is also the Joint Secretary of CG, as many of you know. We will move on to Monish will summarize what is his forte, that is CI in cochlear anomalies. We next have Nishita Mohandas, our Secretary General, as we call her. So some of you have seen how she performs in the general body meeting. She just holds forth and everybody is under control. Nishita has been an amazing member of the CG for the last nearly 20 years now. She is in the Hinduja Hospital, I think, all her life, supporting Dr. Kirtane's pioneering cochlear implant program since its inception in 1996. Nishita is going to summarize for us mapping in difficult situations, which was again an amazing World Cafe. We next have Dr. Aparna Nandurkar. Aparna has contributed immensely to both the World Cafe and to the actual conference yesterday as well. She was in a very good panel on policy decisions and sustainability. Aparna is the spearhead, I think, all India head of the ADDIC program that is happening with the Government of India Ministry of Social Justice. We all think of her as the right hand to the director, Dr. Suni Matthew, and Aparna is really working hard to make sure she crosses all the T's, dots all the I's with the ADDIC program. There have been several issues, but Aparna is single-handedly, with of course a very good team supporting her, doing yeoman service in the ADDIC program. She's also auditing the outcomes and making sure everybody is happy with it. Aparna is going to summarize for us mainstreaming and cochlear implantation. Thank you, Aparna. Next would be, and the final one would be Dr. Asha, a professor at the All India Institute of Speech and Hearing in Mysuru. She's had so many students, PhD students who have become CG members. She's contributed again immensely to the world of CI audio, CI habilitation. Dr. Asha Etiraj contributes to the World Cafe on auditory neuropathy spectrum disorder. This was the single common stream World Cafe that we actually put together on Wednesday, and that went really well with surgeons, audiologists, and rehab specialists in that group. So with that, we will take off, and the request is you will not be called back. So you just take over, Amit, and let's follow on the way it is in the program. Each of you to summarize your World Cafes. Go ahead, Amit.
I shall give them
Good morning, Sunil. Thank you for that. Good morning, everybody. I just want to check, am I audible and visible? Or is my screen visible?
Yes, Doctor, please go ahead.
Wonderful, wonderful. Great. Yeah, thanks for the introduction. And as the opening batsman, without further ado, I'll just carry on in the interest of time. So the World Cafe that I was asked to moderate was on the topic of cochlear implant or ABI in situations with the hyperplastic cochlear nerve. Very interesting meeting. We had the following panelists. I'll quickly run through them. Gavia from Spain, Dr. Rodriguez from Brazil could not attend, Amar Galal and Saad Al-Zaid from Egypt, Dr. Fatih Baki, who actually started the World Cafe concept, he unfortunately could not attend. Neelam from Pune, Dr. Madhuri Gore from Bengaluru, Dr. Naresh Panda, PGI Chandigarh, Dr. Ram Babu from Hyderabad, and Dr. Shankar Medikeri from Bengaluru. So they all had presentations. We went through a number of various questions and points that needed discussed. This is the distill of all that I'm presenting to you in the next 10 minutes. So the first assumption that we made for the purpose of the panel discussion is that we're dealing with the pediatric population who meet the criteria for a cochlear implant. So they've gone through the whole routine. of insufficient benefit with hearing aids, severe to profound hearing loss, so on and so forth, and would be deemed fit for a cochlear implant till the imaging suggested a cochlear nerve deficiency or a hypoplastic cochlear nerve. The cochlea is normal. So these were the assumptions, because if we open up with the cochlear anomalies, then that is a completely different ballgame. And it was agreed that in about 2% of kids who present to us with sensory hearing loss would have some form of cochlear nerve deficiency. That is the definition, which includes aplasia or hypoplasia. So the first thing is that on imaging, how do we define hypoplastic cochlear nerve and nerve deficiency, and what do we need? So, of course, an MRI is mandatory to define nerve anomalies. And on the MRI, either the cochlear nerve diameter would be less than that of the diameter of the facial nerve, and that's an eyeballing. And there is some data to suggest that if the diameter of the cochlear nerve was 1.8 mm or less at the porus, or 1.6 mm or less mid-internal auditory canal, give or take 0.2 mm, then it would be defined as a hypoplastic cochlear nerve. So it's an MRI that we need. However, we all know that in most centers there is also CT scan done, and we would like to highlight that there are pointers on the CT scan that might suggest a problem with the cochlear nerve. So if the internal auditory canal is less than 3 millimeters in diameter, or the cochlear aperture or the bony cochlear nerve canal is either absent or stenotic, then please look at your MRI carefully, because that may indicate a hypoplastic nerve, because we have discussed that in many situations that is missed on an MRI when it's very obvious that there is a cochlear nerve aperture stenosis on the CT scan. That is not being picked up. We also discussed that for the purposes of documentation and presentation and so on and so forth, we should be encouraged to use the Castleman's classification, first developed in 1997, so that we are all talking about the same thing and on the same page. The next question was that in imaging, how reliable is our current imaging to conclude that the nerve is hypoplastic, and what should be the appropriate parameters on the imaging? The desirable is currently to have a 3 Tesla MR system, which is available in most centers, but nevertheless, we are aware that there are a lot of centers with 1.5 Tesla. You can get reasonable images with a 1.5 Tesla if you use a surface coil, and that's where you could discuss with the radiologist on that protocol. It has to be a heavily weighted T2 MR, a volume scan, fine cuts, and you must get oblique parasagittal sections so that you can see all the nerves across the IAC. So that would be the imaging parameters. The next is the audiological assessment. And this, I would say, and we all agreed, is the mainstay in the decision-making process. So you have to work the surgeons have to work very, very closely with their audiologists, and we are very heavily dependent on their input. So there was a long discussion on that, and we were fortunate to have Dr. Madhuri Gore as the audiologist on the panel, and she enlightened us all on this. So in the audiological assessment, the first is, of course, the pure tone thresholds. We need to get reliable, age-appropriate, conditioned audiometry. Remember, we are dealing with children, so it could be behavioral observation audiometry, VRA, conditioned audiometry. It may take time to condition the child, but that's very, very important. Imitance tests and reflexes will help us rule out middle ear pathology that could overlap. Apart from pure tone thresholds, speech perception tests are also very, very important, and we'll come to that, what Dr. Gore shared. And also what is important are parent progress report questionnaires, the MACE, the ITMACE, whatever you use, because a lot of things cannot be picked up in the sound booth when the child is there for testing. So it's like a jigsaw puzzle. You've got to put all the bits together to try and get that information. And in addition to that, again, what was very importantly highlighted, the non-verbal methods to test auditory percepts, looking for the temporal and intensity and frequency responses. So that's very, very important. And this is very hard work for the audiologist, but it is extremely important. The next thing we discussed was that a lot of these children, of course, have been through the process of looking at the hearing aid, and we've decided that they're not getting benefit with hearing aid. But nevertheless, now in this very tricky situation, we can use and we should use the hearing aid evaluation in further depth, because that's going to tell us whether we have adequate neural tissue that's conducting sound. So the process is that we prescribe a hearing aid for the child, fit the child with a hearing aid, put that child through a very intensive therapy program, and during that therapy program and at the end of that therapy program, we assess and continue to reassess the child's auditory responses through ear-specific aided audiogram, through speech perception. So this is really mandatory, and it's like a diagnostic therapy program is what our audiological team led by Nivedita tells us. This is diagnostic therapy because you are providing therapy, but also it is diagnostic. If we have the benefit of cortical potentials in an institute, then yes, one can use cortical potentials also to look for responses with the hearing aid. Now we are aware that that's not available everywhere. It is a desirable thing, but what is mandatory is getting ear-specific aided audiograms and speech perception with the hearing aid. So, and this is from Dr. Madhuri Gore's slide, and it was very nice to see that lots of standardized tests have been designed locally in India and available in many Indian languages. So I've put that up for those of us who are not aware of that, and recommend that we use them. So in addition to this, it is also important, she reiterated, that we watch the recordings of therapy sessions. We look also at speech and language evaluation, because that will help us verify the developmental status of the child, look at total communication behavior, look for any cognitive issues, because that information is also very important. And in addition to that, look at non-verbal communication methods such as gesture evaluation. And there are modalities to evaluate that, which one would recommend we look at. It is also important to look at comorbidities, because they often coexist with children. A proportion of children with cochlear nerve hypoplasia or aplasia deficiency may have comorbidities, dysphagia, cognition, neural issues, autism spectrum, so on and so forth. So it's important to identify that, because that is going to have an effect on the outcome. So that's again mandatory. A desirable thing is to have electrophysiological testing as well. If you have been fortunate, or you are fortunate to have transtympanic EABR, if it's available, it will add to the information. Yes, it's not available widely. It's a process. It's something which is continually evolving, and we have to look at this space. But nevertheless, if you have that information and it corroborates with your primary auditory speech and language evaluation, it certainly helps. And again, the slide from Dr. Madhuri Gore's presentation is a lot of work has been done by Dr. Sunil Dutt and Apurv on TTABR, and they have come up with a classification which we can use. So the point is that it's very specific. So if you get something on the TTABR, it adds to our confidence that our audiological evaluation is good. If it's absent, it may be due to various other reasons, but and it doesn't necessarily mean the child won't get benefit, but it's an added tool. So if you have it and you have access to it, then certainly do use that as well. So when we come to the decision-making process, after all this, when do we advise? So we have three options. We advise a cochlear implant, we do not advise a cochlear implant, and the third is that we could try it out and see. So if you have cochlear nerves visible on the MRI, and you have good, reliable, aided audiological responses, and your audiologist tells you that yes, there is conduction and there is a response, then we would counsel for a cochlear implant. And of course, if you've got positive waves on the TTABR, that adds to that confidence level. When do we not advise a cochlear implant? If we really have nothing visible on the best quality MRI that we have, and we have absolutely no responses on the audiological assessment, or the child has a lot of other comorbidities, then we should be very careful and probably not advise a cochlear implant and look at signing or other modalities. But again, to repeat, audiological responses are very important, because sometimes you can have fibers of the cochlear nerve traveling with other nerves and it may not be visible. So that's when we don't advise a cochlear implant. There are options where we are not sure, you get some responses, there may be a nerve visible, so you can have the option of trying a cochlear implant first and then see what happens. But that is important if the child is very young, because you have an upper limit for the ABI, 4 or 5 years. So if the child is 1, 2, 2.5, 3, you can go down that route. There is a problem with cost in our country, so that has to be mentioned. How do we counsel the family regarding outcomes? What are the expected outcomes? Auditory outcomes, it has been seen, all the data that the presenters showed, that CI provides benefit in many children with cochlear nerve deficiency. They almost seem to do well in the early phase, but the benefit will plateau after maybe 1 to 2 years, say CAP 6 or 7. But the long-term outcomes are very variable, unpredictable. Be prepared for non-auditory stimulation like facial twitching. Duration is to achieve this is longer than other CI recipients. Habilitation has to be multimodality, and we have to be very guarded with regard to long-term outcomes and counsel them with regard to change over ABI. So yes, we do offer CI, but they have to be counseled. When do we recommend an ABI? Directly if there's aplasia of the cochlear nerve, no auditory responses, as they've said, and in the other kids, severe cochlear ossification and things, or severe anomalies. So let's say we've got a cochlear implant first. How do we monitor the progress? Again, regular aided audiogram, speech audiogram, use electrophysiology, EABR, to assess the responses and for map optimization. Look at the behavioral responses, look at speech and language development. When we are monitoring, what should be the red flags that we should see to suggest that the child is not getting benefit from CI? We should counsel otherwise, because time is of the essence. If on mapping we have no perceptive sound, if on aided thresholds they are completely out of the spectrum, if a closed set speech audiogram has no pattern percept, and on your EABR or corticals, you get complete absent responses, these are all the red flags that we have to then count. We have to look for and counsel the family that probably this child is not getting a benefit from CI, and they have to look elsewhere. Either we have to look at sign language or we have to consider an ABI. How long do we wait for things? I think 6 months to probably a year is max that you can wait, but rather than keep waiting, use these tools to keep continually monitoring the child for appropriate counseling. And finally, if it does come to ABI, what can we expect? The results of ABI are very, very variable, very unpredictable. A lot of them, 80% will report hearing sensation. It will be an aid to lip reading. Only about 20% will have word understanding with or without lip reading. You have a huge number of non-auditory sensation, and the maximum score you might get is a CAP, and you can have non-users. So it's not that straightforward and easy. ABI is again in evolution, and I think we have to be very, very careful, because the language outcomes are going to be poor. There are schooling and long-term outcomes. They cannot go to normal school, and signing is of course a very good option. And that is why we feel, or the panel felt, that ABI should still be limited to a few research centers where there are dedicated teams who know what to do in terms of habilitation, audiology, post the surgery, and we have to keep getting more data on the non-tumor pediatric ABI situations before we can come up with even more conclusive recommendations. So with that, that was the summary of that, and I thank you for your time. And to paraphrase what Sunil had said, I think take-home message: if you have better imaging, better auditory response, you'll get better outcomes. Thank you very much. And I'll stop sharing my screen.
Divita Narayan, next.
A very good morning to all of you. I'm here to present on the World Cafe that happened on 8th of November, 2021 on electroacoustic stimulation. One second, I'm just setting up my, 1 second. I don't know how to get rid of this. So we had very eminent panelists on that day, and representing all the parts of the world, US, Europe, and Indian team. We had Professor Mohan Kameshwaran, we had Professor Mario Zanotti, we had Arthur Lawrence from Warsaw, we had Dr. Susan Walsman from US, and Professor Ranjit Rajeshwaran. What we discussed in the panel on that day, that what we learned, what was the recent past as EAS, as we called it, it used to be called as hybrid implant. It was limited to certain centers, which were mostly research-based. They always used short electrode array, and there was a fixed candidacy criteria, particularly for adults. And this was the candidacy criteria then. The 18 years of age or older, in the low frequencies, 500 hertz and below, no poorer threshold than 60 dB HL, and at the mid and high frequencies, worse than 75. CNC word score between 10 to 60% in the implanted ear, and in the contralateral to be 80%. Now, what learnings we did from the past? There was a loss of hearing in the long run with short electrode array. The outcomes were variable. The long-term followers badly required and can be hard. There was a deterioration in performance over time, and there was a need because of the loss of the acoustic part, and there was a need to reimplant with long electrode array, and not many clinics and centers could do it. So what was the timeline? If we look at the EAS timeline, there was a possible to save residual hearing, residual acoustic hearing in a subset of patients that prompted the design and study of various electrode lengths of optimized combined stimulation. The short electrode did show advantage in speech perception scores in noise and other conditions and more difficult situations. Performance of short electrode drops if acoustic hearing is lost, possibly necessitating reimplantation. At the same time, standard length electrode arrays started demonstrating hearing preservation capabilities. And so focus shifted with standard hearing electrode array to hearing preservation. So there was a need to redefine EAS. So when we can stimulate the auditory cortex successfully by electrical hearing and acoustic hearing with or without amplification. It can be with the help of acoustic amplification by the processor or without the acoustic amplification with natural hearing condition in case of good hearing preservation. And there was a discussion that there is a need to categorize or segment different types of EAS stimulation for better understanding of outcomes and benefits. The candidacy as well was redefined. Both adults and children can be used for EAS candidacy. Anyone with any amount of residual hearing in low and mid frequencies can be candidate for EAS stimulation. And speech testing, especially speech discrimination in noise, is needed than in quiet, because in quiet with cochlear implants, we are reaching the ceiling effect with cochlear implants. So to understand the benefit with EAS, we need to do testing in noisy situation. It can be used for SST. Any of the audiograms like this can be a candidate for EAS. Going back to categorization, the Warsaw group, Professor Kaczynski and what Dr. Arthur presented, they categorized the EAS based on hearing preservation in various categories, where they also demonstrated then preservation of natural hearing, natural electro, and they talked about that there's no need for acoustic amplification in those cases. And so they have categorized in these four, so to demonstrate a better understanding, because what was discussed was that if the hearing loss occurs in this category, then with a 10 dB or 30 dB in the category with the patient already having 60 dB, then there is not a candidate for EAS. Whereas even if a 30 dB loss occurs with original thresholds of 10 to 15 dB, they can be a candidate for EAS. So we need to categorize them. And they came up with a new nomenclature with electro-natural stimulation and partial deafness treatment for adults, and they have published data and a good hearing preservation that I'll be talking soon about. So basically, residual hearing benefits of EAS are there. The EAS system is designed for patients with a sky slope pattern of hearing loss. Initially, shorter electrodes were designed to reside particularly in the basal turn to avoid trauma, apical regions where low frequencies are generated. Minimizing trauma with atraumatic surgeries were introduced, and in addition, new electrode designs that are thinner and more flexible were introduced by manufacturers, both shorter and full length. Then there was a discussion about structure and hearing preservation. How does it matter? Does it change outcome? And how long in the long-term study? So these were some of the conclusions and discussions around it. So hearing preservation with ES time, we look at the timeline. So closer look. So there was a discussion for a closer look at patients who meet hybrid criteria. Observation with EAS use and impact on outcomes. Investigating the quality of residual hearing is very important and how relevant. How is residual hearing useful? What amount do we need? And how can we predict who are benefiting out of EAS, and how do we choose the array for the patients? So these are some of the discussion. And if we look at the various perspectives for successful hearing preservation, we can say that for surgeons, it is a marker for atraumatic insertion and structural preservation. For audiologists, better speech understanding and better speech perception. And for patient, it's a subjective benefit in complex listening situation with improved quality of life. And this is the data from Dr. Susan, who from NYU, who presented. They used only 532 electrode array, and they demonstrated good hearing preservation over the period of 12 months. And so this was encouraging. And some of the factors that were discussed, what factors that matters in hearing preservation, that was discussed was length and type of electrode array, the insertion, round window insertion, extended round window, or anterior inferior cochleostomy. There was a little discussion amongst the surgeon, but they all agreed with the round window insertion or extended round window insertion. Use of steroids were extensively discussed and is mandatory. Insertion depth, again, with the angle of insertion was more relevant. The steeper angle of insertion definitely demonstrated better hearing preservation. Wrapping factor is debatable because wrapping factor demonstrates the closeness or proximity of electrode array near modulus, but it doesn't. It definitely improves, and published data is suggesting that it improves the speech perception scores, but hearing preservation. So they can be intertwined, and it's a debatable topic. It is desirable, it was discussed, to have an intra-op monitoring of intracochlear potentials during electrode insertion. So surgeons in the group definitely recommended and demanded that it should be made mandatory. However, it is not available right now. So we looked at what industry has to offer us now. Short versus long electrode array, lateral versus perimodular electrode array, intra-op monitoring, drug emitting electrode array, electroacoustic processor. So we definitely have long electrode array these days. We are no more using, I think none of the centers are using short electrode array. There was a uniformity in the discussion for the use of long electrode array. There was a bit of a discussion around lateral wall and perimodular electrode array. Some of the surgeons group prefers the lateral wall, whereas the American group definitely talked very strongly about the perimodular electrode array and demonstrating hearing preservation in that. Intra-op monitoring of cochlear potentials were strongly demanded and recommended for hearing preservation. If we are going down that route, definitely should be available. However, it is not available readily. And of course, we do not have drug emitting electrode array, and we have electroacoustic processor offered by all the three companies. These are some of the electrode arrays that can be used for hearing preservation. And
how is this background going to come for everybody, na?
Yeah.
Once you log in that package, I think it will come.
Nishita, I can hear you speaking, so I'm sorry.
Yeah, so.
So these are some of the electrodes array available, and it is available with all the three companies. We have options for surgeons to use, and all the three electrode array has demonstrated hearing preservation. So we look at the surgical point, the surgeons had to say, and the round window. So definitely it was unanimous about round window insertion via gentle slit on the round window membrane. A soft surgery technique is extended round window cochleostomy identified by endosteum and opening that with a sharp needle that was discussed. Do not suction perilimb. Installation of steroids into scala tympani as well as systemic or IV steroid were discussed. Use of appropriate electrode array, what they are more comfortable with the surgical techniques, and very gentle and slow insertion of electrode over 30 to 60 seconds was needed. Control insertion depth and immediate seal of the cochleostomy. That these are the points that were discussed and was reiterated by the surgeons on the panel. Then coming to the audiological discussion, why EAS? So definitely it affects the sound perception with better amplitude envelope and fine structures. Temporal structures of sound are preserved. Low frequency acoustic stimulation promotes better pitch, tonal sound quality, and sound quality definitely improves. That was discussed. Then it helps. It is debatable bit about localization, but there are some studies that are talking about it. Speech recognition in noise is definitely demonstrated by various groups that has an advantage with the preservation of low acoustic hearing. And prosody recognition also has an advantage with the residual hearing preservation. Music appreciation and aptitude is also another key factor for in looking at outcomes. And preservation of cochlear structures to capitalize future advances in therapies. So these are some of the audiological reasons for doing a EAS. And if we look at the fine structures, we know that good speech recognition in quiet is achieved with cochlear implant, and we are able to provide amplitude envelope cues, and we are reaching a ceiling effect there almost. But to get them fine structures, which is important for speech recognition and noise, and melody recognition and music appreciation. That is what we are looking at. These are the areas of outcome measures that we should be looking at when we are talking about EAS. These are some of the data that was presented by Dr. Arthur Lawrence. And we had a little discussion around the Warsaw group by Dr. Kozenski. And so it was interesting discussion that they felt in their own big cohort, they felt that you can see in this graph that we are looking at percent correct with SNR variation, with the different SNR values. And if we look at CI with no residual hearing, they are at the bottom of the graph, and we look at the normal hearing, which are at the top of the graph. So basically we are looking at 50% correct percentage with the SNR required. So we can see that to get a 50% correct with us, we need a higher SNR for the CI with no residual hearing, whereas we can have a same amount of outcome with a lower SNR values. And the EAS group is very much falling in between. This is the data presented by Warsaw group by Professor Kozenski team, Dr. Arthur Lawrence. So that they demonstrated a great results with EAS, and they looked and they further categorized the EAS group, that you can see the various graph in between, and they were demonstrating good outcomes, that they are getting good percentage correct with a lower signal to noise ratio as compared to the cochlear implant group. However, none of them are as near to normal. So this is the data from that group. However, it was quite contradictory to the American data by NYU, which Dr. Susan presented, that patients who are not eligible for EAS did better, and some of the non-users. So she had in her data some of the non-user for EAS, and they do not prefer EAS. And the patients who are using standard electrode array and are performing as well as non-users, and some of the users EAS are demonstrating. However, she feels that there is a chances for rejection for EAS. And so some patients, what she talked about, that some patients are really liking it and some are not liking it, and they are preferring the electrical stimulation. So this was an eye-opener for us in the panel, that we always assume that EAS is going to get benefit. So that again further tells us that we should be considering a long electrode array, because the data, the long-term data are variable, with variable findings and variable results are coming from various groups across the and these are some of the reasons that she demonstrated for non-use. And one of the strongest reason was borderline thresholds, and definitely they preferred the electrical stimulation over the EAS stimulation. And other reasons that was demonstrated was Some of the patients liked off-the-ear processors and difficulty with equipment and fluctuating hearing and other factors were there. But borderline threshold was definitely one of the stronger reason for non-use of EAS, and which did not show better results as compared to only electrical stimulation. So overall, in her data, she talked about overall hearing preservation rates were estimated around 50 to 60%. The superior long-term performance provided by greater frequency coverage. So we want definitely a complete cochlear coverage versus short electrode may be preferable given patient who have hearing to appear and perform better in electrical only condition with longer electrodes. Comparisons are challenging. So then we also discussed about sound processor and programming software. We are fortunate to have EAS sound processor in all the 3 manufacturers, and we also have a good robust software working that we can program. So some of the other discussion that happened was what was the programming method, and overlap approach was unanimously selected because we can have acoustic and electrical stimulation both in the same region, that is low and mid frequencies, so that the patient's brain realignment does not happen and they are getting best of both conditions. So overlap approach was what was discussed. And last, if I conclude what is essential and desirable in EAS category of discussion that we had in the World Cafe, and we all concluded that these are some of the essential things that we need to know. Everyone with residual hearing in low and mid frequencies are candidates for EAS, both children and adults. Complete cochlear coverage, the long electrode array, is definitely, and short electrode is not recommended anymore. Surgeon can choose whether they are comfortable with lateral wall or perimodular till the time the hearing preservation and structural preservation is being met. Soft and atraumatic surgical techniques is recommended and is essential. And if not hearing, at least structural preservation should be looked at. And there was a discussion that every surgery, every child is going for, every adult is going, should be taken under EAS category. As much preservation it can be done is only going to be helpful and is essential. What are desirable in this are complete hearing preservation, which is a wishful thinking, but it doesn't happen. And we wish one day we come to a situation where we are able to do a complete hearing preservation. Robotic surgery was discussed because that can insert the electrode array at a constant pressure of stress or force, and that will really help in hearing preservation in this condition. That was discussed because human hands can vary and there are variability in that. EAS electrode and processor to be available with even the low cost implants, in looking at Indian perspective, because here we have EAS electrode array available only at high or premium products and not at the base level products, which is not very good. And because every child and every adult should have this advantage, and there's always some residual hearing. If you look at it and dig and dive deeper, there's always a residual hearing that can be preserved and structural preservation can be done. And all the children and all the adults who are undergoing cochlear implant surgery should get benefit for EAS electrode array. And every child undergoes a surgical techniques and of EAS. And the most desirable by surgeons and audiologists was intra-op ECOG monitoring available to monitor the cochlear potentials. That will be a huge jump which should be available, and it's desirable to have so that we can have, on the table, we can understand how much hearing preservation we have done, and we are much more informed about the post-operative information. And that's all. This is what we concluded. Thank you very much for giving me this opportunity.
Thank you, Nimita, for summing up the recommendations on EAS. So now I would request Bhanumati to present her findings of this World Cafe on multilingualism and cochlear implantation. Bhanumati, you can start sharing your screen and.
Good morning, sir. Good morning, the organizing team of CIGI and CIAN and the scientific committee. Thank you so much for offering me this opportunity. I think the screen sharing has to stop. I can see Nivita ma'am's.
Nivita, can you stop sharing the screen?
1 second. I did stop. I don't know how it. 1 second.
Anil, can you just check this?
Okay. I got it.
Yeah.
So I'll share my screen.
Yeah.
It's not happening.
Yeah.
Just give me a minute, sir. It's not happening. I don't know. Sir, I'm not able to share the screen. I don't know
What's
what
happening.
Security and access.
Anil?
Bhanumati, you may restart your laptop and try it once, I suppose.
It says some security issue or something from your end. I don't know. Do not know. Sir, I'll get back. Do you want to go ahead with another presentation or?
She's not able to share this next one. Okay, I think we'll go to the next Dr. Monish Grover. Dr. Monish Grover, you can share your screen and go ahead with your presentation on CI in cochlear anomalies, and we'll come back to Bhanumati later.
Sure, sir. Thank you.
Yeah.
Okay. Is my slide visible, sir?
Yeah.
Okay. So good morning, everyone. And thanks to the organizing committee and CIGI for giving me this opportunity. We had our World Cafe on the 9th of this month, and we discussed cochlear implant in various cochlear vestibular anomalies. Okay. I'm going to change the slides. That's not right. Okay. And 11 of us from 4 different continents got together, and whatever I'm going to talk about in the next 12 minutes or so is the discussion which we all had and the recommendations based on that. Okay. Just a disclaimer that it's not supported by any pharmaceutical company, and also the fact that Dr. Amit Kishore had a separate World Cafe on cochlear vestibular nerve anomalies. We are not going to discuss that aspect in this particular presentation. Now, to know what's really abnormal, we need to define what's normal, and we actually discussed various parameters to come to a conclusion as to what we should consider as abnormal, and the various literature was searched on this. So what's normal? A cochlea with a 2.5 turns with more than 25 millimilli length is what's essentially considered as normal. For it to be called as a hypoplastic cochlea, a basal turn length of less than 7.5 millimeters and a mid-modular height of less than 3.42 millimeters, and a cochlear duct length of less than 25 millimeters is what constitutes a hypoplastic cochlea. Coming to cochlear aperture, normally it's more than 1.5 millimeters. If it's less than 1.5, it's considered to be stenotic. Internal acoustic canal, 2 to 8 millimeters is normal, less than 2 stenotic, more than 8 is considered to be enlarged. Coming to the dimensions of the cochlear nerve, a normal dimension would be somewhere around 1.1 to 1.4 millimeters. If it's 0.2 to 0.6 millimeters in absolute terms, it's considered to be hypoplastic. and it's obviously when it's smaller than diameter of facial nerve is again considered to be hypoplastic. A vestibular aqueduct should be less than 1.5 millimeter at its midpoint to be considered as normal. I'll discuss this in detail as we go ahead. It can also be compared to the adjacent portion of posterior semicircular canal. And this is the literature which we really went into for deciding these numerical parameters. Now, coming to malformations, late 1700s, Carlo Mandini actually dissected a bone of a 8-year-old child who was born deaf, died in an accident, and discovered the anomalies which were present. And he described the 3 anomalies of Mondini's dysplasia. Sadly, for the next 2 centuries or so, everything abnormal in the cochlear vestibular region was considered as Mondini's dysplasia. In 1987, we had the first classification by Jekyll et al. Based on developmental arrest, and we had the Phelps classification, we had the Zeng classification, and finally the Sinoroglu classification. We also have a classification in our own, from our own country, from my own institute, and we based it on cochlear morphology, modulus, and lamina cribrosa. However, for the purpose of recommendations, out of all these classifications, the one which is most acceptable right now is the Sinoroglu classification, and the final version, which came out in 2016, looks something like this. And we want to discuss various terminologies and the outcomes and the surgical things. So this is the classification which we'll be using. Now, all of us actually decided on some definitions to really include in this recommendation guidelines. So the transmitted perilymph pulsations is the term which we are going to use, that when you open the cochlea, a pulsatile perilymph is seen. No active egress of fluid outside the cochlea is however present. In case of CSF ooze, on opening the cochlea, a mild intermittent leakage of perilymph and CSF into the middle ear is seen, which is easily controllable. And in case of a CSF gusher, it's called as gusher when there's a high pressure free flow of CSF filling up the middle ear cavity, which is tough to control. Right, so coming to investigations, radiologically, we need to have essentially HRCT temporal bone and MRI temporal bone in brain both when you're dealing with malformations. A temporal bone CT scan would be ideally a 64 slice one, having both axial and coronal sections, the slice thickness being 0.4 to 0.6 millimeters. In MRI, we would require an axial, coronal, and oblique sagittal images, especially heavy T2 weighted images. 1.5 Tesla, if you're using it, would be best to have surface coils. Desirable will be when you have an MRI temporal bone of 3 Tesla. It's the best thing, especially when you know that you may be needing ABI in few of these patients. A good MRI is something essential because you may not be able to do it later on. Similarly, MRI should be done under general anesthesia desirably, and you should calculate in the cochlear duct length to differentiate and to calculate the various electrode lengths which you may require. Audiological investigations, essential ones would be, as for routine in evaluations, a tympanometeor emittance, otocaustic emissions, ABR. Now, the other thing which become more important is good audiological input, because many a times we don't know if the patient will really do well with a CI or an ABI. So a BOA, a hearing aid trial with an aided audiogram, and patient progress report questionnaires are really essential. It would be desirable to have an aided ABR, aided cortical potentials, and TT ABRs in few cases of severe cochlear malformations. Many institutes may not have this, and therefore it's not essential really to do it in all the patients. Intraoperative audiology, as for normal, we do impedances and ECAPs, but it's important to remember that we may not have ECAPs in many malformations on all the electrodes. However, they're usually present in LVA and IP2. And ESRs come into picture essentially to be done if ECAPs are not obtained, and it's a good sign if ECAP is present. However, it may not be present in severe malformations again. It is desirable to have intraop ECOG and intraop implant EABRs in your operation room so that they can be done if required. Genetics, essentially, no, never. It's not considered to be essential. However, there are few malformations associated with few particular mutations. It's desirable to do a targeted gene panel or whole gene exome sequencing as per your institute's plan. There are various associated syndromes which will be present again, and developmental evaluation is important. We actually, had this tabulated form, and in the interest of time, I won't really be going to details of every malformation and associated syndrome or the genetic mutation, but this will what we plan to put up in our published or printed guidelines which we have. Vaccination, essentially similar as routine vaccinations, pneumococcal and hemophilus required for the countries in endemic areas of meningococcal infections. it would be desirable to have a meningococcal infection also being given as per the protocol followed. Now, coming to various individual anomalies, vestibular anomalies, when you talk about the first thing, the semicircular canal anomalies, if present, the surgery goes uneventful. The facial nerve is normal in position usually, but may vary again. Electrode can be, any of the electrodes can be used, full banded, half banded, lateral wall modulus, hugging. Outcomes are usually normal. Importantly, two things. If you have a semicircular canal or vestibular anomaly, look out for cochlear nerve canal stenosis. And if the lateral semicircular canal is hypoplastic or aplastic, the tympanic segment may be superiorly dislocated. So that's what you need to remember for semicircular canal anomalies. Other vestibular anomaly, we all know one of the most common anomaly would be a large vestibular aqueduct. And when you're dealing with a large vestibular aqueduct, the criteria, the most accepted criteria right now is the Valvasori criteria. That's more than 1.5 millimeters at the midpoint. The other criteria like Cincinnati criteria and Wilson's criteria are not that commonly used and not that well accepted also. When you diagnose it, essential to evaluate the patient for a Pendred syndrome, that thyroid needs to be evaluated. Surgery usually goes routine, transmitted perilimb pulsations are seen and all electrodes can be used. The facial nerve course is normal and the outcomes are pretty similar to children with normal anatomy. It's desirable to advise these patients to avoid contact sports, and also they should be given steroids whenever the patient experiences sudden loss in hearing so that it may be possible to recover the same, right? So that these two things are desirable when you're dealing with a patient of large vestibular aqueduct, which needs to be counseled with these patients. Incomplete partition 1, essentially to define that, you should have an absent modulus and septa, cystic kind of a cochlea. You may have a wide cochlear aperture and deficient lamina cribrosa. It actually resembles cochlear hypoplasia 2 a lot, just that it is longer than a cochlear hypoplasia 2. Important thing to remember is CP's footplate defect can be associated with IP1, leading to spontaneous CSF otorhinorias or recurrent meningitis. So that you need to be careful when doing surgery also. You need to use only non-modulus hugging full banded electrode arrays, right? Because you don't know the really location of the neural elements in this kind of an anomaly. Intraop X-ray is essential, and there are high chances of CSF gusher as per the existing literature, approximately 50%, and therefore it would be better to have a bigger cochleostomy so that it allows you to do a tight sealing around the peri-electrode space. Outcomes variable. And the children actually start improving late and they plateau down earlier. And many a times patients have undergone ABI after a CI in IP1. Now it's desirable that you do an electrode insertion under fluoroscopic guidance in IP1. Special techniques, again, desirable if required in that particular case, could be using special electrodes, which are developed for controlling CSF gushers, threading the electrode array through soft tissues, using tissue glues, and in the worst scenario, subtotal petrosectomy. Then you come to IP2. So modulus and septations are defective in the upper half. That's how you define it. And if you're talking about Montanese deformity, please do not use the term interchangeably with IP2. It should have a dilated vestibule and EVA associated with it to be called as Montanese deformity. These patients are known to have a progressive hearing loss, just like large vestibular aqueduct. Sometimes even conductive hearing loss may be present due to the third window effect of EVA. You usually have a transmitted perilimb pulsations. Sometimes a CSF ooze might be present and rarely a gusher in 6% of cases has been mentioned. All electrodes can be used. Facial nerve course is usually normal and outcomes are pretty similar as normal kids. IP3, absent modulus, intact septation. This is what it looks like. Always associated with a wide cochlear aperture and deficient lamina cribrosa, and usually have good cochlear nerves. They have X-linked deafness. Mixed hearing loss is common. But unlike hypoplasias, we don't do stupidotomies because that would lead to a massive CSF gusher and sensorineural hearing loss. If the hearing loss is not severe to profound, you go with hearing aids. If it's severe to profound, you go with the cochlear implants. Now, non-modulus hugging electrode would be the best, right? That's because, again, the neural elements are located laterally. Full banded electrodes are required and high chances of misplaced electrodes into the IAC. So therefore, intraop X-ray is essential. Always associated with CSF gusher in all cases. So bigger cochleostomy tight sealing, as you mentioned, for IP1 cases. Outcomes variable, better than IP1, and slow but significant improvement is there. Desirable thing for CSF gusher remain the same as for IP1. Interestingly, lately the various literature have come up which mention hypothalamus abnormalities in MRI. So that can be, desirable to look at. However, no hypothalamic functional issues have been found till now. Cochlear hypoplasia's definition: basal turn length less than 7.5 millimeters, mid-molar height less than 3.42, cochlear duct length less than 25 millimeters. That's a definition for cochlear hypoplasias. We have 4 types, right? And these are how they exist as. And therefore, for definition purpose, this is the table which we actually used. For our own ease, you can actually identify that cochlear hypoplasia looks like a big rudimentary otocyst with existing internal acoustic canal. Cochlear hypoplasia 2 is like a shortened IP1. Cochlear hypoplasia 3 is like a shortened normal cochlea by 1.5 turns. Cochlear hypoplasia 4 is a normal basal turn with middle and apical turns shortened and anteriorly placed. Yeah, the most interesting clinical presentation: hearing loss can vary from normal to profound, can be conductive to sensorineural. Important things: CH2 behaves like IP1 with a stapedal defect and therefore CSF otorias. CH3 and 4, they have stapedal fixations and may benefit out of a stapedotomy itself. Cochlear nerve deficiency is frequent. While doing surgery like a cochlear implant, the promontory is flat and round window visualization is difficult. Short electrodes are better off in CH2 and CSF gushers. Short electrodes are better off in all the cochlear hypoplasias, and CSF gusher is something which is expected in CH2, and facial nerve anomalies are common in this. As in common cavity, is essential that you define it as there's no division between cochlear and vestibular parts of the inner ear. The IAC enters the cavity in the center. The surgical tips would be: obviously you don't require a posterior tympanotomy, do a transmastoid labyrinthotomy. Non-modular hugging full bend electrodes to be used, and facial nerve anomalies are possible. Need to be prepared for CSF gusher and a U-shaped insertion, so that you can have the electrode around the lateral wall and not going into the IAC is good. Intraop X-rays essential. Outcomes variable: start late, plateau down earlier, may not do really well. Desirable to do under fluoroscopic guidance, and special electrodes with individualized length calculated by 2 pi r, the r being the radius of the cavity, is something good to have. The 3 things: rudimentary otocyst, just a small cystic structure without IAC, cochlear aplasia, and complete labyrinthine aplasia are absolute indications for ABI. Just a slide on facial nerve and inner ear malformations. The labyrinthine segment is the most commonly affected facial nerve segment in anomaly. IP3, you have a superiorly displaced labyrinthine segment. CH4, you have a mild anterior superior dislocated labyrinthine segment. Tympanic segment, the lateral semicircular canal actually prevents the superior dislocation. So if it's absent, as we mentioned earlier, that it could be actually superiorly dislocated tympanic segment. Cochlear hypoplasia usually have an inferiorly dislocated tympanic segment. Mastoid segment, the cochlear hypoplasias are the severe inner ear malformations. You have a narrow facial recess. And cochlear hypoplasias, all segments of facial nerve can be affected. So we need to remember that. IP1 and 2 rarely have any facial nerve anomaly. And the question which we discussed was, does it make sense to have funding for inner ear malformations in emerging countries? Because these recommendations are all for the emerging countries and not just our country in India. Essentially, we thought partial funding could be done depending on the type of malformation, and the patient share needs to be put into this, again, which depends on the local prevailing conditions. It's desirable, however, that would be completely funded if the economic conditions improve thereby. Thank you all for your patient listening.
Thank you, Monish, for excellent summing up. So I request the next presenter, Mrs. Nishita Mohandas, to give a guidelines on mapping in difficult situations. Nishita, you can share your screen and start your presentation.
Yeah, good morning, everybody. Thank you to the OC for giving me an opportunity to present Mapping in Difficult Situations in the World Cafe, which was held on 9th of November. Why isn't it not going forward? Yeah. What is a difficult situation and how do we deal with it? A situation is difficult when you do not know how to handle it. Maybe you don't have any other options. It gets you by surprise. It's a situation which you do not like. For example, new technological implementations, like in our case, the cochlear implant. So the burning question to the faculty from my side was, tell me how you would deal with a difficult situation and whether it was desirable for you to keep a positive attitude when you dealt with it. So I had some very eminent and good panelists from across the world and from India. And only one panelist, Dr. Helen Cullington, could not be available as she was unwell. So how I deal with the mapping situation, and then after that, the group discussed and came on a common consensus, and then we shared it as a global solution. On the request of the group, because the situations or the cafe or the topic which I was given in was rather unusual because each case was different. So we couldn't have a step-by-step, set pattern. So we asked the group to share their summary of what they had done in their presentation. So coming to the first presentation, Professor Gonka Senelgu, her case was single-sided deafness and cochlear implant. We all know that binaural hearing helps sound like localization. It helps in speech understanding and noise, and increases communication abilities and better quality of life. But the challenges for a pediatric population was that when you try to do a CI, it is very hard to bypass the normal hearing ear and perform any kind of test. Also hard to set TNC levels and to do free field testing to see what is their performance. So what solution was suggested was there should be a subjective measurement of the observation of the clinician, the family, the teacher is very important. Slowly and gradually increase the daily usage. And you should ask experienced clinical audiologists to perform testing. A global solution suggested by the group was that you need to decrease the age limit for these categories to less than 5 years of age, and you need more studies in the literature. So the next was a case presented by Dr. Meredith Holcomb, and she presented on unresolved facial nerve stimulation. So a patient came and he presented with symptoms similar as superior canal dehiscence. So there was low frequency conductive hearing loss, tinnitus, dizziness. CT scan was done to access the third window effect. So in cases where CD is not visible on a CT scan, then cochlear facial dehiscence should be ruled out as well. And the electrode choice is very critical if CT anomaly is observed. Vestibular testing is also necessary. Post-implant, what they did was they attempted various programming parameters to alleviate FNS. They changed the pulse width, rate. They tried different mode of stimulation, bipolar, common ground, and monopolar. And wherever there was stimulation, they tried to disable the affected electrodes. Also, an integrity test was essential to confirm the device functioning. Later, a post-op imaging was done when the FNS was not completely resolved. They tried to monitor FNS during the programming, and because Meredith also involved a team approach. She spoke to different people in her team, right from the surgeon, the radiologist, and other audiologists. She took second opinion from somebody else, and she continues to ask questions and search for answers because this stimulation wasn't resolved and the patient became a non-user and unfortunately expired last year. So the next presenter was Chandan Saha, and he presented on map where he had to reduce rate. And in this, the typical population was adults with history of long deprivation. And atypical population was child who showed intolerance to NRT-based map even after 7 months of switch on, and his showing signs of auditory fatigue and irritability. So what Chandan did was, he established a stable map based on a low dynamic range, where there was the sound perceived was initially very unclear, the perceived speech, and there was intolerance of pain at sea levels. So the rationale was that consistently the direct stimulation led to better modulation detection thresholds than higher rates at lower levels below 50% of the dynamic range. There was better noise tolerance, especially for soft speech. And the other solution suggested by the global experts was to try maps based on ESRT. Next was Dr. Hiramba Ganpati, who is now located in UK. He was initially from SRNC Chennai. So he presented a very unusual case where there was tinnitus after cochlear implant surgery, and it was affecting this 52-year-old female. She was becoming a non-user. Pre-surgery, she had tolerable tinnitus for 10 years. She had a progressive hearing loss and a successful hearing aid user. And here, in her case, a revision was required to ensure full insertion. Post-implant, during the episode, downed and intolerable tinnitus after subsequent mapping, leading to non-use of the CI. And several modifications were tried, including change in pulse width, stimulation rates, switching of few electrodes. Even tinnitus retraining therapy was started, but the problem did not change. And after a team discussion, the tinnitus matching was done to identify the pitch percept at, so they found it matched at 2K. Mapping levels were gradually increased, keeping lower levels of electrode current level around 2K. Again, TRT was tried and ENT treatment continued. Today, the patient has become a successful wearer of the cochlear implant. So lessons learned here is tinnitus matching can be used to identify the triggering electrode for the cochlear implant, and working around the current levels of electrode to match pitch percept can elevate the tinnitus. Coming to the next situation presented by Professor Manjula. The problem she encountered was frequent changes in electrode impedance on few electrodes associated with map change requirements, and performance also was changing. It was associated with slight but steady increase in ground path impedance. So malfunction of the device was suspected, and there were a working diagnosis on device malfunction was made based on combination of impedance, map level, subjective perceptions, and performance over time. The child also had an additional problem of autism spectrum disorder, and he was unable to cooperate for formal testing. So the strategies tried here was disabling the problem electrode, changing map parameters such as duration, pulse width, reducing M and C levels. And other solutions were change in impedance is not reflective generally as a device malfunctioning. It is important to look for longitudinal changes and compare the changes with the typical course of the impedance changes. Initial management for this problem is to include disabling the affected electrodes, making programming changes, and such strategies, if they do not bring a change in the child's performance, then reimplantation was warranted in consultation with the company. And a failure to diagnose a malfunction could result in reduced performance. So this situation should be avoided. Coming to the next, Nakshi, she presented a case on fluctuating psychophysical levels due to fever and upper respiratory infection, middle ear infection. So pre-surgery, we know that children in that age group are prone to such infections. So prior surgical or medical intervention is recommended. In case of malformed cochlea, type of electrode is very important. So post-implant, during the episode, a complete medical checkup, including complete blood workout to rule out any medical issues, even autoimmune disease, radiological evaluation to rule out conditions like labyrinthitis, medical treatment like a dose of antibiotics, and mapping session, you check impedance telemetry, implant telemetry, audiological evaluations like implant threshold and speech perception test. You remeasure the psychophysical levels, and there is a frequent follow-up. And a tip that whenever the child has a cold or upper respiratory infection, do not do mapping at that point of time. Let it settle and then call the child for mapping. Shashi's case was very interesting. He had a child 3 months where they already found that there was visualization of the auditory nerve on the MRI, and they were wondering whether an audiological test battery approach can provide any information about the presence of the nerve. Providing a map well above the general map profile of children did not give any sign of auditory response. So they did not want to take the risk of stimulating at very high levels, which might lead to further degeneration of the inner ear function. So how did he optimize the map? So he used tone burst ABRs at high levels, and contralateral separates were used where some reflexes were present at maximum levels in at some frequencies in both the ears. The presence of the auditory nerve in both ears was confirmed about these objective findings. So they did not have to use the TTE. And the child went cochlear implantation at the age of 10 months, and in the left ear at the age of 1 year, 3 months with the metal implant. And then they used ESRT and outcome assessment to optimize the map in this child with hypoplasia of the auditory nerve. Now, what he has said is that ECAP was absent in both the ears, intra-op and post-op. Hence, he had no hope about the presence of ESRT, but ipsilateral and contralateral stapedius reflexes were elicited across all the 12 electrodes in both the ears. The lowest ESRT values were taken for creating the map. But upon continuous stimulation, the ESRT would disappear. So he had to give a delay of approximately 3 seconds between stimulation presentations to obtain the ESRT. And a good correlation between the ESRT and MCL level is now an established factor. Also, they looked at the behavioral response, the APR, the listening skills, the video recording was done, a speech therapist report and parents report to set the MCL. So what is a take-home message? Contralateral stapedial reflexes at high levels and tone burst ABR at high levels might give some information about the presence of the auditory nerve. You have to monitor the progress at regular intervals. ESRT, if present, can give you valuable information to set the map profile and provide sufficient delay between the stimulus presentations during post-op ESRT measurements in children with hypoplastic auditory nerve. And the last presentation was by Rajesh, my colleague at Hinduja, and he had presented this study way back in 2009, where there was increase in electrode impedance over a period, reference electrode impedance in cochlear implant patients. So electrode impedance is a critical parameter for proper functioning of the cochlear implant system, the battery life, and for better outcomes, especially if monopolar mode of stimulation is used. And the increase could be a technical status of the electrode migration. The tissue conductivity and current distribution is due to the growth of the fibrous tissues and bone growing over the electrode, especially in small children who were implanted at an early age. We don't know whether the shape is of the surface area or the reference ball electrode in cochlear device or the clover-shaped electrode in the metal device is responsible for this. Now the Cochlear company has come up with a pin type electrode which can be placed easily on the bone surface of the temporal bone under the fascia temporalis muscle. Now the CI manufacturers have come with a new design whereby instead of having 2 lead wires, there is only 1 lead wire which has all the active electrodes as well as 1 ground or reference and another reference electrode on the receiver stimulator package. We do not know whether this design can help the issue of progressively increasing impedance values and how will we measure it. So the solution tried was in cochlear device, it is possible to change the stimulation mode and try to optimize the map parameters. Surgical management in situations where fitting parameters are less than optimum due to migration, then careful replacement of the reference electrode may result in decreasing the electrode impedances and ground path values, enabling faster processing rates and use of more active electrodes. So what we have learned from this is that at each fitting, collect telemetry values and observe if there is an increase in the reference electrode and keep a close watch, and follow-up interval in this case should be shortened. You have to inform the recipient and the family, counsel them appropriately, discuss with the team, do necessary radiological evaluation, and after the stabilization of values is obtained, then follow-up sessions may be set on a normal interval pattern. and also explain the risk of exploration and repositioning of the reference electrodes. We need to we need to prepare the family for an explant of the implant and immediately reimplantation if required with a new implant. So here the global solution is that small children, there is bone growing over the electrode as a result of a lot of bone remodeling. They are growing. More studies are needed to find out what is the incidence of this problem and what happens in those who have been implanted very early. So after this, I think most of the recommended practice guidelines, we don't know which were desirable and which were essential. Basically, we'll have to actually sit down and make these protocols sooner than later, because we all believe that the path we are dealing in is not a straight line, rather it's a spiral. We continue to come back to things we thought we understood, and we come and see more deeper truths in this. All of us, including the panelists, believe that, you know, if we apply our brain and our heart to this problems, we will find a solution, a light at the end of the tunnel, because for every problem there is a solution. You just need to find the right key. And also you need to be backed by a good institution, a good team leader, a good team who believes that failure is an opportunity to grow. They push you into a growth mindset. They ask you, don't quit, just do it. Thank you very much.
Thank you, Nishita, for that wonderful presentation. Now I call upon Dr. Aparna Nandurkar to give her presentation on mainstreaming and cochlear implantation. Aparna, you can share your screen.
Yes. Thank you.
Welcome.
Yes, good morning all. At the outset, I would like to thank CIGICON and GCIN2 for giving me this opportunity to moderate the World Cafe. Our topic was mainstreaming and cochlear implantation, and this cafe was held for 2 hours on 9th of November. Now, when we look at the basic tenets of a World Cafe, it basically believes that together we are wiser, and through conversations that matter, we can shape a lot of things. So keeping these two things in mind, we had a lot of conversations about educational mainstreaming. And I had excellent participants for this World Cafe. I had Anuradha Bantwal, Dr. Anuradha Sharma. I had Dr. Dalia Mustafa Usman from Cairo, Egypt. I had Shefali Shah, who's practicing in India and UK. I had Dr. Kalyani Manke, Ms. Vaishtai Dabu, Dr. Sue Archbold, Rashmi Deshpande, and Ms. Leena Vishwakarma. So we had, people with a lot of experience, stalwarts in the field of education and cochlear implantation. So what we did is we had a lot of conversations about topics related to mainstreaming and cochlear implantation, starting right from the basic question whether mainstreaming is viewed as a goal or it is an outcome. And then we discussed related areas like assessment of readiness for mainstreaming, how can we engage various stakeholders associated with this issue, what are the challenges that can be faced by mainstream children and how we can go about handling those challenges, how do we monitor children who are already in the mainstream. We also did look at some of the existing guidelines, laws, policies, and resources, and also looked at what guidelines need to be recommended about this particular topic. So the first thing that comes through from our discussion is definitely that mainstream education cannot be the option for every child with CI. And this was supported by a lot of discussion. First and foremost, feedback from caregivers consistently places education at the top of their priorities and concerns for their growing child with hearing loss. What happens today somehow is advocates of cochlear implantation strongly recommend inclusive education for all children. There is somewhere an assumption that cochlear implantation is going to make education simpler and the child is going to be in a mainstream education. However, one size does not fit all. So we cannot equate cochlear implantation with mainstreaming. More so now when we see that there are a lot of children with complex needs being implanted. There are late implantees, there are those with associated impairments. So what we can do and need to do is, as professionals, influence the messaging that is going out about mainstreaming. It's not an outcome. It's not a goal for every child with CI, but rather we should view it as an outcome which follows through from the work that we do with the children and from the school readiness. And there is a consideration that a child with CI, when he is in a special school or in a non-formal education setting, it is considered as being stigmatic, not only by the parents and the family, but even professionals somewhere today consider it stigmatic. So we need to get away, go away from that concept. Now, when we look at guidelines, there are guidelines which exist for mainstreaming, which child goes into mainstreaming education, which child does not. But often our decisions practically are governed more by geographic and financial constraints rather than strictly the clinical factors in the child. So decisions should be specific to a given child, considering the factors that are associated with that particular child. The second main thing which evolves from our discussions is that flexibility is the key. The needs of children, educational needs, and even other needs of children differ at different times during development. We are all aware that there are several transition times in the periods of development, so different education settings may be needed at different times. So we need to be flexible about that. Not only that, it's very vital for us professionals to provide support and information to the parents during these crucial transition times. Flexibility is the key so that learners can choose their learning trajectories according to their abilities and interests. And as stated in the National Education Policy 2020, recognizing, identifying, and fostering the unique capabilities of each student by sensitizing teachers and parents to promote holistic development in academic and non-academic spheres. So yes, multidisciplinary and holistic education should be the approach for every child, and development and awareness about this needs to be developed among all the concerned stakeholders. Now, if we have a child who is mainstreamed, after assessing all the factors, then at the level of the mainstream school, we would like to have certain things so that the child is able to perform his best. So highest priority should be achieving fundamental literacy and numeracy as early as possible, especially in those with complex needs. So the schools also should be sensitive about the needs of the child, especially regarding the mode of communication required. So here we also did discuss that we are always expecting oral mode of communication from a child with cochlear implantation. But it can happen that children will require support from other modes of communication. So this awareness needs to be created. Now, while we are placing a child in mainstream, generally the grade is chosen according to the chronological age of the child, which is not appropriate because it should be the child's language level that should be the deciding factor. And there is research which suggests that children who demonstrate age appropriate development or whose development is within few months of their peers are ready to be mainstreamed. Now, teachers in the mainstream school need to be trained in the subtle aspects of child language development to facilitate identification of associated as well as learning issues. At the mainstream school, we would want to have focus on IEP, which should run parallel to the general curriculum programs, and to put in place an individualized family service program, which will provide the much needed individualized attention to every child and its unique needs. Now, periodic monitoring of the child in the mainstream setting is a must. Now, of course, there are various aspects to this, and no clear recommendations can emerge in a very short, discussion like 2 hours. So, who does the monitoring of the child in the mainstream? How often should it be done? What tools to use? These are some of the questions that we need to address. And then we also deliberated a lot on the strategies that can be used in the classroom by the mainstream teacher. And some of these are well known in the literature: prior preparation of the child at home, note taking, buddy system, giving time to answer, clearly identify the requisite sub skills for teaching or learning of a particular topic. And basically what emerged here is good teaching practice for our children with hearing impairment or cochlear implant is good practice for all. So some of these strategies can be utilized not only with the child with CI, but every child in the classroom can benefit with it. Having teacher aides in each class, will not only benefit the child with special needs, but also other children. All support staff, in addition to being trained in the management of assistive technology, must also have training in developing and maintaining spoken language skills in those children for whom spoken language is the choice of communicative option. Now, some attention also needs to be provided on the social emotional development, socialization, self-esteem of a child with CI who is in the mainstream school. Now, if this child is the only child with CI in the classroom, he has no opportunities to meet other children with CI. So these should be provided. Having a team of social workers or coordinators who monitor the child's and family's progress periodically will help, and these social workers or coordinators can then be the go-to persons when the parent or the child is facing issues. Technology management is one big issue that we need to discuss about, or we need to look at. Managing technology in the classroom is very difficult. So we ought to be driving the industry to make it simpler. The focus here is on technology being clinic-based or therapy-based, but the focus needs to shift from it being therapy or clinic-based to being education-based. Appropriate programming of the device, extremely critical. Use of ALDs wherever possible in the mainstream classroom or with the child. School authorities and teachers to fully accept the technology and the responsibility that comes with, because we have often experienced that parents have to fight, about taking up the responsibility. Support staff to be trained in handling and management of the technology that the child is using. Acoustic environment that the child is in when in the mainstream class. We see that there are a lot of challenges that the child undergoes while in the classroom, because often we have children with unilateral CI and there are more number of children in the class, the noise and the reverberation and other aspects. So there are efforts required to improve the classroom acoustics. And first step is creating awareness among the teachers and other personnel in the school about importance of the acoustic environment. Higher signal to noise ratio benefits not only the child with CI in the classroom, but we also have research which says that hearing children also require higher SNRs as compared to adults, which helps in learning effectively. Also, teachers will benefit with a quiet teaching environment. So we are all aware of the various strategies to improve the acoustics in the classroom. Assessing readiness, that was other area which we discussed, and we know that we need decision-making tools to ensure that the child is in the right place. But do we have appropriate tools? So we did discuss some available tools, but we have not been able to recommend a single tool. Because mainstream is not always the right place, we need to use these tools judiciously and appropriately. We often also see that when we are talking about readiness, the focus is only on assessing the child's school readiness. But we also need to have some tools or checklists to assess the readiness of the family as well as the receiving school. And then we talked a lot about parent empowerment. So we need to, right from the outset, right from the point of pre-CI counseling, work on parent expectations. So thorough preparation of the parents for developing appropriate and realistic expectations regarding the child's education and long-term achievements. And this counseling cannot be viewed as a one-time process, but it should be done during all the transition periods at every stage. And we need to empower parents to make the right decision about school placement, beginning by providing them with all the possible options. Research has also showed that parent-child interaction scores are positively correlated with language level and school performance of the child. So it's very important for us clinicians to foster rich parent-child interactions. Parent groups will play a very important role, especially in promoting advocacy. And like we have buddy system for children, we can also foster buddy system for parents. Then we discussed a little about the legal provisions. We know that there are various laws like UNCRPD, Right to Education Act, Rights of Persons with Disability Act, and now the upcoming National Education Policy. So we often see that provisions such as those under Sarva Shiksha Abhiyan 2009, they are not meaningfully implemented. We need to take steps to make the government authorities fully understand that the implications of including a child with hearing impairment or CI in mainstream classroom vis-a-vis children with other impairments like a child with visual or orthopedic impairment, they are not the same and they cannot be equated. Then we also know that National Education Policy 2020 is going to be implemented soon. So we as professionals have a major role to play in making meaningful recommendations as the guidelines and the rules are being formed now. And then we also need to go with the sustainable development goals which stress that leave no one behind. However, here we discussed one major issue that when we look at education, it is an issue which is handled by the state government. And when we talk about regular schools or we talk about special schools, they are coming under the Ministry of Social Justice and Empowerment, whereas regular education is governed by the Department of Education. So what happens is there is no dialogue between the two and a strong need is there to bridge this gap. Plus, when we make any recommendations to the government, our approach should be to focus on learning needs of all the children, not only children with CI. So then it can have a global or universal as well as a national application. However, there are more things for us to do as clinicians or as professionals. Promote universal newborn hearing screening to facilitate early identification, intervention, early implantation, which in turn can promote mainstreaming. Clinics must address the development of social skills in the children they recommend for mainstreaming. We observe often that once a child gets into mainstream school, the therapy is discontinued because the academic pressures are too much, but this in turn puts the child at a major disadvantage. There needs to be provision for itinerant teachers, and these teachers should also be trained in classroom acoustics and technology management. We observe often that more challenges emerge as a child enters in the higher classes or the secondary school. So at these transition times, there is more need to provide attention to mental health and other teenage and adolescent issues. Periodic monitoring of the various aspects of the child's performance is essential. Team approach is very, very important for holistic development of the child, but this is lacking at times and we need to put a more focus on that. More focus on vocational assessment and guidance to be provided at an early age, not wait until the child is little older, but start this right from the beginning. There is provision by law to accept a child with disability in mainstream, but we often see that valuable time is spent by parents in fighting the system to get the child accepted. Okay, so we need to improve the dialogue between parents and the mainstream schools. But not everything can be done at the level of the mainstream. We have to empower special schools too, where they can be provided with annual targets to mainstream an increasing number of children and support them through the process of mainstreaming. Need for more trained professionals to work with children with CI, because limited number of professionals means that we are sacrificing on good parent counseling. So there is a need to strengthen our end before we strengthen the mainstream schools or the teachers there. We also discussed that under National Education Policy, there is going to be continuous comprehensive evaluations, and we as professionals can develop tools for this and hand them over to the regular schools. It's important to foster total communication in children with CI in the mainstream because they have something to fall back on when the technology fails. So to conclude, I think we all discussed and said that there is a need to develop a lot of resources such as parent training booklet, awareness booklet for teachers, modules for teacher training, modules for training of support staff, tests or checklists for assessing readiness of child, family and school. And members from this World Cafe have shown their willingness to get together and connect and work on development of some of these resources. So I would like to conclude by thanking CIGICON for this experience.
Thank you very much, Aparna. That is an excellent compilation. So we call upon now next Dr. Asha Itiraj to give her thoughts on this World Cafe on auditory neuropathy spectrum disorder. Asha, you can start sharing your screen and go with the presentation, please.
It's saying good. I'm just trying to share my slide.
Yeah.
Oh, I don't know. It's just telling me to quit. 1 minute. Just give me a minute, please.
Yeah.
I think she's sharing her thing, so I'm not able to.
Yeah.
1 minute, okay. I had everything ready and then.
Ma'am, we are seeing a blank slide.
Well, I'll just try and share my screen. I think it got closed. Give me a minute, please. Okay. Share screen. I'm not able to get my slide over here. And it's okay.
Move to your first slide and slideshow.
Yeah. Is this visible now?
Yes, ma'am. Yeah, go ahead.
Okay, thank you, everyone. My panel and I would really like to thank the organizers for giving us this great opportunity to have conducted the World Cafe on Auditory Neuropathy Spectrum Disorders and cochlear implants. We had a World Cafe meet on the 10th, and I had a wonderful group with me, Dr. Alfagar Mohammed from Saudi Arabia, and Dr. Anu Sharma from USA, Mr. Apurv Kumar from India, Dr. Kapil Sikka from India, Ms. Parul from India, Dr. Rajiv Pachauri from India again, Dr. Ruchika Mittal of India, Dr. Vanija from India again, and Dr. Wissam Isawi from Egypt. So we had a group of ENT doctors and audiologists working in them majorly with the diagnostic area, and also audiologists working with both audiology diagnostic as well as rehabilitation. During our discussion, we addressed 6 different aspects, and this included candidacy, the audiological tests that needed to be done, surgical aspects, mapping issues, rehabilitation issues, and funding. Our major discussion was focused on candidacy and the audiological evaluation, though. Let me see if I can. Yeah. And to address these different aspects, let me just try and move my pictures are okay. Okay, to address these 6 different areas, we had very focused discussion, and we discussed 14 different questions. So the answers to these 14 different questions is what I'm going to be giving. The responses over there, I've summarized it, and I'm not gone into each person's point of view over there. So the first few are about candidacy. Are cochlear implants the choice of rehabilitation for all those diagnosed to have ANST? And the response was it can be done for most of the individuals, but it depends on the site of lesion, that is whether it is presynaptic versus postsynaptic, and it is recommended with more confidence for presynaptic lesions. It depends on the severity of the lesion, and the severity is decided based on cortical responses, speech identification scores, progress in speech and language, or communication skills made with hearing aids. And again, the decision was saying mild ANST may benefit from hearing aids, but should be monitored closely to check if they need to cross over to a cochlear implant at a later stage. And those with more severe ANST were recommended cochlear implants. The next dependent variable that they thought was the age of onset. And those with congenital ANSD were thought to be more beneficial from cochlear implants, and we will discuss this again a little later on. So the second question was, based on what audiological test do you think that the decision should be made to implant an individual diagnosed to have ANSD, and is an invasive procedure required? So we classified the tests over there as being mandatory tests or essential tests and desirable tests. So the mandatory tests, or some of them are routine tests. So pure tone evaluation, using any of the approaches, techniques that are appropriate for the age being tested, tympanometry and acoustic reflexes, OEE, ABR, cochlear microphonics, word identification if the person is verbal, auditory performance questionnaires, speech language development, including IT maze, depending on the age of the person. The desirable tests decided were cortical auditory evoked potential, then specifically the P1 part of it. And this was more to decide on the severity of the condition. Trans-tympanic ABR, and this was considered necessary if a unilateral cochlear implant is being suggested for a person to decide which ear is to be used. Then cochlear ECOG, and then that information has gone to the wrong side, I'm sorry. Then genetic test to decide is OTOF mutation. Those with OTOF mutation are found to be better candidates for CI. And one major thing that came out was saying invasive procedures are not mandatory. So you don't have to say, I don't have an invasive procedure and I cannot make a decision. The third question was, does the outcome from cochlear implants vary in those with early childhood ANSD and those with late onset ANSD? And the decision was saying yes. The main reason that they gave was saying the prognosis is poorer for those with late onset ANSD, and those with a late onset ANSD probably have more postsynaptic problems or neural problems, leading to poorer outcomes from CI. So it's not so much the age that they thought was the important aspect, it is more the diagnosis, whether it is presynaptic or postsynaptic. The fourth question addressed was, should those diagnosed to have ANSD but have aided thresholds well within the speech spectrum and poor performance on hearing aids be recommended cochlear implants? And this was a unanimous decision, yes. They said yes after necessary evaluations, as speech amplification is more important than just sound awareness. And the decision was also saying, as there is no other way for them to use their hearing, as amplification would only distort the signal heard by them, whereas the CI would enable better speech language development, especially for the younger ones, and for older ones for better communication skills. The fifth question addressed was, is rehabilitation a challenge in individuals with ANSD using CI who have considerable residual hearing but poor speech amplification, as they would get direct auditory stimuli as well as electric stimuli? And if this was a problem, how is it to be overcome? And there were some varied responses that we got, but mostly they said it doesn't affect. So auditory signal heard by individuals with ANSD using CI who have considerable residual hearing does not affect the electrical signal heard by them. That was the general consensus, but slight variations were there among the panelists. The reasons that they gave was saying they attend to the signal which is of great benefit to them, that is the electrical stimulation, and ignore the signal that is not enabling them to communicate, which is the auditory signal. So they may be hearing both, but they ignore one and attend to one. And if anybody finds that the auditory signal is interfering, these were the suggestions given. They may consider using earplugs to reduce the auditory signal, or increase the M and C levels in the cochlear implant to avoid interference of the auditory signal, or use a Bluetooth device for direct stimulation. The sixth question was about funding, and we divided the question for those who are not in India and those who are in India. So we asked this question saying, is funding provided for those with ANSD who are recommended cochlear implants in other countries? Is funding provided for them? And all those who were not from India said yes. In Egypt, a single device is given, and that's not different from those who don't have ANST. So a single device, like what is happening in India. In Saudi Arabia, they're a lot more lucky. Bilateral is given for those with severe to profound hearing loss, and this is the same as what it is with anybody without ANST. In the USA, again, they don't differentiate those with ANST versus don't have ANST, and bilateral if the person is considered a candidate. So I asked the Indian panelists whether they thought that cochlear implants should be funded in India also, and unanimously everybody said yes. And so SIGI and all of us should make a representation to the government agents, asking them to also include those with ANSD as being under the list of people who could be benefiting from cochlear implants or given cochlear implants. The 8th question was about surgical aspects. Would the cochlear implant surgery surgical challenges for individuals with ANSD be different from those who don't have an ANSD? And the surgeons both said that it would be very similar. But when the question asked about the facilities that would be done, would it be different for those with ANSD versus those not having ANSD? Slight variations were recommended. So if the non-audiological tests or facilities should be slightly different is what they said. Thorough systematic evaluation is warranted, as those with ANSD may have syndromic problems. And this was something new that we all came up, and we haven't been thinking about it. And I don't think this is done on a routine basis. And as some of it may be routine, where you do an MRI for the brain also, but in addition, they've also wanted a recommendation of MRI for cranial nerves, which may be also affected because of the syndromic condition. The 10th question was, should CI surgery be recommended for children below 12 months of age once a diagnosis of ANSD is confirmed? And very strangely, this entire group said no to it. No, as it would be difficult to rule out maturational delay. And they felt that there's reports of spontaneous remission of ABR around the age of 12 months, that's 1 year. And I think they were very conservative about it because OAs are present and ABR is absent, and you cannot be sure whether it is a maturational issue. I was thinking that had the panel also had people from Australia or Sweden, maybe we could have got different responses. So maybe we need to be looking at different other parts of the world also before we make this entire decision. But our group decided saying no for those below 12 months. The next question was, should those diagnosed to have ANSD and a recommended CI be provided unilateral, bilateral, bimodal cochlear implants? And they were supposed to justify their choice. And the majority recommended bilateral, provided funds were available. So, but there was no consensus among them whether it should be sequential or simultaneous implantation. So it was like half and half. This half of them recommended sequential implantation. This was recommended, saying first let's confirm whether the child is benefiting from the cochlear implant on one side before making a decision about the cochlear implant on the other side, which seemed to make sense. But a lot of them felt saying there is no other option for them. So simultaneous, if possible, and that means if they can afford bilateral, that's what the choice is. But one caution was made, and this was something new to me, where they said there may be a unilateral ANSD. So don't just directly make a decision about bilateral CI, decide whether the person has a unilateral ANSD before making a decision about cochlear implants. The 12th question was about mapping. And would mapping of CI users with ANSD be any different from those without ANSD? And the decision was saying that it's not going to be any different. And there's no changes that you might be making for a child who's not having ANSD would be similar to the children who have ANSD. And would rehabilitation for those CI users be different? And again, it was unanimously felt, no, it won't be different. But it depended on whether it's a late onset or early onset ANSD, but the decision was saying by and large, it is not going to be very different. And would the outcome measures be different is another question that we asked. And it was felt saying that the kind of measures that you would use for a child without ANSD or an individual without ANSD would be the same for those with ANSD. So to summarize what we decided in this group was, the general consensus was CI should be recommended for those with ANSD, and the recommendation should be done based on specific tests, and invasive tests are not mandatory. But when you make your recommendation, you need to be looking at the severity of the condition before making any decision. Then rather than making a decision based on threshold measurements, speech amplification scores should be used. And that was something that all of us decided, and saying, don't go by only the pure tone threshold results. It is the speech amplification results that are more important. Cochlear implants should be recommended depending on the site of lesion, that is whether it is presynaptic or postsynaptic. Bilateral CI is recommended if funding is not an issue. Caution should be placed before recommending CI for children with ANSD who are below 12 months of age, as they may have delayed maturation. Then prior to surgery, testing for systemic disorders should be done. Mapping and rehabilitation techniques are similar for those with as those who do not have ANSD. And requesting for funding agencies, request that funding agencies should be including ANSD individuals also as something that we should all take forward. And if I suggest that SIGI gives a representation to the funding agencies and say, please include this. There may be some of them who already have it. I'm not 100% sure, like how it is in the US. But as far as I know, it is not included. So once again, thank all of you for this opportunity.
Thank you, Dr. Asha, for the nice summary. So now I would request the last presenter of this World Cafe session, Dr. Bhanumati, to share her slides and give her presentation, please.
Thank you, sir. Thank you once again, everyone. Sitting back and relaxing a bit and watching everyone present made my job a little easier, I suppose, because we are going to talk about topic. I hope the slide is visible. Can you please confirm?
Yes, ma'am. Good.
Okay. So as you can see from my title, it's multilingualism and cochlear implantation. So this is quite a broad topic, and I really thank the scientific committee from Habilitation and Ms. Rashmi Deshpande to come up with this topic, and that too on a World Cafe. And you can meet my esteemed panelists who were there for the brainstorming discussion: Dr. Dalia from Egypt, Dr. Deepti, Ms. Deepti from India, Ms. Falguni Shrikant, Ms. Ritu Nakra, Ms. Shweta Deshpande, Ms. Gina Roy, Ms. Rupali, and Ms. Neelu. So I acknowledge every panelist and their opinions which they had shared with me, and which is a big compilation which I'm trying to put forth. Hope we can do justice to the topic. So as you all know, that multilingualism is nothing but children are acquiring more than one language, wherein they comprehend or produce two or more languages, either in oral, manual, or written form. And this is like a basic working definition that they usually use in the literature. So either they should have a basic level of functional proficiency or use of a particular language, regardless of the age that the languages were learned. Now, with the background that you see, as it'll be quite awesome to know, there are 7,900 languages all over the world, and more than half of our world's population are multilingual. And definitely, as per certain literature, it is saying that there are going to be increasing number of linguistically diverse children in future, and it is expected to be more than 40% increase in the numbers. So the state healthcare systems in various countries are definitely funding cochlear implantation program, and with a lot of funding opportunities, we are seeing children opting for cochlear implant from various socioeconomic backgrounds and ethnicity. So there is a lot of linguistic and cultural diversity in this particular group. Now, so what are the issues that we have to address at the forefront? Identifying and supporting their unique needs becomes mandatory for professionals like us. There are 7,900 working in intervention in 900 languages all over the world, and more than half. Working in intervention and education settings, and by 2030, it is estimated that those who are not going to have English as their first language is going to raise to 40%. So we need to support and develop speech, language, and literacy in this population, which is going to be an ongoing debate in this population. So let us see the inputs from various panelists and what we have come up. Definitely, there are a lot of factors impacting language acquisition, and there are some presumptions based on literature. It says that it all depends on the amount of an exposure to and use of the language that the child is exposed to, because there are a combination of languages that are acquired by the child at different times of their life. And the age at which the acquisition of each language begins matters a lot, and the purpose for which the language is used is also an issue. Now, myths or facts. There are definitely many myths about this particular concept, because they say that multilingualism itself will create negative consequences for language acquisition, which is quite shocking. And they also say these children end up with some communicative impairments, with cognitive issues. So they say and suggest that you should use only one language, because it is going to overly tax the system, which is already struggling to cope with two languages. With one language. So oral children in multilingual environments are presumed to show slower functional speech perception skills, as per some literature studies, which is again quite a shocking experience, because in our experience, from the panelist experience, none of us had seen this in our clinical experience till now. And so identifying and supporting their unique needs becomes mandatory. Now, what are the benefits versus the controversial issues? Benefits of multilingualism is there is a good executive functioning when a child learns more than one language. This is proved in research. And the metalinguistic awareness is going to be very high. And this is also going to protect them against a cognitive decline in future. And it allows for incidental and natural language learning. Whereas there are few which says it is going to affect the first language acquisition. There are definitely some issues with grammar, syntactic and word retrieval skills. And it also ends up in children lagging with their vocabulary skills with the two languages by different researchers. So with all this background information, we decided that let us give the bifurcations to different panelists, and they come up with different opinions. So we decided to go on a hierarchy. Pattern of language development that we see in normal hearing, typically developing multilinguals, versus a cochlear implant children. And then we moved on to the pre-implant predictors and choice of language and intervention modalities, mainstreaming, assessment with respect to formal and informal, because it's a dynamic assessment. We measure the outcomes as well, so it is dynamic. And culturally and linguistically appropriate intervention approaches, followed by specific intervention approaches. So when you see the language development in multilinguals, when you compare the normal hearing and cochlear implant, what did we come up with? It is going to take place in two fashions. One is simultaneous, that is they learn L1 and L2 at the same time, and sequential, where they learn one language followed by their native language, that is sequential. So if you see the phases of development and stages of development as shown by Dr. Dalia, we found that it is nothing great a difference between the two groups, between the hearing impaired group versus the normal hearing typically developing group. And there are some certain there are factors which actually affects both the groups: the external factors and internal factors. External is the age of acquisition, mode of acquisition, and the extent of exposure to a particular language, versus internal factors could be their cognitive abilities, the potential of a child to learn two languages, and the social interaction. So overall, we found that it's almost the same rate of development with respect to the linguistic milestones, and increasing exposure to languages always gives and increases the quality and quantity of the language input. Now, proficiency in more than one spoken language is an advantage for their cognitive, cultural, communicative, and economic advantages. Definitely, all these are going to be advantages. Now, moving on to the pre-implant predictors. When a child comes to you, and we do have certain things which we have to keep in mind during the pre-implant period. So it is definitely a reality that multilingual children with CI in a country like ours or worldwide is very common these days. So what are the factors that we have to think about? Age of implantation, which comes first, the duration of hearing impairment, use of amplification prior to CI. These are factors which we really need to think about when we're talking about multilingual children. Now, there are some constitutional factors and external factors. Constitutional could be the language learning pattern and associated problems that the child is presenting with. based on which we have to decide the further assessment and rehabilitation. External factors could be the language stimulation at home and the access to rehabilitation. So the comment given by the panelists is experiential learning is very important. It's like the garbage in, garbage out concept, which we have been seeing since last 2 days. A good input leads to a good output. Moving on to the choice of language and intervention modalities. This is something which we have to really think about and come to a consensus, because we have a lot of contradictory opinions within the professionals itself. Mother tongue first, or language of the heart or emotions. So when we discuss, the final thing that we came to a consensus is language of intervention at first should always start with the home language, because the child, we are talking about the younger implantees, where the child is implanted and the child is listening to the immediate caretakers, parents and immediate caretakers. It's preferable that they start with their home language. And as and when they gradually move on to different environments outside their house, the second language can be introduced, or there can be a simultaneous introduction of 2 languages. But the language of intervention should always be started with their home language. Spoken reading and writing language teaching of the child. See, this is again an issue which we have to discuss with the parents and decide on the language which they prefer. But definitely we have to explain the advantages of using home language which the child is familiar with. And all the intervention programs should be tailor-made with respect to their cultural, educational requirements and progress of the child. When we talk about the intervention modalities, I mean, unanimously, this would be agreed by everyone. We are talking about the younger implantees without any associated problems. Auditory verbal modality was primarily to be considered, and then we move on to the combination of modalities and multisensory approach, which is again a case-to-case basis, because this definitely supports the spoken language development. And due to the advancement in technology with respect to the cochlear implant processors and accessories, what we have right now, wireless noise-free hearing and Bluetooth transmission, it definitely gives an access to a finer phonetic feature of language. So we did not really feel that exposure to more than one language will be an issue in the auditory verbal modality. So auditory verbal modality should be primarily considered. Now, the next topic that we discussed was considerations for mainstreaming. Here, 3 points was discussed by Ritu. Child's readiness for school's readiness for children with hearing loss, and family and community support and services contributing to the school readiness. I think all of you would agree upon this. The linguistic abilities of the child should be at pace with the academic demands, and the higher order executive functioning always gives a better cognitive skills when we access 2 or more languages at the same time. And there should be an option for equitable and quality inclusive education for the child. Aparna ma'am had just discussed on mainstreaming, so this I'm sure everyone would process immediately. And the child should be engaged in active learning process, and we should develop some curriculum modification for these children to develop culturally and linguistically sensitive professionals who get themselves involved in rehabilitation and in the mainstreaming aspects. So overall, the child's capabilities to maintain a commensurate status in the child, and the NEP 2020 actually talks about the regular assessments to check the pace of the progress. So it's a blessing for us, the NEP 2020. I hope if it goes in the right lines, I'm sure it's a blessing. And regular assessments should be done, use of assistive devices to optimize, to receive optimum benefit of the technology for these children. Classroom acoustics should definitely be taken care of. Equal opportunities and participation should be given to these children. And we should acknowledge the child's strengths and challenges, and we should also have realistic expectations for the classroom performance. So when we talk about the outcome assessment, we actually divided them to formal and informal. When we talk which assessment in which language, we have to target all the languages, but assessment in multiple languages which a child is familiar with is mandatory. So we actually have to think on a phonological and phonotactic structures, because a child is learning 1 or 2 languages simultaneously or sequentially. It is not that always a child is exposed to one language at the same time. So the phonological and phonotactic structure is different for different languages. So assessment has to be done in multiple languages. And there should be a thorough and culturally sensitive case history. So this is like a specific point which we were discussing with Gina Joy. There should be a comprehensive language profile, because you know that the languages are used at different stages, and the proficiency of language, the combinations of language. So we need to have a complete language profiling done during our assessment, because the history of use of these languages differs with the exposure to each of these languages. and multilingual children's use and proficiency also differs. Now, when we talk of formal assessment, we have norm reference and criterion reference. The basic problem that we face in multilingual countries like ours is language specific tools, which we actually lack. So although we say we have to assess speech perception, intelligibility, stimulability, phonological awareness tests, reading abilities, and participation based on ICF, all these is put up on a platform, but we have to be sensitive that the tools which we are developing should preferably not be adapted. Rather, we have to develop new tools in our languages, which is very, very important for most of our countries. Informal assessment, we don't have to always rely on formal assessment and say we have to give them a norm measure and comparison with a norm measure. We always can think about narrative sample analysis, where we do an audio video recording of which is of a very high quality, have the knowledge of phonetics and phonology to transcribe and analyze the child's speech in totem, and transcribe it and analyze the language sample on your own in different languages. So the clinician should be very well qualified to do this, because we are not going to have formal assessments always for different languages. Now, addressing the intervention techniques, specific and unique needs of a multilingual CI child. So it has to be an optimal early intervention protocol.
Bhanu, I have a personal request. We're really running short of time, 40 minutes late. Can you wrap?
I'll summarize, sir. I'll summarize. So we have to enter into a family entered services, approach a social model rather than a medical model, use a strength-based approach for accessible and comprehensible language, and knowledgeable, and you should always utilize a knowledgeable and supportive family systems and languages. And we have certain strategies which are specific for multilinguals, or it's not that different from the monolinguals or from the other group of CI children that we use. These are the strategies that we can think of. So the highlight is definitely CI children can speak more than one language, and the language spoken at home should be the first language. Number of languages learned depends upon the cultural and linguistic background they come from, and tailor-made intervention. So we made some essential recommendations. I'll quickly go through it. The early is always the key factor. Early age at identification, fitting of technology, and early intervention. So UNHS will definitely serve the purpose. Listening and spoken language services is highly recommended. Full-time use of the technology and consistent use of home language. Incidental exposure is very, very critical for language acquisition. The linguistic boundaries, one place, one language, one person, one language, has to be decided and discussed with the parents. Balanced exposure and a dynamic assessment throughout their rehabilitation program is mandatory. IEPs are definitely mandatory. Need for development of specific tools, as I said. Language exemption in mainstreaming. It is not for younger implantees, definitely it is for the older implantees. Code switching and dual language schooling should be encouraged. And with respect to associated disorders like APDs and ANSDs, we need to have, develop a caution in this, because these are not the same group which we are talking right now. Yes, there are multimodal spoken language approach should be used, where we use both bilingual and cross-linguistic. And we can also use language pairing, music perception in different languages and culturally appropriate backgrounds. And we should discourage direct parroting, which should be explained to the parents. With respect to professionals, train a native speaker, familiarize with the language of the child, and do specific tools in different languages. Record a competent adult speaker or age-matched peer for help always in the clinic. It is not that you will have this support every time. Speaking the same language and dialect, undertaking the test is very important. Also, hire bilingual and multilingual support staff and service providers. Now, which is not desirable? Use of only one language concept is not desirable all the time. So we have to be very careful about this. Establishing a consistent language between home and school is very unrealistic. And the conversational fluency actually doesn't decide your academic learning concept. So total communication, when we talk about total communication, is another challenge, where we do have multilingual children with CI who can offer total communication. There again, we have to levy caution. So the promising factors, receiving CI at very young age during the optimal learning language learning period is very important. And the choice of language, as I discussed, is very important and we have given our thoughts about it. Need for specialized assessment tools, culturally appropriate interventions, focus on specific intervention strategies, and evidence-based practice. Thank you so much. Thanks a lot for the organizing committee to have given this opportunity. Thank you again. I hope we haven't crossed from our end. I do not know how we postponed. Thank you, sir. Thank you, Dr.
Okay.
Yeah, the full marks to all 7 of you for wonderful summaries, wonderful work, but 0 marks to all 7 of you for timekeeping because all of you were between 15 and 20 minutes. Awesome. Anyway, without further ado, we are 45 minutes late on the scientific program. Let's move on to the next integrated panel discussion. Dr. Madhuri Gore to take over.
Good morning. The next panel is begin shortly, moderated by Mr. Shashidharan. It is all about manpower development, and everybody knows Shashi. He's been there in the fields for so many years and very analytical and very clear in all his communication. So over to Shashi. Shashi will introduce the rest of the panelists. Yeah.
Good morning, ma'am.
Please, Shashi is the audiologist at MESIARC, works with Dr. Manoj. And yes, his passion is pediatric audiology. Over to Shashi.
Good morning. Thank you. Thank you for the invitation. It's a pleasure to be here. Our discussion is going to be about the manpower development and training in a cochlear implant clinic. For a short while, let us move away from science and discuss about ways to manage a CI clinic. Before we proceed, let me introduce the panelists. Mrs. Asha Gawal is a senior audiologist and speech therapist in New Delhi. Dr. Milind is a consultant ENT surgeon in Mumbai. Saji Maridurkara is a principal research audiologist working with Cochlear Limited, Australia. Dr. Rakesh Kumar Singh is a professor and head ENT at Indira Gandhi Institute of Medical Sciences, Patna. Ms. Shefali Shah is a certified AVT practicing in India and UK. And we have with us Dr. Rakesh Kumar, Professor AIMS, New Delhi. What is human resource development? It's an ongoing process that analyzes, forecasts, and projects an organization's present and future manpower requirements. What is our legacy? We all know that the number of CA recipients are increasing. Have we trained enough number of professionals to take this forward? We all started with one audiologist, one surgeon, and probably one habilitationist. And from there, we all grew. What is this generation of professionals doing to help the succeeding generation of professionals? Next slide, please. So our discussion is going to revolve around the manpower development with respect to the professionals, with respect to the supporting staff in the CA clinic, and with respect to product-related service. Now, this is the first question. I marked the questions. We have 12 questions. So the first question is, this question is to Saji. Saji, how do you mold the audiologist in the CI team? The audiologist in the CI team has 2 primary roles. One is to perform the candidacy assessment, and the second one is to perform the post-operative management. How can we improve their skills in audiological evaluation? How can we improve their skills in providing realistic expectations and mapping? I remember, Saji, you were running around in India in 2000. You trained several audiologists. I thought among the panelists, you are the best person to answer this. And I think you are my first teacher as far as CA related work is concerned.
It's a great topic, great question, Shashi. So 2 thoughts that comes to mind: candidacy, mapping. Let's think about functional outcomes and diving in. Now, when we think about candidacy assessment, the first thing that comes to our mind is all those that audiogram with that shaded region, that MRI requirements, that hearing history requirements, all that are absolutely necessary. We all need to learn all of those things. But I think the most crucial thing that a CI clinician needs to learn is to get a sense of the possible outcomes for the cochlear implant recipient. because the role of a clinician is not just to say yes or no to the patient. It is to help the family understand what may or may not be possible with a cochlear implant. I recall this person, this young adult who was congenitally deaf and never wore a hearing aid, coming for an implant. And we spent hours counseling them, please don't go ahead for this because this is all that you get. Nevertheless, they went ahead for the implant. But after that, predictably, he got very minimal outcomes according to our definitions, but he was happy. He wore it all day, every day. He got 0 speech perception scores, but functionally, he could cross the road confidently. So I think the candidacy training should be all about functional outcomes. We should train on that. So how do we do that? I think we start by documenting the functional outcomes of cochlear implant recipients. Now, for example, in Australia, the Shepherd Center has developed the Functional Listening Index, which is a great tool to look at functional outcomes over time. And you can compare it with the normal hearing children. You can see what the trajectory is for different children. And it's by having that knowledge, we can help new clinicians joining our team to gain that confidence in doing that counseling. And it also helps experienced clinicians also. Like, how do we do candidacy assessment for someone like a single-sided deafness, like where the children are actually doing quite fine? So I think functional outcomes is one. And in terms of mapping, the biggest challenge that clinicians face is—
Saji, before you go into that, let me interrupt you. Like, when you suppose a new audiologist joins me, what do you think? How much of time do they need to get these realistic expectations to their brain? Like, you need to train them over a period. So how do you really train them? Index, I understood what you meant by index. Other than that, how do I transfer my skills to them? Your views about it.
Yes. So if we have documented what are the real world outcomes, if we can look at someone with this kind of hearing history, this kind of etiology, what kind of outcomes is possible? If we document it, and if we are able to convey that, and if there's ready references for these new professionals to see what is possible, and look at a chart and say, oh, this is where they would get up to. By having that thing right now, it's all stored in our head. So when we experience clinicians, when we see an audiogram, we see a hearing history, we know automatically what are the possible outcomes. It is the ask is to take that and let's try and find ways to document it so that someone new can come in and they can go forward. They may not have all the experience of an experienced clinician, but they would be in a better position to feel a bit more confident. And that knowledge that we've got stored in our head, we need to find ways to put it out there so that people can get more easier access to that.
Okay, about mapping, you wanted to say something about mapping.
Oh yeah, again, mapping, when we think of mapping, it's all about impedance, pulse width, rates, maxima. Those are things that we first think about. But to me, I think the most important thing is to develop the skills to interpret what the current outcome of the patient is and what they're saying, what they need, and then match it to some kind of solution that you need to do. You don't even need to know what the solution space is, because the software itself sometimes tells you what the solution is, or you can ask other senior clinicians. But interpreting what that patient needs, what they're experiencing right now, and what their challenges are, that is the key skill. So I think we start off by getting clinicians to observe a good practice. But I think the next step could be a radical idea, maybe it's not so radical in many places, is to send them headlong into a management of cochlear implant recipient before they have necessarily mastered the nuts and bolts about mapping. They do not know everything, all the parameters right at the beginning. And I've done this with clinicians, thrown them in the deep end, and actually not given them any support. And when you learn by your own experiences, that's the best way to learn that, and you master the programming systems and all around that much better when you learn by your own experience. But so I guess the key point here is diving in early. Let's not hold off. Let's not wait till we have mastered every jargon out there. Let's just let people dive in, and they'll just learn from the experience.
Thank you, Saji. Can I move on to Asha, ma'am, for the next part of this question? Ma'am, how do you improve the audiological skills? as far as pre-implant evaluation is concerned? How do we, every audiologist cannot step into this work immediately after their training process, right? So how do you actually nurture their skills?
Yes, Sajis said very good technical aspect of it. I will like to put it more about from my clinical experience, since, well, the most important point is that make them understand, give them responsibility to take a holistic approach in correlating the audiological investigation test battery. So there are the junior who are performing the test, and the new person who is MSc graduate has a depth of knowledge of audiology and can do all the tests very well. He needs to understand the correlation of it, what is expected. So that needs to be understood by him. Then second thing is regular clinical meeting. In our clinic is happening, like supposing we have around 5 to 10 cases per month, in which these profound cases, they are candidate or not. So regular clinical meeting, we help.
That's a very good concept, ma'am. Regular clinical meetings so that everybody will know what's going on with a particular case.
So it increases their interest in the topic. Make them understand important and empowerment is a part of decision making of the candidate, and also sensitize that you are the responsible for this child. If you are going to send a wrong report and other 10 clinic surgeons are going to see and implant the case by your report, then how you are playing with these children. So making them aware of the life of a child, life of a parents also. So this whole thing should appear right from the beginning, ethical practice, and that is how I develop their confidence.
Just one more question to you, ma'am. I need one sentence answer for this. Don't you think that it's very important to keep talking to your surgeon also with respect to this evaluation, so that surgeon and the audiologist tells the same thing?
Absolutely, but I don't give them empowerment. They just observe me that all the time I'm doing that, and that's that domain I keep to myself. I don't give them that domain. Yeah.
Okay, the next question is to the CA surgeons here. I'll start with, next slide, please. I will start with Dr. Rakesh, Professor Rakesh in Ames. So the awareness, the proven outcome through cochlear implants and the government CA programs, all these have resulted in an exponential rise in the total number of CA recipients. Do we have enough CA surgeons to handle this? What is your vision about the future requirements? What are the surgeons doing at present to carve out more surgeons?
Yeah, very important question. In a medical college, in spite of so much of awareness and the surgeons and other trained staff available, we still have waiting period for a few months for any implant patient after he deposit money and get everything done. So that means we are not having enough. So medical college, obviously we have the referred cases, so we have more workload. But referrals, because there are not adequately trained surgeons available in the periphery. So we need more ENT surgeons, we need more auditory verbal therapists. And also the important thing is, especially for the medical colleges or any big hospital, you need to develop a team. One cannot do that, okay, one surgeon is doing and suppose he leaves the hospital. So the program should not stop. So we need to train the second and the third person in queue. So if one person goes, the other person takes over. Side by side, I also insist that the person who are involved in the cochlear implant should be the one who take it as a whole. You cannot just do implant and just forget about it, because this is a lifelong, you have to be with your patient, with your audiologist, with the auditory verbal therapist. So we need more trained staff. We need more commitment as far as from surgeon's point of view. And we need to have the commitment towards our patient. We need to check their progress. So it is not that you just a trained surgeon and you operate and forget.
Dr. Milind and Dr. Rakesh Singh, do you have anything to add on to this? Dr. Milind, please.
Yeah,
I would add to this that, I train a lot of surgeons here at our institutes at KEM and have been at Nair, and also doing in private. Now, what is lacking is, we need a lot of hands-on training, hands-on workshops where more surgeons can be trained. Second, very important point in mentorship, which I would say, is that surgeons mentorship is basically those of surgery. So I think slowly, as in you are mentoring one surgeon, you have to have steps. You have, suppose he assists you 5 surgeries, 6th one you give him to start, or at least give some part of it. Main part of inserting an implant, you may keep it to yourself for some time, but slowly I would say that maybe 2025, it is up to the mentor and the mentee to decide what is comfortable, but slowly he has to leave his hand. You can't be holding, one mentor cannot be just holding a bicycle and letting him drive throughout. I think there has to be some number which mutually to be decided. There is no fixed number, but somewhere we have to leave their hand, just sit outside, have a coffee, and be supportive to him for surgeries so that he can be trained. And I think that should be the way to go ahead and train more surgeons.
Okay, Dr. Rakesh, please.
Yeah. Rakesh has already mentioned about the evidence related to the backlog of the waiting of the recipient. He is also my mentor. He developed the cochlear implant center at my institution. So, just I want to add something. We need to convert all medical institutions in an implant center to hold the outstanding implant services in the future. Because the future we need massive surgeon, requirement of the massive surgeon to come back to cater the whole society. NMC, that is the regulatory body for the medical education, has already made it regulation, and the method of implementation, it's strictly. Our aim should be to train all the ENT surgeons in such a way that they can do efficient implant surgery. Institution has a great role in that respect, since it is a factory of manpower production.
Thank you. Dr. Milind, may I take the liberty to tell you just 1 or 2 sentences for this question so that we can move on to the next, please?
Yeah. So as already mentioned by 2 other surgeons, there is a need for surgeon to develop in the periphery. In the metros there are many surgeons. As we can develop more periphery, so a proximity of a surgeon or a mentor to the training is important. If the surgeon and the mentee and the mentor both are in the same city or nearby, maybe the surgeon is more confident when he start doing new surgeries. He can really approach the person and immediately call him. So I think that is the way we should start training more and more surgeons who are around you.
So to sum it up,
eventually they may be your competitors, but there is no way out. We need to train them more. Yeah.
So to sum it up, we don't have enough CI surgeons right now. We need more and more surgeons. So you all have a huge task in front of you. Now coming to the next question. Next slide, please. This is to Shefali. Shefali, I'm just combining, in the interest of time, I'm just combining question number 3 and 4. Just go through this. It's about managing the recipient strength in habilitation. This question has 2 angles. One is about online speech therapy. Another one is about online training for the professionals. Among all the 3 processes, that is surgery, audiology, and habilitation takes a lot of time. And it's a major challenge in providing sufficient manpower. Shefali, kindly share your views about effective utilization of manpower in this area. What I mean is, how effective is the online speech therapy? How are we managing right now? And the next part of the question is, next slide, please. I'm just combining this in the interest of the time. How effective are online training modules for rehabilitation? Is our training program designed to address the learning styles of the future, or are we tied to our current models? what is the duration of training that a rehabilitation professional need to handle CA recipients? Kindly share your views about online training programs for rehabilitation professionals. Does this improve the quality of work of existing professionals? There are a lot of professionals who just want to start practice in this field. Will it improve their skills? This is my question. Over to Shefali, please.
Thanks, Shashi. I agree that rehabilitation or therapy takes the longest amount of time. But to be honest, therapy is actually probably the least efficient in terms of personnel. Now, let me explain that. And that's largely because of the nature of the work itself. If you look at surgery, you have a senior master surgeon. You have a team who can prep the patient. Master surgeon comes in, does the critical work. You have someone who closes, he moves to the next patient. Similarly, with audiology, you have someone who can focus on objective audiology, someone who's doing the subjective measures. But in therapy is based on two things. One is on relationships. It's all about the relationship between the therapist and the family, and the relationship that one as a therapist is trying to foster between that family and themselves, but also the family and the child. So it's about relationships. And the second thing is that therapy needs consistency. Because it is based on relationships, the family needs to know that you as therapist or me as therapist is going to be with them from start to finish. And that is what gives them security. So if you look at the day of a therapist, there are three parts as I look at it. One, of course, is that you're doing the therapy. The second part is that you're actually planning for it, and that does take time. And there is a third element where you're actually in family meetings. So if you look at your day, how many can you do in a day? Say 7. If you did 7 a day after day, you would have one exhausted therapist, right? Now, the reason I'm saying this is therefore what it boils down to is that you can do probably 5 a day if you can, because that allows you to plan at home. And the reason I'm saying that is this because a lot of young professionals, therapists come to me and there is frustration. And so those of you who are managing your own practices and who are hiring therapists, if you have families beyond, say, 25 families, you need a second therapist.
Yes.
Don't pressurize your existing therapist to come on, like make your sessions shorter. I'm talking about auditory verbal therapy where you see a family once a week, okay? Now I know—
Shefali, may I interrupt you? So what you mean is that a lot of human touch is involved in therapy. So you need to think, you need time, you need peace of mind. So every CA clinic, they must make sure that their therapists are not overstressed, at least 4 or 5 sessions per day. Am I right?
If you want a service delivery model, that is ultimately the test, right? That is ultimately the test. Okay, now there are a lot of questions you've asked me, so let me rush through this. In terms of training, right? Is there a lag or am I the only one hearing it?
No, it's fine. It's fine.
So in terms of training, in our work in the hearing sciences, we talk about access. We're always talking about access. So my question to all of you is, how accessible is training? How accessible is our training module? And and that's why I actually have an entirely online training module, which is Learn AVT, and I'll explain why I'm doing that. But when we talk about access, what are we talking about in terms of training? We're talking, it needs to be global outreach. Yeah, you can be anywhere in the world across time zones. I mean, right now I'm in the UK, so I'm waking up at 3 a.m. every day to be at the 9 a.m. sessions, right? Now I can do that for 3 days. But if you're talking about training, that's not sustainable for students. So the great part so that's why I went completely online. So I've recorded all my lectures, right? Anyone, anywhere in the world can access it in their time zone. You can go back and you can view those lectures more than once. And then it uses the trainer's time efficiently because you come into actually discussing rather than just transferring knowledge.
All right.
Second thing is that training, I think today needs to be affordable because it's for young professionals, not free, but affordable, and it needs to be scalable. So can you do it as a national rollout? And that is where online training just is the winner. It's also about the future because see, we have to look at, are we training? Am I, as trainers, am I training the way I was taught? Or am I training based on current research and my current clinical practice to address the needs of a future generation of professionals as well as children or adults?
All right.
So the other thing that I really want to focus over here, that is really important, I think, for there to be a shift in the perception towards habilitation. Now, if you look historically, the medical profession has always had a rich history of guru shishya parampara. You transfer, you always transfer those skills. In terms of audiology, it's driven largely by the technology. The manufacturers are always upgrading your skills, but then they are upgrading your skills regarding the product, right? There is also the other side of clinical services. Is that being addressed? But in terms of habilitation, we're just kind of hanging in between because everyone talks about habilitation, but I mean, what is actually being done to prepare you to do that work, right? Now, so that's why training in habilitation is really essential and it needs to be rooted in practice. So I can't just be talking about the theory of it. I need to be able to guide you about how to do it. And if you're stuck, how to get unstuck. That is the value of training. And all this, of course, online. So you're talking about imparting knowledge, but you're also talking about transferring skills. So when you talk about the efficiency of any training service, it has to make a change in the quality and the nature of the services that the students are giving. And I just want to give two quick examples here. So for example, in the online training course that I've just started, and that's Learn EVT, that's in the first month. What I really loved in the virtual session that I just had was that the students were saying, that the concepts are really clear. And the second thing is one guy, he told me, he said, this training is amazing. So I said, really, why is it so amazing? So he said, because I started applying what you are teaching me to my practice. And I said, yes, that's exactly what needs to be happening. Because if that's not happening, then we need to relook at how it is that we're training.
I think this has to be, I think your skills like this has to be transferred to many candidates through online training. I think
this is one last thing I just want to make.
Yeah,
sure. One thing is that when one is training, it's not about just one-offs. Okay, it's not that, oh, I did this with this child and it worked. The question is it replicable? And that is ultimately what the skill is, that what we are trying.
Definitely, it has to be replicable. Now, moving on to the next question. Next slide, please. It's about improving our professional skills. We all started our career, and we all know that 20 or 30 years ago, what we were and what we are now, right? We all have improved our skills. We all get into our initial training process and start our service. How to improve the quality of our service? How do we transfer our skills and experience to the next generation of professionals? I think all of you can answer this, and maybe 1 or 2 sentences each, please, so that I can move to the next question. Anyone?
Yeah, can I begin, sir?
Yeah, sure.
Sashi? Yeah.
Sure.
I think the most important is teamwork again. Give them exposure. If it comes to habilitation, don't underestimate habilitation professionals, right from the switch on or the candidacy, or even the new product specialty, or even the device or switch on, they should be part of it. So keep them together, even if the audiological thing is working.
Okay,
audiologists give them
so
research
your point here is, ma'am, about teamwork to improve the professional skills. Any other points?
One point I want to mention is about observing and reviewing our practice constantly. Right? When we're in the middle of just doing and doing things, we may lose the opportunity to observe what we're doing. So I've seen this in play in a lot of great, fantastic programs where I observe where the surgeon might be operating, but his camera output would always be on the TV where everybody else gets to observe. So the surgeon gets it benefits from the feedback from everybody else in the theater. Warren Estabrook, the doyen of auditory verbal therapy, also recommends that we record the therapy sessions and we review it. I've learned most of what for programming by being in the observer chair. So I think the key idea is let's pause and let's take time to observe some of within our clinic, our own colleagues, so we can observe what's actually happening in the session. So we slightly detach from the doing aspect of it, so we can review and find those little areas of improvements. It's a bit like mindfulness meditation.
Thank you, Saji. You said it. I think, Taket sir, just a couple of sentences,
Yeah,
and then I'll give you the next question.
Next
question is to you.
Just one thing that we need to interact, as Mr. Sadiq told, with your colleague, with expert through CABs, workshop, hands-on. It is true for everyone, including surgeon. And that will give you the insight. And also don't just operate and forget. Interact with your patient, interact with your therapist, and try to improve every day. So that should be the motto.
Okay. Next slide, please. So the surgeons are operating, audiologists are doing their work, habilitations are doing their work. Have we actually created a bridge to the school? My wife is a school teacher. She keeps on telling there are CA children in her school. They say that they're very scared to touch the processor. They say that something goes wrong. These teachers, they are very scared of touching the processor. They say that if something goes wrong, family will lodge a complaint against us. So our work should not be tied to the clinic. Did we use the existing manpower, or did we recruit enough manpower to provide necessary orientation to school teachers? Are we successful in addressing the issues of CA recipients beyond the CA clinic? Did any one of us step outside our clinic, and did any one of us visit the schools and took care of these children? It's open to all.
Yes, Sashi. Sashi, what I have done in my clinic is that those recipients who are already attending school, so they become advocacy. Their parents, when they go for regular meeting to the school, then they talk about the teacher and they take this front end, meeting the teacher and explaining them about the device. So
great.
Rather saving our personal time, through the recipient's parents, we are approaching to the schools. And if some school they want us specifically, then one of my staff will go and take over the lecture.
That's great, ma'am. Maybe you started early. You are one step ahead of us. Great to hear that. Any other things? So if there is no other message, I can. Yeah, Shafali, please.
I just want to add, I don't want to add to what has already been discussed in the World Cafe on mainstreaming, but I think the way forward is that it's, like in education, we talk about developmental versus remedial, right? So I think the way forward is that we look at training manpower for the mainstream fresh. And we don't try and work on the existing teachers, but we start again and we divide it into what are the areas that they need support in. One would be the audiological information, one would be on, say, these classroom acoustics, and the third is actually on addressing the language ability of each child with a hearing loss. How do you support that? And we train that accordingly.
To the resource teachers. Yeah, got it. Can I move on to the next question then? A CI program becomes successful only when the surgeon, the audiologist, and the habilitationist stay together. Only maybe they are in different places, but only if they stay together. What may be the main factors that holds a professional to the CI team? I'm sure that a lot of delegates over here, they want to hear from you all. How you are running a successful program? Just list out the factors, please. Dr. Milian?
We do. Yeah. So I think what matters in the team is the coordination, and to my team, it doesn't end with just surgery, and it continues right from before surgery, after surgery, regular follow-up meetings, and we discuss all the cases in detail, obviously, with complications and with problems, and that keeps a team together. regular meetings which would be focused more at the post-operative cares rather than the pre-operative. That helps a lot. Radiologists are a part of our team who gives us very good feedbacks, and we give them a feedback of their reports. And I think that is the way you should keep the team together. And about the training part, which I didn't get an opportunity to talk, that when my mentee, when he's doing a surgery, all the CT scan, MRI we discussed beforehand with my existing radiologist and his new radiologist. So radiologist training is a part of our training.
Okay, thank you. So that you mean transfer of knowledge between the team members. Any other points?
Yeah, I would like to.
Dr. Rakesh want to say something? Ma'am, please wait.
Yeah.
I'll come back to you.
Regarding team, about 5 or 6 years back, we started cochlear clinic. So that is a good thing to keep a team. So you see the patient pre-op, you see the immediately after surgery, you see the rehabilitation part at the various stages of their post implant program. So that way you see the good result, you see the not so good outcome, and then we need to have this side by side. We have to upgrade by attending the courses, various CMEs. So that usually, like, not only good thing, you have to discuss the things which are not so good and how to improve upon that.
Okay. Any additional points?
Yeah.
Let us not repeat the same thing.
Yeah, correct.
I mean, additional points, please. Dr. Rakesh,
Yeah.
I'll come to you after Ashana. Ma'am, we have very less time now. I think we have
just one sentence.
12 minutes and I have many slides.
Yeah, just sustain their interest and not make them feel bored about the things.
That's a great
them
point.
Another future, which he already said, making them attend conference and work on the research paper, so they stay with you and move ahead. Show them the bigger picture.
That's a great point, ma'am. Sustain their interest. That's a great point. Anything else? Dr. Rakesh?
Yeah. So I can define it in 3M. That is, first, motive. Second is motivation. And third is the management. So we should motivate each of our team members, including the core team member, the supportive team member, and the additional team member. And the work of the team leader is to make a strong bond in between them and make a goodwill feeling among the whatever personnel associated with the cochlear implant team.
Okay. I think in the interest of time, I'm moving to the next slide. Saji, I'll come back to you later. Next slide, please. I'm skipping this. We have already answered that. Next slide, please. How effective is our reach in rural areas? What best can we do to cut down the traveling time of parents to clinic for rehabilitation and other CA related services? Anyone can answer this question.
I think to have a,
Please,
I think the first step before you go to outreach is to really have a strong base. Once you have a strong base and you've sufficiently got your processes in place and your systems in place, you can apply it. Because I believe, especially in therapy, the more a family stays home and with their child, the better the service is. And so you take the service to them, and that's the whole issue of how do you transfer your skills. And that is where distance therapy comes in. And so to ask the question that you asked earlier, is distance therapy effective? Why are we asking that question? If you, let's assume, what do you love, Sashi? Cameras, watches, what's your passion? Anything? Cameras, yep, I guessed. Okay, suppose you want to buy a camera, right? You want, I don't know, do you want a Nikon, you want a Hasselblad? I don't know what you want, right? Are you going to say, should I go online and buy it? Or should I actually go physically to that country where it's available? That question doesn't enter our mind. So why do we ask it in terms of services? Yes, what it means is, as professionals providing the service, it takes a heck of a lot more from us as professionals. That's what I'm saying. Are we on top of our game? And then can we do the outreach? But
I think Shefali, you're saying that we should reach out to them through some way, through online training. I mean, the online training has to be set up in villages. Services has to be set up in villages, or we must reach out to them, right?
But it can't be a versus situation. Is it going to work? That's a ridiculous question. I have to make it work. How do I make it work? And then once I'm offering it, is it working?
Yeah, we did this conference. This is online. It's working. It's working very well. Everything has to work online if we put things appropriately in place. Saji, anything to add on to this?
Yeah, so we asked this question in a research question recently. We said for audiological services that CI Clinic provides, how many of them can be done remotely, right? So we found that when we work with lots of clinicians, we found that 55% of the issues that recipients report can be addressed by just talking to them. Just having a Zoom call, 55% could be addressed by that. Another 10% we can address by programming up their devices as when you find out what is wrong, post it to them. Another 10% by allowing them to make master volume based interval adjustments or programming adjustments, you get another 10%. So you can see there's a big percentage of issues you can address just by remote methods.
What about the surgeons? Like they do a surgery and the patient goes to a village and maybe there is a wound infection. They need to do a debriding of the wound or something. The patient has to come all the way back to Delhi, AIMS or to Patna. So doctors, can you train some surgeons in this particular village so that you can be in touch with them and take care of this recipient instead of them traveling all the way? Is it being placed? Are you people already doing it?
See, what I would say that a non-cochlear implant surgeon to take care of my wound, I will be little hesitant. He should be able to pick up if there are any signs of complications or anything. So this is a little tricky. So I would rather say that you train more cochlear implant surgeons so that my colleague who's doing there, suppose a patient has got operated with me, he can always go to another cochlear implant surgeon, but to a non-cochlear implant surgeon to take care of a cochlear implant immediate post-op is little difficult. And in the long term, obviously, we have to think about this as far as the therapy is concerned, that I know people who have to travel 100 kilometers for a therapy. So do it's a time that we consider this aspect before we actually implant the child.
Okay. Shefali wants to add on?
Therapy, I don't think...
Wait, hold on. Your voice is breaking, doctor. We can't hear you.
Such a child who cannot reach to a therapy.
Okay.
Hello?
Yeah, it's
now
okay.
Is it
yeah, it's okay.
Okay. Yeah. So I was saying that before implanting, we should be thinking about these terms, whether the child is going to make it to therapy regularly. If he has to 12 kilometers just for one therapy, I think to for a better outcome, we have to consider this factor before surgery.
Okay. Any other points? Dr. Rakesh?
No, initial post-op, we tend to keep patient with us for 3 days and then we ask them to report back for suture removal and then they go back.
So you want the patients to come back to you. That's what
initial care, yes, myself, but later on antibiotic they can give, but intervention like the debridement and all, no.
All right, doctor. Can I move on to the next question? Asha, ma'am? Yeah.
Can you just summarize in the next 2 minutes?
Yeah, I am. See, you gave me up to 11:50, you gave me the time. So I have another 6 minutes. I'm going to summarize. So the last couple of questions, I'm going to combine it. That's question number 10. It's about need for supporting staff in the CI clinic. Due to lack of manpower at some of the clinics, professionals are forced to do a lot of non-clinical work. We all are aware about this. This would consume productive clinical work, clinical hours of the surgeon or audiologist or habilitationist. Kindly share your experience about the areas where more manpower is required to solve this issue. That's one point of this question. Next slide, please. Coming to the product-related service, this is an area which is being neglected by many. All of us struggle with product-related service. How do you streamline the product-related service? Have you created work boundaries for your staff? Who will handle the product-related service? Do you see a need for more support from CA companies in troubleshooting the devices and product counseling during device activation? what is your vision for the future? To sum it up, it's like product-related service. How do you handle the product-related service in your clinic? This is a question. It's a long question, and let's try to answer it within another 5 minutes.
Yes, I can quickly say a few points, Sashi, on this. We know that product 24/7, our recipient should be online and not offline. It is very important to have 2-3 tiers of service product specialist development in your clinic, not only one. From that point of view, a specific product specialist who will be a storekeeper, and he will know the things are available with them and will be able to coordinate and will be trained only one specific product only, which is a basic product 802, which has a limited. So one person for a basic training, then there's another person trained for the advanced training product specialty. So there are 2-3 layers of the people.
So how many of them are there in your clinic, ma'am? How many such specialists are there in your clinic?
Five are in my clinic. 2,000-3,000 recipient I'm taking.
3,000 recipients. Are you able to manage this 3,000 recipients with 5 product specialists in your team?
Yes.
They are packed up.
Because most of them are not always. Only the recent one, the group between 3 to 5 years of implantage, they require more. Till 2-3 years online, it can be sorted out. So only 3 to 5 years, so that cut down the recipient database.
All right. Did anyone of you feel that your relationship with the recipients and your relationship with the CI families got affected due to lack of product-related services?
It has not so happened because we have different group of the recipients' parents themselves. Teenager group is separate. The new implanted groups are, and their parents are also interacting with them. And we have every 3 months meetings going on also
Right.
an yearly annual meeting. So they all are together on a bigger platform and they understand the importance, and all the time 24/7
Okay,
they are
ma'am.
available.
Okay, ma'am. Let me move to others. Any points from others?
Yeah,
Okay, Saji or Dr. Rakesh, who?
No,
Dr. Rakesh, yeah. Please, Dr. Rakesh.
Yeah, I was just saying, because there are a few incidents where even the simple thing like the wire got broken, and especially patients who have been funded by the government, they will not be very keen in purchasing. So I had just an idea, if like the companies, when we do the rate contract, when the speech rehabilitation get the funding, can we have something for like initial 1 year, so that once the parents know that benefit is there, they will be willing to spend from their pocket. Initial phase, they are very, very reluctant to spend. So that was one idea.
Saji?
We're dealing with an exponential rise in number of recipients, right? So we have to reinvent the way we think about this or way we work about this. So there are 4 possible approaches that many people have tried. One, self-help, train recipients to take care of a lot of things by themselves. Second, it's a triage mechanism. That is, triage, have someone who can triage what the basic issue is before it is actually escalated to someone with more training and qualification. Third approach, which is very popular in the US, is audiology assistance. We have people who are just mainly, and that's what Asha ma'am was talking about. And the fourth approach in Australia that we've been using is cochlear implant recipients themselves. Because they know how to deal with these devices, so they have volunteers who actually go and help with simple issues. So
that's great.
There are multiple approaches, but I think Dr. Rakesh brought a big point there, important point. These services are add value to the recipients, and it's not necessarily be provided for free. In the UK, there are services where the healthcare service actually pays for a company to actually provide these services to recipients. So I think first step is to recognize that these things should not necessarily be free. It's something which is valuable, and it's something that is potentially reimbursable. And that means we need to create that awareness right up front, that you probably need to start thinking about this much upfront and involve the payers in funding this sort of initiatives as well, so that the clinics just doesn't have to absorb this whole thing.
Thank you, Saji. I think I have to summarize this because I promised Dr. Sunil around 10 minutes extra. So we all are certain that this profession gives us, we all have gone through lots of success and issues, and we all have found satisfaction in this profession. I'm not going into this particular topic. So let me summarize this. Coming to the summary, there is excellent training for surgeon, audiologists, and habilitationists in place in India at present. Effective utilization of manpower using online facilities is already there. The process of building manpower is on the rise. This is one area which we need to concentrate. Online training modules for the habilitationists must strengthen the foundation further. CI clinics must employ adequate supporting staff to take care of their recipients. What I mean is the clinical things and the product related service should be separate. When your program grows, you should add on more supporting staff. Like Asha ma'am said, she has 5 in a clinic. So if your program is 2,000 or 3,000 recipients, you should have at least 5 or 6 supporting staff to take care of this, not audiologists. We must move beyond our clinic to provide necessary support to CA recipients. Next slide, please. The team must keep learning, provide ethical and quality service, and find ways to stay together. Our teaching institutions must consolidate on improving the knowledge and skills of their students in the CI field. We must provide necessary support to families to stay in their own areas and undergo CI related services, sitting at their home and undergoing therapy. That's what Shefali said. Product related services must be streamlined through the clinics and companies. We should talk more about this maybe in the upcoming conferences. Every clinic should develop a protocol and collaborate with the existing CI clinics to take your team forward. You can learn a lot from the existing CI clinics. Keep in touch with them. This is what we did a long time ago. Together, we create an effective platform for the future generation. Thank you, everyone. Dr. Sunil, I took 2 minutes extra. I gave you 8 minutes. Thank you.
No problem. Thank you, Shashi, and all the panelists for a wonderful panel discussions. Thank you for keeping up the time as much as possible. Thank you. So we will move on to the next section now. Now we are going to break up into 3 different halls. Now here we continue the surgery invited talks, for which I would like to invite Dr. Naveen Patel, who is going to be chairing this session. I will just introduce Dr. Naveen Patel, and then he can take over and introduce speakers and conduct the session. Naveen Patel is not an unheard name. He's serving patients since the last 30 years and has completed 1,000 procedures. He not only made himself a pioneering expert of this field in Gujarat, but also known figure himself by all other patients and their acquaintances throughout the country. Almost the most experienced otologic surgeon for handling the complicated and revision surgeries, Dr. Naveen is ranked almost the topmost lists of ENTs. He also has published numerous publications both in national and international journals, and is very actively involved in programmed for severely or congenitally deaf people. Over to you, Naveen. I think.
Thank you, sir. Thank you very much. Thank you for your kind introduction.
Welcome.
Since we have been having a little delayed schedule, can I have a slide and invite Dr. Alan Chang, please? Dr. Alan Chang is from USA, and he received his BS in biomedical engineering at the Johns Hopkins University, graduating Phi Beta Kappa and Tau Beta P. He then received his MD degree from the Albert Einstein College of Medicine and graduated with distinction in research in autobiology. Dr. Chang pursued his residency training in Department of Otolaryngology and Head and Neck Surgery at the University of Washington. During residency, he undertook a 2-year NIH-sponsored research fellowship investigating mechanism of hair cell generation. We are going to listen about hair cell regeneration. It's a very interesting topic. After residency, he sought fellowship training in pediatric otolaryngology in Children's Hospital, Boston, Harvard Medical School. Dr. Chang joined the Department of Otolaryngology and Head and Neck Surgery at Stanford University as a surgeon scientist in 2007. His clinical practice, based on the Stanford Ear Institute and Lucille Packard Children's Hospital, focuses on otologic diseases, including congenital hearing loss and cochlear implantation, and chronic ear diseases in the pediatric population. Dr. Ellen Chan, welcome to our CIGICON 2021. Over to you.
Good morning. Good evening from where I am. Very nice to see you. Can you hear me okay?
Yes, sir. Yes, sir, we can.
Let me share my screen here. This has been a wonderful presentation. I'm a cochlear implant surgeon myself. I have really enjoyed it so far. Can you see the presentation mode, or is it
Yes.
the...
No, we are not seeing presentation mode. Yes.
Not. Okay, let me see if I can change that. No, all right. Let me change that again.
Yeah. We are not yet seeing it. Go to presentation mode, please. Yeah.
How about now?
No, not yet.
Not yet. Okay. Let me try one more time here. Apologize. I know you guys are pressed on time. Let me do that.
Yeah. Yes. We are on now. Please.
Great. All right. Well, thank you so much for inviting me. This is a topic, hair cell regeneration, that is near and dear to my heart. It's a little switch in this discussion that you guys have been having on cochlear implants. We're looking forward as looking for a biological option that can potentially treat hearing loss. And I also want to give you a warm virtual handshake from California. I saw that Dr. Nevin has a background of the Bay Bridge, of the Golden Gate Bridge. So thank you. I wish I could be there in person to greet you, and I hope that we can do that in the near future. So in the next 20 minutes or 90 minutes or so, I want to give you an overview of what we know about hair cell regeneration in mammals, as well as non-mammals, and also what have we learned so far recently on what happens in the human inner ear. So I don't think I need to impress upon this audience the impact of hearing loss, which is a major health problem of epidemic proportion. It is the most common sensory disorder worldwide, affects millions of individuals from newborns to the elderly, affects how we communicate day to day, especially this impact is especially more profound during the pandemic. It's hugely expensive to our society, and the number is expected to increase with our aging society. So, as we all know, the inner ear relies on multiple components, particular within the inner ear, the cochlea, are these sensory cells called hair cells. They are divided into, they're the most beautiful cells in the body, and they're divided into two main groups within our cochlea, mainly the outer hair cells that are the amplifier of sounds within the inner ear, and the inner hair cells, which are the actual mechanoreceptors that receive sound input that are, when they're activated, they relay sound into the auditory neurons that is relayed to the brain. And they're called hair cells because of their particular structure, the stereocilia. They are exquisitely sensitive to motion. They're as little as nanometers. That's how we detect sounds. And the deflection of this stereocilia allows ion channels to open. Ions enter hair cells, and this is how hair cells are activated, how we detect sound, and this is how we perceive hearing. Now, each of us, each of our ear has about 15,000 hair cells. We're born with the same number of hair cells that's supposed to last us the whole lifetime. There is absolutely no regeneration. This is a scanning electron micrograph showing a damaged cochlea from a gerbil. What this means is that once we lose the hair cells, this is why hearing loss is permanent. Now, just to put that in perspective, there are actually about 1 billion neurons in our brain. So the number that we need to regenerate to recover hearing seems like it's a much more achievable tasks. Now, is hair cells really the mainline mechanism of hearing loss? What this study shows from archived temporal bones from Dr. Lieberman's group is that there is an excellent correlation between hair cell number that lost over time as their pre-mortem audiogram. So that this is a 78, 95, and 89-year-old patient with hearing loss, and looking at hair cell survival in their archived temporal bones after death, there is a very excellent correlation. So based on this and many studies, hair cell degeneration is a major underlying mechanism of hearing loss. So if mammals don't regenerate, why are we looking at hair cell regeneration? Let me just go back to this study over over 30 years ago now, first discovered in chicken by Jeff Cohen's group. This is a chicken cochlea. You can appreciate a sea of hair cells. These are the cells that are very same function to detect sound as in chicken, as in mammals, but they're structurally very different. Now, after damage, this is after noise damage, you can appreciate that many cells start to balloon up. This is a process of degeneration. But within days, this is just days later, you can already appreciate that there are certain new hair cells that appear to have short sterocilia appearing after a few days later. Now, they also use a marker called thymidine analog, which detects cell proliferation. And cell dividing is a process of how the hair cells are regenerated. You can see the cells start to divide. This is how they realize that supporting cells are the cells that regenerate hair cells naturally in the chicken cochlea. Now, amazingly, in these are birds that are also damaged. In addition to regeneration within days after damage, what you can also appreciate is that after the initial hearing loss or elevated thresholds, that within just a few weeks, the auditory thresholds of these birds actually return to normal levels. So not only do these hair cells regenerate, they actually able to function, innervated, and also detect sound to fully recover hearing in these birds. This is what drives our interest and many other groups' interest in looking at hair cell as a biological avenue to recover hearing. So does this actually happen in mammals? I already told you earlier that this does not happen in the mature cochlea. Now, several groups, including ours, actually looked at young cochlea. This is actually a picture from a mouse, young age, that is genetically engineered so that we can label the supporting cells in red here. And after damage, what you can appreciate is that there are actually a small increase in the number of hair cells that are regenerated from the surrounding supporting cells. So this suggests that this indeed can happen, but in a very immature state of the mammalian cochlea. Unfortunately, these hair cells do not mature fully. In fact, there's no recovery of function. But what this suggests is that there is some innate ability of the mammals to do this at a very young age. And this is just a picture showing that in addition to conversion of these cells from supporting cells to hair cells, there's actually a small degree of cell proliferation as well. Now, along with that, there are other groups that have really taken advantage of this neonatal cochlea system to build what we call an organoid system. This can serve actually like a cochlea in a petri dish that allow really drug screening. This is work coming from Bob Langer and Albert Edge's group at Harvard, really borrowing the neonatal cochlea as a platform to form organoids that allow them to test additional drugs. In this case, this is a notch inhibitor that allow them to generate many more hair cells from these neonatal cochlea and allow them to test drugs. So you'll probably hear the term organoids a lot. This is a hot area in the field of hair cell regeneration. Now, so far, what I've told you is that non-mammals, such as chicken, there is very robust regeneration. In the mature mouse, there is no regeneration. And indeed, actually, all the non-mammals that have been looked at so far, this is a zebrafish that actually have hair cells on the surface of its body to detect the water currents. These are all readily regenerate. So how do we understand the lack of regeneration in the mammalian cochlea and more? Now, our group and several other groups have begun looking at the vestibular system. As you all know, the inner ear has 5 vestibular sensory patches, and the one that has been most studied is the utricle. This is a picture of the utricle, which is structured like a pancake, but they also have very similar mechanoreceptors using hair cells as to detect motion of our head, and organized a lot more like the non-mammalian system, the chicken, is that there are hair cells and they're surrounded by supporting cells as a sheet of hair cells. Do they regenerate? Yes, they do, very robustly. This is first I'm showing scanning electron micrograph of a chicken utricle that's after damage, in this case by aminoglycosides. You can see within weeks, there is very robust recovery of these hair cells. Now, surprisingly, back to, again, a little less than 30 years ago now, is that in this case, a guinea pig that has been damaged by aminoglycosides, within weeks, there is actually some recovery of these hair cells, even though you can appreciate that they appear shorter, they appear to be fewer in number, and this actually sets the stage of many of us looking at the vestibular system as a platform to regenerate hair cells. Indeed, some of the work from our lab and others have found that the neonatal as well as the mature cochlea can regenerate hair cells. But what happens to these hair cells is somewhat surprising, is that not only do the number recover, but you can also appreciate that they do not recover all the features of what we expect from a functional hair cell, meaning that they actually are missing certain stereocilia structure, they are fewer in number, so it begs the question whether they recover function at all. Now, we followed up on this as well as others using a adjuvant therapy to actually push the regeneration further. This is an example of using a transcription factor ATO1 that we introduced, and others have done also with gene therapy introducing ATO1 as well, is that we can actually push the degree of regeneration further, that the number of hair cells would be further increased from the baseline level. And indeed, this allowed us to actually push the hair cells to a more mature state than what we expect as well. So in other words, we can actually manipulate the mammalian vestibular system to regenerate more and mature more than its baseline regeneration. Now, so far, a lot of the studies have been done on animals. How do we translate this to human? Does this actually happen in human? These are the questions, and so far the studies have been really limited by the difficult access, like you can imagine, very limited tissues we can get, most likely from post-mortem sampling or like mostly from organoids, as I mentioned earlier. So we have actually pursued this quite a bit in the last few years, working with our neurotologic surgeons. We devised a way to harvest the utricle from patients with vestibular schwannoma undergoing translap surgery. We also were able to harvest this from organ donor patients to compare the inner ear tissues from the 2 cohorts. And you can see that the very small size of human utricle that we can get is extremely tiny, but this is actually all the tissue we need to study hair cell regeneration from humans. These are just some examples. I cannot show you everything, but I'll just highlight what we have found in the human utricle. These are pictures from scanning electron micrograph of individual hair cells in the hair of the utricle from falciparum schwannoma patients. What you can appreciate is that there are some examples of very normal appearing hair cells, but many more examples of hair cells that are missing stereocilia, they're most likely degenerating. So what this data tells us is that the falciparum schwannoma is actually normally having hair cell degeneration. Now, when we compare this to two groups of utricle from both the organ donors, which has no history of inner ear disease, versus the falciparum schwannoma, which we know have hearing loss, what we see is that when we look at a marker called PAL4F3, which is normally missing in supporting cells, but normally present in hair cells, is that in this patients with falciparum schwannoma, there is some ongoing regeneration by marking the PAL4F3 in supporting cells. So this was surprising and exciting to us that this falciparum schwannoma tissue indeed is a model system that we can study hair cell regeneration in humans. Now, I know I've covered a lot of grounds. Here's a summary. Non-mammalian species readily regenerate hair cells indeed to actually recover function. Hair cell regeneration can occur in both the mammalian cochlea and falciparum systems, and that with manipulation, we can actually now push regeneration further along on hopefully can improve recovery of function someday. And indeed, in addition to animal studies, human falciparum schwannoma utricle serve as a model system that we can study both hair cell degeneration and regeneration. I am very grateful. I have a lot of colleagues and collaborators and students who have helped move us along to study this important area. And we always welcome students from all countries. And I'm happy to answer any questions. Thank you for listening.
Thank you, Professor Chang. It was a wonderful presentation. And we have been enlightened with hair cell regeneration. I think I will cut short the questions and hand over and introduce next speaker, Dr. Naresh Panda. Dr. Naresh Panda is from Chandigarh, India. He's a professor and head department of otolaryngology and head and neck surgery, PGI Chandigarh, and for the post of director, PGI Chandigarh. And he has been currently working as professor and head in the same department. He has been leading the department with utmost gusto, dedication, and personal example of hard work and devotion to duty. He has been instrumental in bringing up a great academic department in the country. He is having his post-graduation and DNB and FRCS in our all very good degrees. Started with successful SHARE program in PGI Chandigarh in 2003, and they have 400 implants till date. Has been nominated as a member of Faculty of Surgical Trainers by Royal College of Surgeons of Edinburgh, UK. Is International Fellow of American Academy of Otolaryngology and Head and Neck Surgery, nominated as an executive member of the International Federation of Otolaryngological Societies, IFOS, since year 2019. Dr. Panda has an extensive research experience in field of genetic mechanism of deafness, effect of long-term use of mobile phones in hearing, HPV-related head and neck cancer, and has published extensively and has 401 publications, 250 of them being in the international peer-reviewed journals. Over to you, Dr. Naresh Panda.
Good afternoon. Thank you very much, sir, for the kind words. And my job this afternoon is to talk about complications of cochlear implantation. as we go forward, I'm not able to, yeah. So congratulations to the organizing team led by Dr. Sunil Dutt and Dr. Shankar Medikri, my friends, for having making a stupendous effort in organizing a great conference for us. And this is also the time to pay our tributes to our teachers and gratitudes to the mentors on whose shoulders we keep progressing. The
Hello.
I'm not able to actually go forward. So before we go on to discuss about the complications, we need to understand that do we have patients with those who have higher than average risk following cochlear implantation? That's important because we have many young surgeons in the audience. We should understand which are the patients we need to be more careful about, or those patients who are more susceptible to develop infections. And it's been enumerated here: age less than 12 months. One has to minimize the blood loss, as it was said yesterday by one of the speakers, that one cannot have more than 10% of the blood volume in a child whose blood volume is 80 ml per kg. You got to avoid injury to the emissary veins, prolonged surgical time, particularly when you are doing a bilateral simultaneously implants. Adults more than 65 years, particularly those who have comorbidities and reduced immunity, are more susceptible. A prior history of chronic otitis media makes them more susceptible for infection. A history of meningitis, presence of an anomalous or dysplastic cochlea, and not to forget about the chances of a sudden cardiac arrest in a child with JLN syndrome. Now, prevention of complications, it begins with thorough evaluation and careful planning of the patients and ends with meticulous surgery and post-op care. It is important to understand the skin preparation. For the last 10 years, we have not been shaving these children. We use a 3M clipper instead. Antibiotic prophylaxis, all of us give prophylaxis, and depends on your particular choice, which one you want to prefer. In a survey amongst the UK surgeons in the year 2008, it was found that amoxiclavulinic acid was preferred by 50% of the surgeons. Vaccination against Streptococcus pneumoniae is mandatory. H1B is being covered under the National Immunization Plan at the age of 24 months, along with pentavalent vaccine and H1B. So that's the reason that only vaccination against Streptococcus pneumoniae would do. Incisions, we all started with a lazy S incision. We have progressed to smaller incisions. And it's important to understand that our incisions, if it doesn't cross the hairline, it is important because the hair follicles may contain the organisms which could become pathogenic later on. And this actually minimizes the flap related issues. Raising and choice of flap, every surgeon has his own choice, but it's important that one has to ensure adequate blood supply, do a gentle dissection, avoid drying of flaps, copious irrigation of wound during surgery, and also it is better to secure your flaps with sutures rather than using retractors, because that may have some injury to the tissues. Now, cochleostomy, all of us have now come to round window insertion, and that's the way to go. One has to ensure minimal draining, less suction, minimize perilymph loss. And whatever bone debris has to be sucked and irrigated out. And it is important that in order to have a smooth insertion, take care of the crista fenestra antero-inferiorly. Now, this picture, if you can make out, this is the picture which is showing a cortical mastectomy which has been done. One has to keep the overhanging edges, thin the posterior canal wall as much as possible, expose the short process of incus here, and you should see the pyramid along with the stapedius tendon, and a sufficiently wide posterior tympanotomy is mandatory. So as you can make out, we are trying to do a cochleostomy now using a 0.8 mm micro debrider burr. And this is very handy. It doesn't, hides your view. And gradually, you actually take out the round window membrane, making a large cochleostomy. Irrigation is important, but at the same time, it should be to a minimum, because otherwise it may hamper your vision. And this is an insertion tool being used for insertion of a cochlear implant electrode. It has to be done very slowly. ensure that there is no displacement at the time when you are taking out the insertion tool. Post-operative imaging is important. All of us do it. And as Dr. Mohnish in the morning talked about, that intraoperative imaging is important in anomalous cochlea, and it has to be, the insertion also ideally should be done under fluoroscopy control. However, at times you are in a soup, and this was one of our patients who had a misplaced electrode. You can see the post-operative imaging at 24 hours showed a misplaced electrode. And let us see what we did. And this patient was immediately explored the next day. This is the picture where the electrode is in position. We are trying to take out a little bit of the clots. The clots are there around the electrodes. And as we go further, we are trying to take out the soft tissues around the electrode here. And having taken out, you can see the electrode well in place, but just watch me when we are withdrawing. Yeah. So you can see that this electrode had gone into the hypotympanum, and that was the reason. And the insertion tool, actually, we were not able to find out that it had actually gone into the hypotympanum. So we have done the reinsertion again after a copious irrigation of the wound. And this is how an uneventful insertion of the electrode was done in this patient. So coming to the complications, we have, it can be divided into minor and major complications. Minor are the ones which settle with conservative management, IV antibiotics, and local wound care. These are the major complications which actually cause a lot of devastating effects on the patient and the surgical team. They are the complications which require further surgery or explantation, and they cause a significant medical and psychological problems. So they can be seen as this table shows: the flap necrosis, improper electrode placement, facial palsy, device failures, CSF leaks, meningitis, hematoma. It is the wound infection, which is the red flag, which causes a lot of anxiety amongst the surgeon, cholesteatoma, perforation drum while doing surgery, and reimplantation are the complications. The minor ones are the magnet wounds because of the strength of the magnet, change in taste because of injury to the cauda, otitis media, transient vertigo, hyperemia of the wound, and tinnitus. So an early postoperative care is important. Avoid hematoma. So what one should do is, at the time when you have closed the wound, we normally don't put the non-absorbable sutures these days. For the last couple of years, we have been using monocryl sutures, subcuticular sutures. So you need not call the child back for the sutures removal. And you squeeze the wound before the pressure dressing, which is important. A pressure dressing has to be kept only for 24 hours. If you keep it longer, the consequences of prolonged pressure dressings like skin ischemia, hypovascularization of the underlying tissues may cause increased pain and postoperative problems. Now, facial nerve is important, and though we are clever, we know about the position of the facial nerve based on our CT and MRI, but many a times you expect the unexpected. Try to look for the sentinel cell, drill with a polishing burr, thin the posterior canal wall well, because it gives you an additional space to work in to make a posterior tympanotomy. Avoid injuring the canal wall skin. It's the most important step, because you can expose the facial nerve sheath without any consequences. And third, and lastly, avoid shaft of the burr on the exposed nerve. Now, this was the patient who had contracted mastoid. There was a there was a constriction in the membranous labyrinth. And as you can see, this is the picture showing a contracted mastoid. And this is actually sometimes disaster for recipe. As you can make out the video, contracted mastoid overhanging. This is the sigmoid sinus here. This is the facial nerve which has been exposed. But we are a little careful here that that the shaft of our burr is not touching. There was a little bit of a basal turn ossification. It took little time to make the round window, to make the cochleostomy through the round window. So once you have widened the cochleostomy, and then you're ready, steroid lake where you can, it's instead of putting heel on, and then very slowly electrode insertion is accomplished. Abnormal facial nerve stimulation, we all know it could happen in patients with advanced autosclerosis. This is because of the presence of the spongy bone, and one has to troubleshoot by disabling few of the electrodes or change in the stimulation method. This is common thing. We all need to understand, particularly the young surgeons, that the magnetic strength may cause problems, and these children often come after 1.5 months. They will come with this wound. You have to ask, you have to change the magnetic strength, and things become all right. Non-auditory stimulation, we all know this is because of the current from the implant electrode spread out to the cochlea and stimulates the surrounding structures. One needs to reprogram the device, or reducing the current levels in the rogue electrodes. Now, coming to this flap related problems, which actually cause a lot of morbidity and a lot of tension for the patients and difficult to manage. The most often the organisms are Staphylococcus aureus, followed by the other gram-negative bacilli, and the ideal management protocol is still elusive. The major infection with exposure of implant needs admission, incident drainage. You give IV antibiotics for say around 10 days, but most often or not, you may have to go ahead. Now, bacterial biofilm formation has been talked about. They are deposition of extracellular polymorphic substances, which could be identified by confocal microscopy. Staphylococcus has been identified in majority, many of them. Even if you give appropriate anti-staphylococcal antibiotics, you are actually don't get any response. So surgical intervention has been talked about. Many surgeons have talked about use of a pericranial and scalp rotation technique with 100% success. We have used the temporoparietal fascia flap at our center, which I'll take you through an image gallery now, where this was the picture, a post-operative picture with the implant in place, had an exposure of the implant. We have extended the incision. We are trying to extend this incision, again, expose all the disease part of the skin and the coverage. Once we have done this, you can make out that the incision has been again extended, trying to take out all the granulation tissue around the receiver stimulator unit. This is the film of granulation tissues which you find over the well. You have to take them out. Many a times you may have to make a new bed for the implant and secure the implant with new tie down holes. Here we have taken out all the granulation tissues. You have to ask your assistant to very carefully keep this receiver stimulator unit without any displacement, because there would be a possibility of displacement of your whatever inserted electrodes. Next, once you have made the well again, secured the receiver stimulator unit, now we proceed with raising the temporoparietal fascia flap. Now, after proper infiltration, we have extended this incision. This is the exposure. This is mostly the temporoparietal fascia flap is a subfollicular flap, and a large flap can be actually retrieved to cover your receiver stimulator unit. So this picture shows that the incision has been extended, and a full view of the temporoparietal fascia flap. You can see that the temporoparietal fascia flap has been raised here, which covers the implant in a very excellent way. This is the closure. This is the well-healed wound and the implant in position. Device failures, not so common, but if it happens, a soft failure means the integrity test may be normal, but patients would be hearing excessive loudness, intermittent signals. You may have to actually explant and do a reinsertion. Heart failure, where there is an abnormal integrity test, mostly there would be history of trauma to these patients. Now, many complication rates, the averages from between 4 to 11% has been reported. The minor complications are from, say, 7% to up to 21%. This is the chart showing the complications which are patient, and I want to highlight that we had 9 patients who had wound necrosis and implant exposure, and with this temporoparietal fascia flap and re-exploration, we have been able to save five implants. So to complete my talk, the happiness of doing surgery keeps us sweet. The trials of surgery keeps us strong. Sorrow, which we saw during the last 1.5 years, keeps us human. And life, that is complications in cochlear implantations, keep us humble. So let's be all humble and keep on learning and doing things. Thank you very much for your patient listening.
Thank you, Dr. Panda. Thank you very much for your lucid presentation of complications in cochlear implant surgery. And with that humbleness being given as a message is a nice one. Thank you very much. I think we are all having a little running short of time, so I will request the instruction.
Thank you, Dr. Naveen Patel and Dr. Naresh Panda and Dr. Alan Chang for an excellent invited talks. As we're short of time, we will move ahead. Now we are going to go for the instructional courses now. The first instructional course is on radiology in cochlear implantation. I think, can I have Dr. Manoj's slide, please?
Yeah.
Dr. Manoj is going to anchor this radiology instructional course. I'm going to introduce Manoj Manikot and for the session to him. Dr. Manoj Manikot is the ENT and cochlear implant surgeon with special interest in hearing loss, dizziness, allergies, and even salivary gland and thyroid disorders. He's an invited faculty at all institutions in India, and he has performed live surgery at major teaching hospitals. He has delivered orations at major annual conferences, and he has presented scientific papers at many international conferences. He conducts a regular temporal bone dissection courses, and he has got a otology and cochlear implant fellowship programs at his center. He is interested in the research activity in association with the hearing groups. He has mentored and set up cochlear implant centers in India, Sri Lanka, as well as Vietnam. He has publications in both international and Indian journals, and he is also the reviewer for Indian Journal of Otolaryngology. Over to you, Dr. Manoj. So you can introduce your...
Hi, Shankar. Hi, thank you so much. Can you hear me?
Yeah.
Now, thanks once again for the organizers of CIGICON 2021 for this great opportunity given to us. And I also welcome my co-presenters, Dr. Neelam Ved, who you have heard before. She needs no introduction. And of course, the dynamic Monish Grover, who has actually made my talk totally irrelevant, but I still think we should go ahead with this. Now, we will be, this is the two of them. Neelam will be talking on the MRI for surgical planning, and Monish Grover on post-operative and intraoperative imaging. Now, we all know that dual modality imaging is a must. This slide is courtesy Sanjay Vaid. HRCT is assess the bony labyrinth, and MRI for assessing the membranous labyrinth. I shall not go into details of this, but basically CT for bone and MRI for the cochlear structures. So in short, the CT helps the surgeon, MRI helps the patient. Now, what does radiology tell us? It tells us, can we do implant at all? Will it be easy or difficult? Should we do at all? How should we do? What device to use? And what went wrong? CT for cochlear implants, we need a few basic requirements. We would say 256, but like Monish said in the morning, 64 would do. But the better, the bigger, the better. We need a small voxel size of 0.25 millimeter. A surgeon should have software to reconstructions, and contrary to what people believe, free softwares are available, both for Windows as well as iOS. You need to get axial sections in truly horizontal plane. This is something that I would really emphasize, but I shall go to that later. And you should also have the ability to read scans. It's not enough to have software, but you also know how to read them. And I hope by the time this instructional course ends, you people might have an idea, especially the young and inexperienced. When should you do CT scan? CT scan should be done just before surgery because disease can quickly alter CT picture. Like for example, a child gets an otitis media, your CT can change. So it is important to do it just before surgery. Is it necessary to decide cochlear implant candidacy? No, MRI is more than enough for that. So there are a lot of experienced surgeons who don't do CT at all, do just MRI. But it does help the surgeon. And of course, you must be aware of radiation in very young children, which is why when a 2-month-old, 3-month-old baby comes to you, You first do an MRI and then do a CT just before the surgery is posted. Now, there are a few things that you need to look at. The first look that you need to look at is an area. So you focus on this one picture alone. Basal turn, a round window abutting the basal turn, and the facial nerve and the posterior canal wall. And where you can see the three canals of the cochlea and three coil of the cochlea. See now, that is a round window and that is a basal turn. And when you go to the next picture, you find the three turns. I mean, the next slide is the same picture, but you see the basal turn, the second turn, and the apical turn. This is the one picture that you need to look at to find out if you can do your surgery without any problem. Now, in this picture, you also see the facial nerve, that you see a grayish mark just behind the promontory there. And you also see a facial recess cell, which as surgeons, we want to look at before entering the facial recess. You find it most of the time, even in a case which doesn't have any cells like this. This happens to be an 8-month-old baby. Now, imagine this happens. Now, you're looking at the posterior canal wall. That is your most constant landmark. As a surgeon, you would expose this area. And if you follow the posterior canal wall and do the natural direction of drilling, you would go like that. And what happens if you go like that is that you might end up here, there, which actually is a lot anterior than where you need to reach. So if as a surgeon you see this picture, you need to immediately understand that if you take a 30-degree angle from your natural direction of drilling, you would reach the basal turn. And this is something that you need to run through your mind before every surgery. Just look at this one picture. And there is a second picture that you need to look at. Of course, you do look at mastoidimatization, you do look at the chorda tympani, and you do look at the malleus and the stapes there. You look at the pyramid, you look at the cochlear aqueduct. A wide cochlear aqueduct can sometimes produce a gusher, if the middle ear is aerated or not, all that you look at. But this is the second picture that you need to look at. Now, this second picture is the level of the internal auditory meatus, and where if you draw a line, you might see structures anterior to that, that is a cochlea, and posterior the labyrinth. You need to look at an area where there is a ice cream cone. So here you find the cochlear aperture, which we will come to when we discuss something about anomalies. You will find, if you look very carefully, the interscalars partition. You need to have eagle eyes to look at it. It's better seen with an MRI, as Neelam would tell you later. You should see the vestibule, and you should see the vestibular aqueduct there. And how do you know it's a vestibular aqueduct? Because it's just posterior to the posterior semicircular canal that you see here. Now, you also, in this picture, you would see some things as well. You see the malleus and incus, you see the horizontal facial nerve, which is running above the oval window, and below the oval window, you see the stapes footplate. Sometimes, like Levin said earlier, you can get prolapse of the membrane through the footplate in an impending gusher. You have to look at that area. You have to see if there is air above the footplate. And you also look at the internal auditory canal, and whereby you try to find out, do we have anomaly or not? That's a very key area to look at in an anomaly. Now, the do's of CT imaging, like I said earlier, is to learn how to read images, flag anything inappropriate. Go back to my old slides and see that do you see all that, or do you have to flag anything that is not right? You ignore the unwanted, you remember your limitations, and always coordinate the radiologist if you have any doubts. Now, see what happens. CT imaging in very young children will give no additional data. So it is not an ideal tool also for intracochlear changes. For example, if you have something like meningitis, a CT could be extremely unreliable, though you have classifications on that. And the tilt artifact can be very misleading. Now look at this picture. See, that's a basal turn. You see the basal turn in both pictures, left and right. Stapes, both pictures, left and right. A round window, both pictures. I'm talking about left and right side. Cochlear aqueduct, both sides, and pyramid. If you see all 5 of them on both sides in one picture, then you know for sure there is no tilt. But look at this picture. You see the basal turn, the second turn, apical turn, on the other side only the basal turn. So you clearly know that there is more than a 2 to 3 millimeter tilt, which is not right, because here there happens to be a cochlear hypoplasia, and your measurement of the electrode length could be grossly wrong. Now, what is important? Like I said earlier, the cellularity is important, dimensions of facial is important, cochlear architecture is important, IAM diameter is important, too low could be bad, anomalies, facial nerve position is important. Like for example, here, the sigmoid is anteriorly placed, but it's really not going to matter to you. But here, the sigmoid doesn't look very prominent, but the anterior portion will make your surgery very difficult, just like the case narrated described earlier. What is not important? 3D reconstructions of cochlea look fantastic on your scans, but zero use. Brain detail is better seen in MRI. Emissary veins are not an issue, honestly. It is not an issue. You should know as a surgeon how to handle emissary veins. And one of the trainings that you have to do as a young surgeon is to know how to handle bleeding. And the fluid in the mastoid is not, unless it is an anomalous cochlea where it could well be CSF. Cochlear duct length. Monish, our next presenter, is one of the beautiful paper. Are we giving it adequate importance? Because we know that there is a large variation in cochlear duct length. It can go from 25 to 36 millimeter. Some of the metal electrodes are 32 millimeters long. So if you have a small cochlear duct length, you may not be able to put in the whole electrode. There are also some beautiful articles like this by Abdur Rahman, who's a good friend of mine. Is a lovely article where they have correlated cochlear duct length with the basal turn width. So that's what they do. They take this value, which is A, they have this value. See, can you see that? The measurements, the cochlear height, and they have actually categorized this and said that in males, the mean cochlear duct length is 32.39, in females 32.47, and the range could be between 32 and 28 and 37. Similarly, 15 and in males and females. And this is the outer organ of Corti and the lateral wall length, which are beyond the scope of this topic. So in short, cochlear duct length should be measured as a matter of routine. You have softwares to do it like Autoplan. You must have heard Kranti's presentation earlier in the conference. But by and large, most implants would fit in most ears. It's only occasionally that you could have trouble. And that one generally happens with anomalies. This is how you measure the diameter of each turn. Normally 1.8 millimeters should get in most of the implant that we have. Now, we also have an article, Sanjay Vaid and I, along with Neelam Vaid and Amit Zope, on the role of HRCT MRI in degree of difficulty. I would recommend all new surgeons to read it, where we have made a difficulty rating between 0 to 3, which would be no difficulty, 8 and above, prolonged and difficult surgery, where these things like, for example, facial nerve anatomy, posterior canal wall, sigmoid sinus angle, and all those things with the anomalies and degree of mastoid pneumatization, which could directly affect your surgical difficulty, whereas the jugular bulb and the direction of the basal turn vis-a-vis the posterior wall external aortic canal, like I said earlier in my beginning of the talk, has got no impact on surgical difficulty. Now, we need to have a flow chart for decision making. Now, this is what you do. So when you want to know which side you want to do, always it is radiology. When there is a radiology, if there is one ear that is better, you always implant the better ear. But if other ears are same, you depend upon whether they have audible hearing, non-audible hearing, or varying period of auditory deprivation. And only if radiology is same and there is audible hearing and non-audible hearing are equal in both ears, or auditory deprivation is equal, does the surgeon or the patient have a choice in dealing with what side you need to implant. So beginning of this flow chart is a radiology. So radiology generally decides which ear you're going to implant. Now, my friend Levin Senadoglu, I just with permission that I put the next few slides, he has given this beautiful classification. He said that if you understand cochlear implant malformation, you can time your surgery, you can choose what implant you need, whether it is CI versus ABI. You can find out if the child is going to get meningitis or a CSF gusher. And also we can make what kind of approach that you need to do and what type of electrode that you need to have. Now, this was already talked about by Monish in the morning. I'll do a quick run through. This is where complete cochlea is absent. This is CLA, Michel deformity. So labyrinthine aplasia could be there with aplastic petrous bone. So the trouble with this is that here the brain can be in the middle ear. So that could be really dangerous. You could have a labyrinthine aplasia with aortic capsule or without aortic capsule. A small cell here and there could not classify as cochlea present. So if you have this, clearly 100% indication for ABI. There is absolutely no chance for you to do a cochlear implant in this case. The next one, which is between this and the common cavity, you could have a small little bud without the internal aortic canal. Remember, this must be without internal aortic canal. So the rudimentary aortic cyst, again, clearly an ABI indication because there is no internal aortic canal, no nerve. You could have the next ones, which are cochlear aplasias. See, you draw a line through the middle of the internal aortic meatus. Here, you find nothing anterior to that line, only facial nerve, and posterior had the labyrinth. So you could have a cochlear aplasia with a normal labyrinth or with a dilated vestibule. Here again, line through the mid-AIC, nothing anterior, only posterior. So here, some people make a wrong diagnosis of a common cavity. This is not a common cavity because here there is no cochlea, and therefore it can only be treated by an auditory brainstem implant. Whereas this is a common cavity. So if you draw a mid line through the middle of the internal aortic meatus, even if you have a little bit of the sac anterior to the line, it is called a common cavity. So here you may get a CI, because CI, there will be structures in this cavity that is lined by hair cells, which may be connected to the cochlear nerves, and a CI could be done, but of course you must be very careful not to allow this to get into internal aortic meatus, and like what Monish said in the morning, it's called a letterbox technique by looping in the electrode into the common cavity. Now, cochlear hypoplasia is also of three types. You have cochlear implant hypoplasia 1, where there's a little bud which is much bigger than the rudimentary orthocyst, but also has got internal aortic meatus and a vestibule. You must understand the differences. Cochlear hypoplasia type 2, which is a cystic hypoplastic cochlea, big risk of CSF leak because there is no modulus. Or cochlear hypoplasia type 3, where there's a small cochlea less than 2 turns, and a cochlea with a hypoplasia type 4. Here, the very classical. You'll have a long basal turn and a little bud sitting at the tip of that. It's like a hockey stick. Now here, this is cochlear hypoplasia type 4. So in cochlear hypoplasia type 3 and type 4, you could still have some benefit with cochlear implant if you find a nerve there. So cochlear implants plus minus, but you must also understand these people can be there with normal hearing as well. Now, you could have an incomplete partition cochlea. This is incomplete partition 1, a big cystic cochlea, dilated vestibule, big CSF leak. Most of these people have meningitis. So if you have recurrent meningitis, you must be more or less certain it is hypoplasia, incomplete partition type 1. Or you could have incomplete partition type 2, the classical Mondini deformity with a dilated second and apical turns and a dilated vestibule with the normal semicircular canal and an enlarged vestibular aqueduct. Now, you could also have a type 3 where you have the interscala partitions and no modulus. And here again, the nerves are good. And generally, the outcomes in IP3 and IP2 match those of normal cochlear patients. So these are people for whom cochlear implant is generally done. But why did I put a question mark? Because some of these people may have a conductive hearing loss or even normal hearing. And please go and don't do a cochlear or a stepidotomy for this conductive hearing loss, because then that is when they become profoundly deaf. You have the enlarged vestibular aqueduct. Here, everything else is normal, modulus, interscala partition, vestibule normal, but you have a large dilated vestibular aqueduct where CI again query because some of these people can have normal hearing as well. Now, you have the cochlear aperture anomalies, which will be covered more by Neelam, but basically, if you have aperture less than 1.4 millimeter, there could be, so you can have a hypoplastic canal or an absent canal or bilateral narrow internal aortic canal. So if you have both all these things, they are called cochlear aperture anomalies. They are grouped under one classification. And most of them would need an ABI because they may not be a good candidates for cochlear implant. But however, if you have, like was discussed in the World Cup, I think, if some of these people demonstrate good aided responses, you could try a CI, but telling them that if this fails, they may have to go for an ABI. We also have a CT grading system for otosclerosis. Describing this would be much beyond the scope of this topic, but you must understand this. You could have a grade 1, which is solely fenestral here only. So you can see the small little thing just anterior to the oval window. Or grade 2, you have patchy localized disease, all this grade 2, B, C, A, B, C. A means only basal turn, B is basal and the middle turn, and C around the basal, apical, and middle turns, and C where there is a diffuse confluent involvement. So you need to know what kind of otosclerosis a patient has before you take them up for surgery. You may have some difficulty, but generally these surgeries go on well, provided you use a proper electrode without a perimodular electrode, without a full banded electrode. Why you need to know is that if you have autosclerosis and do a CT and you find a type 2 or C, and with a good speed discrimination, they go for cochlear implant. But however, if they have a poor speed discrimination, and if there is a low airborne gap, you have to go for cochlear implant. But if there is a good speed discrimination and a large airborne gap, they need to go for stepidotomy. So when you have a cochlear autosclerosis, it all depends a bit on what type of scan they have and what is the speed discrimination. This again is an extremely important slide, whether you want to do a cochlear implant or a stepidotomy, or you do give a hearing aid. So if there is a good speed discrimination, no airborne gap, hearing aid, and everything else, you would decide a surgical intervention. Just a small word about a bone conduction implant, which is actually beyond the scope of this topic, but I will give you a small little protocol. So if you have a young neonate with a bilateral atresia, you have to do a BC BERA, get a bone conduction threshold. If it is abnormal, do an imaging, and you have to, if there is a small airborne gap, you need to go for a surgical intervention. And if there is a fit bone conduction hearing aid with the BC BERA is normal, that 5 to 6 years do an imaging and go for surgical intervention, because some of these children with EAC atresia may also have a cochlear anomaly. So this is when you do a MR imaging if there is a abnormal bone conduction threshold. If there is a normal bone conduction threshold, wait and do a CT only at 5 to 6 years of age. So thank you so much. And I would hand over my presentation to our next presenter, Dr. Neelam Ved, and we shall be summarizing at the end of this. Thank you so much.
Ma'am, you need to unmute.
Neelam, you can start sharing your screen.
Yeah, I'm just doing that.
Yes.
Yeah. Is my screen on?
It is on.
Yeah, thank you. Thank you very much, Manoj, for the invitation, and to the organizing committee to be a part of this instructional course. A lot of what Manoj has said is going to be a part also of my talk, because at the end of the day, what we are really saying as a team that evaluates hearing impaired individuals is that we need dual modality imaging. So both HRCT and MRI have to be used together to get the best input that we can for the benefit of our patients. So why is it that we need this dual modality? What is it that MRI is going to add to the information already that Manoj has given us? The first thing is one has to realize that the MRI is the modality of choice to visualize the structure that we are interested in, which is the inside or the membranous labyrinth and the entire auditory pathway up to the cortex. So this is the only modality that's going to give us that information. It's going to be able to give us information maybe to answer the common question that most parents will have for us is, why is my child having a hearing impairment? So it might give us some information about the etiology. It will give us, or it will help us in decision-making about the options of intervention that we're going to offer. Are we going to offer hearing aids, cochlear implants, or we're going to directly tell this family that you're a candidate for auditory brainstem implantation, or maybe, sorry, we can't do anything. The choice of the implant definitely is influenced by the MRI. And the reason I say this is because let's say a child has some lesions in the brain that need constant imaging, then you've got to change the choice of your implant to have that implant which is MRI compatible. So the choice of the implant is also influenced by this. And most foremost is the fact that this is the one modality that's going to help us to predict somewhat the outcomes that we may be facing. The same slide that was put up by Manoj here. And what I want to stress when we put on this dual modality is, what is each one giving us? The HRCT basically is giving the surgeon a roadmap. But the MRI is what the team needs. So all of us, when we sit in that cochlear implant OPD and we are evaluating our candidates, I think the investigation of choice for us would be an MRI, because that's going to tell us how we are going ahead. And like I said before, it's this imaging modality that's going to be able to trace the entire auditory pathway right up to the primary auditory cortex. So let's look at the images that each part will show us. And here I have a comparison of the cochlea. How does it look like on an HRCT? And how does it look like on magnetic resonance imaging? What we are seeing here, these are images that are taken in a 3D format for cochlear implantation. And this is the same 3D format picture made in the MRI. I do agree with what Manoj said, that the reformations really look good on paper. And when we are doing an instructional course, I think, yes, we will show these images. Do we really use them in day-to-day life? We don't. What we do use in day-to-day life is this image. And this image is now showing us the internal structures of the cochlea, which is of very, very importance to us, because as surgeons, we want to try and insert the electrode array into the scala tympani. So on the MRI now, you can really visualize the internal structures, which are of utmost importance to us. You can see the scala tympani, you can see the scala vestibuli, and you can see the osseous spiral lamina. So this is very well visualized on the MRI, whereas in the CT, you see the interscalar septum very well visualized. So the CT, you see the ISL, whereas in the MRI, you'll see the OSL, the scala vestibuli, and the scala tympani. The next structure that you want to see, and that was again mentioned briefly by Manoj, was the more central anatomy of the cochlea, and that now we are looking at that structure which is known as the cochlear aperture and the modulus, which houses the spiral ganglion cells. Very important, again, to decide the implant that you want to use, and also what are the possible complications that you can have during surgery. So this is a picture which is on CT scan, but this is what we will see on an MRI. So an MRI, again, you're seeing the scala tympani, the scala vestibuli, and this grayish square structure that you're seeing in the center is the modulus. This is what it looks like on the MRI, and this is what it will look like on the CT scan. The important thing that you're getting in the MRI, which you're not getting in the CT scan, is the fact that the cochlear nerve is entering the modulus. And this is important because sometimes you can have a very, very normal anatomy of the cochlea, but you don't have a nerve which is entering into the modulus. And that again has an impact on your decision making. So this is a comparison of what you can see on both the modalities of imaging. And look at it here now, the cochlear aperture and the cochlear nerve going through the aperture into the modulus. The next structure that we're going to visualize as we are going up the auditory pathway is going to be your nerves. And when you look at the nerves and you're looking at the internal auditory canal, one has to remember that during imaging, depending on whether the imaging is taking a section through the superior internal auditory canal or the inferior internal auditory canal, the trajectory of the nerves is going to be different. In the superior part, you're going to have the nerves parallel to each other. That's going to be the facial nerve, and that's the superior vestibular nerve. Whereas in the inferior, it's more like a V or a Y shape, where the anterior one is the cochlear nerve and the posterior one is the inferior vestibular nerve. To visualize the nerves better, this section or this picture is the one that I think most surgeons are going to use to base a lot of their decisions. And this is a sagittal oblique reconstruction for the nerves. This is the plane in which this image is obtained. And what we are hoping to see here is what we call a glove with a baseball in it. I try to imagine this, I put this here, but really, I mean, it's beyond my imagination how they call that. But in any case, what we are trying to see is 4 nerves. So you're seeing the superior vestibular anteriorly, the inferior vestibular, sorry, posteriorly, the facial on the top, and the cochlear nerve below. And as you can see here, the cochlear nerve really looks the biggest. So this is again important, because when we are looking at anatomy and we're looking at cochlear nerve hyperplasia, there are two ways of measuring it. One is you compare it to the diameter of the facial, but now we have literature which has given us measurements of the cochlear nerve in the midpoint of the interauditory canal, and you can actually use that to decide whether this is a hyperplastic nerve or not. As we go further central, we now hope to give us, through MRI, the entire auditory pathway right up, because again, this is going to help us to decide candidacy and outcomes. For imaging the auditory pathway, what we're using now is the MRI here again. And look at the structures that you can see. This is the brain stem. And what you're seeing here is the interfascicular part of the 8th nerve. That is the facial. What you can see here, this is the inferior cerebral peduncle, and you can actually see the two parts of the cochlear nucleus. That's the ventral part there, and that's the dorsal part there. Further, when you look at the auditory pathway, you're now looking at the superior olivary nucleus, with some of the fibers now crossing over to the other side. The trapezoid body seen over here. And then as we go higher, the lateral lemniscus, the inferior colliculus, the middle geniculate body of the thalamus, the primary auditory, and the secondary auditory radiation. All this is visualized on the MRI. So any pathology in these regions can be well figured out. When we look at the nerves, what is it that's of importance to us? And we have this classification that was given to us by Castleman and Officius as far back as 1997, and it is still used today. You basically classify it into two types. A type 1, which means that the nerve is absent. So when you're going to look inside that sagittal oblique groove, you're only going to see one nerve. You can have a cochlear vestibular nerve dysplasia, which means if it's undivided 8th nerve, you're going to see two nerves, the undivided 8th nerve and the facial nerve. Then you're going to see an absent cochlear branch, but there will be 3 nerves there, and a hypoplastic cochlear branch. Now, whether these nerve anomalies are associated with an abnormal labyrinth or a normal labyrinth, it's classified further as A or B. To show you diagrammatically, or how it will look like on the MRI, this is a type 1 CVNA, which means a cochlear vestibular nerve aplasia. So that means there is no other nerve present here except for one, and that's the facial nerve. The next one is the type 2 undivided cochlear nerve, which means you're seeing one, which is the facial, and you're seeing one nerve, which is the 8th nerve. But there is no further differentiation into the vestibular and the cochlear parts. We next go into the next category, which is the type 2 ACB, which means there's an absent cochlear nerve. So you have the facial, you have the superior vestibular, you have the inferior vestibular nerve, but the cochlear is not there. And this is the hypoplastic one. And if you compare this to the image that I showed you before, we can see that this cochlear nerve is definitely smaller vis-a-vis the comparison to the facial nerve. The one imaging in modality where MRI is the most important, I think, would be labyrinthitis ossificans. And if we have any patient that has a history of meningitis or suspected meningitis, I think MRI is the modality of choice for imaging these patients. And you have this classification that was given by the BCIG, and that's the one that Sanjay and I use in our practice. Now I'm going to take you through the various stages of ELO to show you how an MRI really picks it up. This was a young child who was referred for imaging post an attack of meningoencephalitis. And as you can see here on the MRI of the brain, the child has active meningitis. There is enhancement of the dura. You can see a lot of the white matter enhancement, which is showing encephalitis. What the technician picked up and immediately pointed out to Sanjay while he was doing the scan was the fact that that cochlea on both sides was not looking very bright. So there was a signal anomaly that was picked up on the plain scan. The minute it was picked up on the plain scan, a contrast was given. And when contrast was given in the MRI, we can see that there is enhancement in the cochlea. That means this child definitely has now what we call the precursor stage of LO. That means there's active inflammation in the cochlea, and we need to warn the pediatrician and that this child has to be watched for hearing loss and evaluated further. So this is acute labyrinthitis and how it looks. Subsequently, the kid was followed up and we did a repeat MRI after 3 weeks. So now you can see what's happening to the fluid signal here in the cochlea. You can see that this is becoming almost completely black. There's very, very little fluid here, and compare it to the other part where there is fluid. So this is what's happening to the right ear. This is the left. It's becoming darker and darker. When it's becoming darker, that means the fluid in the inner ear is not lighting up. That means there is an intracochlear pathology that's happening. And subsequently, when we did the further imaging, as you can see, the left cochlea was almost lost. Luckily, the right was maintained. This patient was counseled to come in for an implantation. And actually, this was one of the few families that took a decision very, very early. And we implanted the right ear within about 6 weeks after the attack. The fibrous stage of LO, and this is another one where MRI is very important. What I have for you figures here is the CT pictures. And as you saw in these pictures showed by Manoj, this cochlea is looking normal. You're seeing a very good basal turn, a middle turn, and a apical turn. There seems to be no disease here. But then you do the MRI and look at the signal here. This is absolutely low signal on the right side. The left side, there's hardly any signal. So this fibrous stage of the LO is picked up only on MRI because there is no bone formation as yet inside the cochlea, which is why the CT scan is going to look normal. Remember, CT picks up bone and MRI picks up membrane or soft tissue. And you can see that the only way we could diagnose this was on an MRI. So some more pictures. This is CT. And again, look at the MRI pictures. You can actually see where there's fluid, where there's not. Gives you an idea of, are you going to be able to really insert the electrode inside? And if not, what are the other possibilities that you have to discuss with this family? So for LO, remember, it looks like a white out on HRCT, which means when you look at the structure anterior to the internal or tremiatus, everything looks white. And these patients are sometimes even diagnosed as cochlear aplasia. And this is something that one must remember because your radiologist and the technician who does this has to be aware that he or she has to change the settings of the bone to be able to distinguish between cochlear aplasia and a whiteout on an HRCT. And this is what it looks like on an MRI, which is a complete blackout. Internal tremiatus, we can't see any lighting of any signal anterior to that. The other place where MRI really has a very predominant role is on outcomes. And we've done a study, which I presented previously in CIGICON, but one has to remember that every patient that's evaluated for hearing impairment does not only undergo an MRI of the temporal bone. There has to be an MRI of the brain done, especially if these patients have other associated issues like torch infections, or if they have, which I will show you, something like ischemic issues at birth. So the preoperative brain MRI is the most important one that will give us an idea of adverse outcomes in pediatric CI recipients after implantation. Just sharing some images. This is a 3-year-old girl with a bilateral sensorineural loss. Look at the amount of hyper intense signals that she has in the periventricular white matter. Most importantly, she has anterior temporal cysts. This is a patient you're really going to be very cautious about counseling about the outcomes. So when we did the torch titers, they were pretty high with the CMV infection, but these are the sort of changes that you're going to see. This is a 1-year, 9-month-old, again, bilateral sensorineural loss. Look at this. There is a lot of subcortical white matter hyperintensities. There's a sign of hypomyelination. Again, in this child, we need to exclude torch before we go ahead and think about what we are going to intervene and do. This is the one that we see a lot, especially in premature children. This is hypoxic ischemic encephalopathy. Look at the amount of brain changes that these children have. So the MRI of the brain has to be also looked at, and not just as ENT surgeons and as professionals working with cochlear implantation. We shouldn't only be concentrating on the ear. How do you get the pictures that I've shown you? You need a very dedicated radiologist and a team, and I'm lucky to have one. But not every one of us can be married to a radiologist like Dr. Sanjay Vaid. So this is what I would suggest you share with your radiologist. When you're looking at getting these sort of images, what you are really looking at a 3 Tesla MRI. You need a 32-channel MRI, or you have to have dual-phase array coils. These are the sequences through which we were able to show you all these images. It's a very technical term, which I think your radiologist or the technician will understand, and I'm willing to share this slide with those of you who are interested. The brain MRI, however, is routine sequences. There is nothing special that's being done for that. How do you know that that MRI that you have in front of you fits the quality that you want? And there are a couple of structures that you should be able to see in that MRI image, which will tell you that this is an MRI of good quality. One of them is the identification of the Scarpa's ganglion here. You can actually see the macula in the vestibule, and you can see the inferior ampullary nerve. If you can see these structures in the MRI that you have, then you know that that MRI that you've got is of good quality, and it is going to fit the bill that you want. This is the sort of report that I am given when a patient goes for imaging. And again, like I said, it's an extensive report. A lot of people feel that's a lot of information, but each sentence in this report has an impact both on decision-making and the outcomes that we are going to try and predict for this child. The take-home message that my talk would be, we have to do dual modality imaging. We are not at that age where, that stage where we can say only MRI or only CT, at least not for those of us who are starting out. Always use a high field strength magnet. And if you don't have a 3 Tesla and you have a 1.5 Tesla, then you have to insist that they use surface coils. Optimize the sequence for best resolution. Use something called isotropic imaging, which is acquiring the images in one plane, and then you can reconstruct them in all the other different planes. Very, very important to strike a balance between image resolution and scan time. This is a procedure that's being done under anesthesia. You have to be sure that you cannot spend so much time acquiring resolutions of the appropriate images to the point where there is an engagement into the child's life. In all our MRIs, we have a pediatric anesthetist that is there in the MRI room during this is done. So this is very, very important as a take-home message, because you are going to be, now doing imaging for younger and younger children. As we are saying, early intervention is the way we are going ahead. Thank you so much.
You may start now. So, good afternoon, everyone. And at the outset, let me thank Dr. Manoj for giving me this opportunity. I especially felt happy when I got this topic because, when these two stalwarts have done their job, seen all the preoperative radiology, done their surgeries, by this talk, I go ahead and tell them whether they did the right job or not. Right. So it makes me feel good to present on this topic itself. Now, why do we need an intra or post-op radiology? First is obviously to confirm the correct placement of the electrode array. Right. We need to know whether we have done the surgery right way or not. The medico-legal importance is something we need to be careful about in today's era and a reference for future evaluation and researches. There are various modalities by which we can do this. Simply a portable plain X-ray film radiography. A better developed version would be a C-arm. Then you have things like cone beam computed tomography, a digital volume tomography, intraoperative fluoroscopy, and when you come to navigation now with the robotic CI coming into place, the navigation obviously comes into place. So we'll be discussing a few of these, considering it's an instructional course. When you're getting an X-ray done, or in fact even a C-arm done, right, the aim basically is that your central ray of your X-rays should be passing through the modulus, right? And that's when you actually get the best image of the electrode array running through. So this is your cochlea, this is your modular axis, and this will be approximately 45 degree or 50 degree to the mid-sagittal plane. So that's a range of 45 to 50 degree which we have. Now, based on that, we have had different kinds of views in the literature which are there. Now, Stenver's view, which was the first view, right, which we already were doing, was a 45 degree to the mid plane and a 12 degree to the horizontal plane. That's where your central ray of the beam would go. The modified Stenver's view, right, which is the most commonly used and was described by Marsh, was a 50 by 0. 50 would be the angle between the mid-sagittal plane and the axis, and it's purely horizontal in the main horizontal plane. So that's where the modified Stenver's view comes into place. And the cochlear view, so it's like a 45-0. If you go into literature, cochlear view and modified Stenver's have also been used interchangeably. But real description of them actually talks about cochlear view being 45 degree angle to the mid-sagittal plane and absolutely horizontal, and the modified Stenver's view 50 degree and absolutely horizontal. So it's pretty much similar. How to do it really is intraoperatively. If you're taking this image, you just tilt the head 45 degree towards yourself or 50 degree, whichever you want to, and such that the implanted ear is towards the lower side. So that's where the film of the, the X-ray or the C-arm will probably be, right? And so it's tilted 45 degree towards your side with the implant being on the lower side. That's how you go ahead, and the beam comes right from up downwards, vertically down. That's how you do it. So that's your cochlear view or modified Stenver's view. If you're doing a transorbital view, you actually need to do a Townes view for cochlear implant electrode array. So that's classically a 30 degree angulation to the horizontal plane, and that's how you go about do it. Intraoperatively, you just bend the head, flex it a bit, and just take an X-ray. Plain, simple vertical rays coming from top down. And that's how you do a transorbital view. Obviously, it's much better to do this if you're dealing with a bilateral cochlear implant or something, so that you get both the implants in one single view. Now, how do you interpret it? A well-placed electrode array should be fully inserted but not over-inserted, should have equally spaced electrodes. There should be a wide arc subtended by the electrode array in the shape of the cochlear turns, and this arc should be pretty gentle without any sharp turns. And we'll see a few photographs to really come to this. Now, this is what a good radiograph would look to me as, and this is the negative image of the scene. Right. If you really look at the structures which are seen in this particular video, it gives you a lot of information itself. So obviously this is the magnified view, right? This is the cochlea in which the cochlear the electrodes are actually running into it. You have the vestibule just above this. In this image, you can see the vestibule. Then you have the superior semicircular canal and the lateral semicircular canal, the middle ear cavity, and the oval window and the round window. So these are the structures you can identify on a plain radiograph. Now, you look at the Townes view, you actually see both the electrode arrays. So that's why it really helps you to assess the insertion on both the sides. The angulation is important, and we'll see why that is so. Now, one of the most important things which you really talk about is the angle of depth. And, till maybe a few years back, I was really confused how to calculate an angle of depth. It's not actually the depth of insertion, it's the angle of depth, angular depth of insertion, which is more important. How do you really calculate it? Is you draw a line, right? So it's kind of an imaginary line running through the axis of the superior semicircular canal, passing through the center of the vestibule, and the part where it intersects your electrode array, right? It's considered to be the round window, right? So that's your first line. The second line then goes through this intersection of the first line and the electrode array to the center of the arc, which is subtended by the electrode array. So it's kind of considered the modulus area. So you draw a line along the considered subjected round window to the modulus, And this line is actually a line which is used to calculate the depth of angular insertion. So this would be kind of a 360-degree turn, and then the angle which is extra angle beyond this line, you draw till the distal most electrode tip, and you add that angulation. So this becomes your total angulation, right? And by various studies, it's been, the adequate depth of insertion, it ranges from 420 to 60 degrees, 420 to 600 degrees, depending on the electrode which you're using and depending on whether you believe in a complete cochlear coverage or otherwise. But that's a wide range which actually exists. But important to realize what is your angle of depth in every post-op X-ray which you're actually doing. Now, if you look at the various companies which are existing, it's not going to read by names, but this is what you need to know when you're seeing a particular implant model which you're using. So that's a straight electrode array, the REST electrode array of Cochlear Limited. When you have the few stiffening rings outside the round window, this is the the perimodular 5-through electrode array, which is very near to the modulus. This is the advanced Pionex with its the 12 electrodes, 16 electrodes going inside, and then you have the middle. So these are very different kind of pictures which for every kind of company which you are doing the surgery for. The depth could be suboptimal in the way that it could be less insertion or it could be an over insertion, as you can see in this particular X-ray. So you need to be careful about that. Misplaced electrode arrays is when you don't get the gentle curve which you really want to see. So this is obviously a misplaced electrode array, and these are the indications when you need to really go ahead and do your CT scan to confirm it. And this was a case of malformed cochlea, common cavity, and so you see the U-shaped insertion which has come up in this kind of a malformation. Now, interestingly, this first X-ray would actually look pretty much normal to me, right? And that's kind of a C-arm view which we got. You need to look at whether it's actually been done in the right axis or not, right? Because the moment you turn it, actually you'll come to realize it's gone into your vestibule and coiled out there. So it's not like the cochlea which showing the curvature out here. It's actually in the vestibule. That's your superior semicircular canal. That's your later semicircular canal. So you need to look at the angulation at which the things are. This is again a misplaced electrode array going into the superior semicircular canal. A similar Townes view, a picture, image provided to me by Neelam Raj. If you look at, this is an IP1 anomaly which he operated upon, and you see this left side a very good curvature, and you see the right side, it doesn't give you that good an impression. That's maybe puts you in doubt whether you are really in the right place or not, and you need to take a lot of help in electrophysiology and your clinical sense in these pictures. So correct angulation, should you do a repeat X-ray maybe in this and take a good angulation, change the angulation a bit, you may actually get a perfect coverage as you see on the left side. And post-operative obviously can be confirmed with the help of a CT scan, and we just see that. Okay. Now you can also see tip foldovers in your intraoperative X-rays, which are an important indication of maybe trying to change it on the table if you really want to do that. You may have kinking in the electrode array. So these sharp things which are just outside the cochlea and inside the cochlea, not good to look at and actually lead to issues like short circuiting when you're doing your testing on those things. If you're doing a middle turn insertions, this is what you kind of see. It could be an antegrade insertion when you're going from middle to the apical. It could be a retrograde when you're going from middle to the basal electrode. So you need to know your clinical picture before you really comment on this. You can actually also check for magnet displacements, right? So usually you would have the magnet in the center of the coil area. If it gets displaced anywhere, this is the kind of picture which you get. And obviously clinically, the patient is not able to use the processor very well. And this particular picture will actually tell you where the magnet has got displaced and you need to deposit it back inside. You can also do cochlear stenting intraoperatively and check whether you are in the right place or not. This is one of the patients of which was having a cochlear ossification waiting for funds. Did a cochlear stenting in this patient, and that's what we got. Second part would be an intraop fluoroscopy. Now, the indications for intraop fluoroscopy would be academic, one to see the intracochlear behavior of the electrode array, especially when you are developing new electrode designs. But more importantly, clinical for us, it's a severely malformed cochlea or a severe ossified cochlea when using double arrays or something. You like to see a fluoroscopy picture. Now, it's simply taking multiple shots of short exposure with a C-arm and looking at the way your electrode is moving inside. Importantly, the patient is placed in anti-stenverse view, so the head is turned away from the operating surgeon, and you take short bursts of those X-rays which are there. And you get real-time pictures, and you know whether in malformed cochlea you're really inside the cochlea or go on inside the internal acoustic canal, and that's where it really helps you out. So that's where In-drop fluoroscopy is useful, especially for malformations like IP3 or IP1 with deficient lamina creprosa. So that's your plain X-ray. Then you come to CT temporal bone after cochlear implants. Now, indications for this would be again academic purposes. More important to see the scalar position or scalar location at times. It is also important to do this if your X-ray shows that there are issues with electrode placement, or you're doing a revision surgery, or you'll end up with any complications. And obviously, this is where the role of cone beam CT also comes into place. Now, post-op CT, you could have misplaced electrode arrays anywhere. Here we see it's going into the hypontine pinna, probably into the subcochlear canaliculus. It's going right near the carotid canal in this particular patient, entering the carotid canal, right? Then you can have insertion inside the vestibule, which we saw even on our X-rays, and then going into the eustachian tube, going to the nasopharynx area. So people have put it on the wrong places where you can imagine, and that's where imaging really helps us out. And obviously a malformed thing, you can have an electrode array going into the internal acoustic canal. Now we discussed this picture just a few minutes ago, and you look at these two, the arcs which are subtended by the electrode arrays, and it seems the right side may be not proper, but if you look at the CT scan done after the surgery, it shows the electrode insertion beautifully in the IP1 anomaly, which you're able to make out. And the electrode is really running around the lateral wall of this cystic cavity, which makes it a beautiful insertion and a successful surgery. You can also have implant site infections, and Dr. Manoj actually provided me with these photographs, which you know, if you're assessing it properly, the CT would provide you that there's a fluid collection beneath the implant, and excessive separation from the underlying skull would actually indicate towards that. And it will also tell you a better spread along the infection beyond the well. The CT would actually be very happy to deal with it. Just a few words on cone beam CT scan. It's a kind of a differentiation from conventional CT scan, because conventional CT scan has a fan-shaped thing. The rays are coming in a fan shape. It's basically a very narrow cone in a cone beam CT. This is good for in the sense that there's a lesser exposure to the lens of the eyes which we have. So it's better for the patient. The advantages of a CBCT would include that there is a higher spatial resolution with decreased metal artifact of the electrodes. You can see this in the photographs which are presented out here. The acquisition time is much shorter, and a rapid scanning time is there. That's why the acquisition time is shorter, significantly lower radiation dose, and a reasonable price to it. The disadvantage of what my radiologist tells me is that this is a highly sensitive modality for motion artifacts. So the head has to be perfectly still during this time of 40 seconds, which are existing. Now, when looking for paracoronal images, they are best for scalar location to the sensitivity to tune of 100%, specificity of 90%. So this is a paracoronal cone beam CT. Your radiologist can actually provide you with that. And what it really shows you is this, in this particular patient, the electrodes are migrating into the scala vestibula. This is where your scala tympani would be, and this is going into the scala vestibula out here. Scalar translocation may also happen. If you look at the figure on the lower left side, it's in the scala tympani, but just the next image to it actually shows it's going translocating into the scala vestibula. And that's where a CT would actually, especially a cone beam CT, would overscore over a normal X-ray. Suboptimal insertions, as we can see on X-rays, it can also better be seen on CT scans. These are incomplete insertions, a tip fold over, kinking inside the cochlea, just outside the cochlea. And if you hit the lateral wall and you're trying to just push it against resistance, this is what happens to electrode array. So all these are pretty much visible. Your electrodes are known to migrate out. So if it's, this was actually an image of an over-inserted, the electrode array. If you see the first electrode actually pretty much inside, and with time it actually itself kind of came out and the electrode migrated on. This can happen even in well inserted, optimally inserted electrode arrays. A line on MRI after cochlea, the MRI compatibility in the majority of implants which are available are now 1.5 Tesla compatible, and you can do MRI of any part of the body with the implant inside. However, their advanced versions are available with 3 Tesla compatibility. That does not mean that you will be able to image the whole of the brain with these kind of an implants. So visualization is affected because of the magnet which is present inside. And if the magnet is present inside, almost 1/2 of the brain cannot be visualized. So if you're looking at a patient with acoustic neuroma or a patient who would require repeated imaging of the brain, it's better to have an implant which allows you to remove the magnet and not have issues with MRI later on. Important question which comes to my mind and has been asked many a times, and I've asked it many a times, is it really required in all the patients? Intra-op X-rays, right? 2017 Laryngos article at systemic review, actually it's mentioned that current literature is not conclusive regarding the utility of routine imaging, but it appears to be most useful with abnormal cochlear anatomy or when the surgeon questions placement. So that's about intra-op. If you're not doing intra-op, always do post-op, that's for sure. It's only about doing whether we need to do it intra-operative or not. Ideally, yes, you would want to do it in every patient when you're doing a surgery. When can you avoid, right? In my experience, that's what I would do now. If you've already done about 100 cochlear implant surgeries, that's just an approximate figure to it. And you are pretty well versed with the kind of resistance which you're facing. It's not a new electrode array. So almost 100 implant surgeries done with normal preoperative radiology, good smooth insertion and an uneventful surgery, and a straight electrode array, because a perimodular or a modular sucking electrode array has a chance of a tip fold over much higher than what a straight electrode array would. With normal intra-op impedances and E caps, the input given by audiologist, I might actually avoid an X-ray. So ideally do it in every case, but if you are having any other issue, if it's a malformed calcula or the insertion is not really smooth, you did multiple trials, you're doing the perimodular electrode array, always do an intra-op X-ray. Thank you.
Okay, I'm going to take over from there, Manish and Manoj and Neelam. That was absolutely fabulous course in radiology, and definitely instructional in every way. The terminology is used, instructional course. We are not going to entertain questions because we're really running 40 minutes or so. So let's move on to the next instructional course. Can we mute everybody, please? Instructional course is on problems during CI surgery, and to moderate this, I would like to invite Dr. Amit Kishore, and his co-presenters would be Dr. Kapil Sikka and Dr. Shankar Madikeri. All three have been introduced in this conference. So over to you, Amit Kishore.
Good afternoon, Sunil and everybody. Am I audible and are my slides visible, please?
Yes, yes.
Wonderful. Okay. So good afternoon. And for this particular instruction course where we are talking about problems that we might encounter during CI surgery, I have with me Dr. Shankar Madikeri from Bengaluru and Dr. Kapil Sikka from AIMS in New Delhi. Now, I was going to, so the plan was that I was going to just lay the foundation for this. So, of course, as surgeons and one part of a bigger team, we have to do our bit to ensure the best possible outcomes and anticipate and manage potential surgical challenges so as to minimize complications. And in this situation, we are aware as surgeons that we could have potentially one or more of the following. You can have issues with the flap, hematoma, infection, necrosis, issues with the device, migration, extrusion, facial nerve trauma or injury, issues with round window access, either trauma to the external canal, difficult exposure to the round window, thus resulting in electrode misadventures, a contracted mastoid, making that very difficult, and getting it hard to get a correct angle of insertion. In the process, we may land up damaging the electrode or the intracochlear structures. We may have incorrect placement, incomplete placement, or extrusion of the electrode. We may encounter perilymph, more importantly, CSF leak, and if the electrode goes into the vestibule, dizziness. So these are the things that we as surgeons have to keep in mind. And of course, the very simple adage is prevention is better than cure. So I was going to talk about some of the basic things, but I'm going to stop here because Dr. Madikeri, I think, has something to attend to. So he's requested that he do his presentation. So I'm going to is Dr. Madikeri there, sir? Hello?
Yeah, I'm here, Amit.
Would you like to go on or would you like to take over or should I? Okay. So I'm going to stop sharing to discuss. So my bit. So what we have done is that we have sort of divided the topics, and I was going to show something, and then Dr. Madikeri and Dr. Kapil. So I'm going to stop sharing, and then Dr. Madikeri is going to do his bit, and then I will come back after he's done his part.
Thank you. Can you see my screen?
Yes, sir.
Yeah, thank you. Thank you, Amit. Yeah, I am going to show some problems which I faced during CI surgery and how to tackle them. I'm just going to share 3 cases and videos. So one is a partially obliterated cochlea. And the second one is a forward sigmoid sinus with a very narrow facial recess and difficulty in finding the round window. And the third is a case of revision surgery where the first surgery they had placed the electrode in the extracochlear placement of the electrode. Okay, to that, this was an 11-year-old boy who had suffered meningitis 1 year back, and then he came with a bilateral profound hearing loss. His loss was detected because the boy's performance in the school was deteriorating. Could not benefit with the hearing aid and speech therapy. So his CT scan was showing the partial obliteration of the cochlea, right side less compared to the left. Left was both first and the basal and the middle terms were blocked. So whereas in the right side only the basal term there was a partial block. So with this case, decided to do a right-sided cochlear implantation. We have done a cortical mastodectomy and a posterior tympanotomy. As you can see here, with a 1 mm stator drill, I am drilling the first cochleostomy, which has been done anterior-inferior to the round window. Then I am gradually thinning the incus buttress, and I am going to remove the incus buttress and then dislocate the incus from the stapes head and remove the incus. So that now I am able to see the place anterior to the oval window. This is the stapes. This is anterior to the oval window, and this is the processus cochleariformis. This is the area where we usually drill for the second cochleostomy into the second term. One should be very careful when you are drilling this. You have to be more vertical because just anterior to that area you will get the carotid artery. So here we are inserting a double array. This was the apical array which I inserted through the second cochleostomy, which contains 11 electrodes, but I was able to put only 7 electrodes inside. So after this, there was another basal array, which I'll be showing you shortly the diagram. The basal array was introduced through the first cochleostomy. So whereas we got about 8 electrodes in the basal term and about 7 electrodes in the middle term. So as you can see, this is the double array manufactured by the Cochlear company. You can see a basal array. There are 2 helically wound bleeds which come out of the receiver stimulator and immediately they divide. So the basal array has got 11 electrodes and 1 to 11, and the apical array has got 12 to 22. So you can differentiate this because there will be 1 less stiffening ring on the apical array. And there is 2 ground electrodes, MP1 and MP2. It's a ball electrode and the in the receiver stimulator base itself. So this was the audiogram, aided audiogram with the implant, which was done after seven years of in 2019. It was operated in 2011. The implant before because after this surgery, he finished his graduation. He did a BCom, and then he got a job he has been doing. And just before he went to Australia for his further extension of the job, we did this, showing a good responses in the speech frequencies within the speech banana. So the post-meningitic hearing loss, the labyrinthitis ossificans can happen anytime after meningitis, even as early as 15 days. So there is not able to predict the occurrence of labyrinthitis ossificans, when it happens and in which cases. But we know very well that the auditory performances are poorer with partially implanted patients. That is why hence this thinking of cochlear stenting came into vogue. This was described by Dr. Milind Kirtane. So when you know that the patient is going to develop as a profound sensory neural hearing loss post-meningitis, in case in our country, if the parent doesn't have the money, so it is better to open up and do a mastodectomy and posterior tympanotomy and cochleostomy and put a stent, like either you can put a depth gauge or a dummy electrode and leave it. And whenever they get the funds, so we can go ahead and remove the stent and then put the active electrode array. So it is always advisable to do an early bilateral implantation in cases of bilateral profound hearing loss, which happens after the meningitis. So this was the second case of forward sigmoid sinus with a narrow facial recess and difficulty in finding the round window, which I did it in one of the mentorship centers, where we have done an anterior transposition of the posterior canal wall and cochleostomy insertion. So as you could see, there was a corner septum which I had to open up to enter the mastoid antrum. And you can see very well the sigmoid sinus is quite forward. It is almost touching the posterior canal wall in the lower part. And there was a very, very narrow space for the facial recess to be opened up. Still, we did open up, did the posterior tympanotomy, and I was able to open up the middle ear, but it was a very, very narrow exposure. We were not able to see the details like the incudus-stapedial joint or the round window in this particular case. So after even trying other methods of thinning the posterior canal wall and changing our orientation from inferiorly looking at it, we were not able to identify the round window. There was hardly a very small glimpse the round window was visible. Then we decided to do two vertical cuts, one superior and one inferior. These cuts were through the bone only, without damaging the canal skin, but it went from lateral aspect up to the tympanic annulus. And once we did these two cuts completely, then with the help of a periosteal elevator, you could see the bone between the two cuts was pushed forward along with the skin attached to it. Now you could see there is a bigger posterior tympanotomy. We were able to see the promontory and this area, but still the visualization of the round window was not complete. Only there was a partial visualization. So because of which we decided to do a cochleostomy. So the cochleostomy was done anterior inferior to that whatever round window, just margin we could see. But we were able to do a good cochleostomy. And then I have used advanced bionics 1G electrode in this case. So with the help of the introducer, I was able to insert the electrode array completely into the cochlea through the cochleostomy. And then we sealed the cochleostomy with the connective tissue. And at the end of the surgery, I reposed the posterior canal wall, which was anteriorly displaced, and we were able to manage this situation effectively. So what are the difficulties in finding the round window? When they have difficulties, what are the tricks? There is a proper thinning of the posterior canal wall and drilling the bone in front of the facial nerve, and sometimes inferior extension of the posterior tympanotomy as much as possible. And sometimes changing the orientation towards the middle ear, turning the table towards you, and visualizing, arranging your microscope in such a way that from inferior aspect of the posterior tympanotomy, you are able to look into the middle ear, and maybe you may be sometimes able to visualize the round window. Or in case if necessity arises, so in some cases, mobilizing the posterior canal wall by two vertical cuts and pushing it forward with the canal skin attached and repositioning it back at the end of the surgery, as we did in this case. The other option would be, if you are not possible to do all these things, one can do anterior tympanotomy. I thread the electrode from the posterior area and then insert it into the round window or the cochleostomy from the anterior tympanotomy side. So this is one way of finding out preoperatively whether you are going to have a difficulty in identifying the round window. On the axial cut of the X-ray, so you draw one sagittal line, and then you draw two lines on either side passing through the basal turn of the cochlea. So the angle created between these two lines is called as an alpha angle. And there is one more line can be drawn through the posterior canal wall. This is a yellow line. And the angle between this yellow line and this green line is called as the beta angle. So an alpha angle of less than 50 degrees and a beta angle of more than 20 degrees, if you find, then one should expect difficulty in identification of the round window and be prepared to tackle such situations on the table. So this was another extracochlear electrode placement in one of my another mentorship centers during the first surgery. It was a 1-year-old child implanted 1 month back in one of the centers. They did not get any neural responses on the operating table, and they took a CR picture which was not very conclusive. They did a post-operative CT scan which showed an extracochlear electrode placement. So as you can see here, the electrode array has entered through the cochleostomy, just the basal turn, and then it has come out of the lateral wall of the cochlea, and then again it has gone into the hypotympanum, and then later maybe high up between the carotid canal and the jugular bulb, that is the crotch area. So this case, we did the revision surgery for this case. So when we opened up post-orally, we could see the receiver stimulator, and we cut both the active and the ground electrodes. We removed the receiver stimulator. we removed the ground electrode. In this case, it came out easily. Otherwise, sometimes there will be some bone growth happening around the ball electrode. It is difficult to remove. So I had to little bit revise the mastoid cavity because there was already some amount of ossification had happened. So I had to widely open up the particle mastodectomy complete, and there was a lot of fibrous tissue surrounding the electrode array, which was curled in the mastoid cavity. So that we had dissected it very cleanly and delicately without pulling out the electrode. So with the help of scissors and the sickle knife. Then in this case, I had to widen even the posterior tympanotomy, which had a little bit obliterated, especially drilling the bone just in front of the facial, as well as in the inferior aspect, as I mentioned earlier. So to create a good posterior tympanotomy, to have a good visualization in the middle ear, you could see the active electrode array there in the middle ear also here. So after this, I dissected out the thick granulation tissue with the help of a right angle pick in the middle ear. And further, I thinned the posterior canal wall. So with these maneuvers, we were able to identify the round window niche. So once I was able to identify the round window niche here, so I took a 1 mm skeeter drill again, and we opened up the upper lip of the round window, as you will see very shortly. So once I opened up, can you see now drilling the operculum of the round window, which exposed the oval window. This is the oval window. I am moving the incus, and you could see, I don't know if you carefully whether you can make out the movement of the round window. So we identify the round window properly. Then we decongest this area with adrenaline gel foam, and then after that we came back, and now I am pulling out that old electrode array. You could see how much kinking has happened in the electrodes, as you see here distally. So there was no way I could have used the same electrode. So now I'm using a 23 number hypodermic needle to puncture the round window membrane. You could see a little gush of perilymph coming out from there. So once then now I'm using a dummy electrode first, because there was already a false passage. I didn't want my active electrode to go through the false passage again in the outside the cocktail. So once I put this dummy electrode, then we took a C-arm picture, which showed that it had not gone into the wrong path. It was inside the cochlea, turning inside the cochlea. Once we make sure, then I opened up the new implant, placed it in the bed and cut it. Then I pulled out slowly the dummy electrode. Then this was a cochlear nucleus 24 straight array, full band electrode, slowly and gradually inserted through the round window again, and sealed the round window properly with the connective tissue. And the ground electrode array was pushed under the temporalis muscle, and again we took the C-arm picture where you could see the electrode array again inside. We measured the impedances. The 6th and 7th electrode, 5th and 6th were open circuit, maybe because of the air bubble and the lateral wall dehiscence. And we did the NRTs. We could get the NRTs beyond the 7th electrode in all the things. Basal electrodes we could get because the earlier transgression of the basal turn, beginning of the transgression, with maybe some amount of fibrosis and all, we could not get it. Okay, so thank you very much for your patient listening. So that is my presentation over. Thank you, Amit, for giving me an opportunity.
Thank you, Dr. Medicki. Thank you, sir. Okay, so we'll go on, or I'll go back to what. Okay, there we are. So, am I visible?
Yes, you are.
Yes, wonderful. Thank you. So, yeah, going back, a reminder of all the problems that we might face. And right. So, as I said, prevention is better than cure. Now, Dr. Medicki has shown some advanced issues. Dr. Kapil will also show some advanced issues. I'm focusing on some of the simpler, some of the simpler issues, and that's because we still see them. So we're going to talk about flap necrosis, facial nerve injury, and a few other things. Now, it's really painful that even at this current day and age, we still see these situations of device migration and flap necrosis and things like that. So, and some of these are very recent pictures. So that is why I thought that I will once again go over this. This is an instructional course, and which will include novice and upcoming surgeons. So I thank Dr. Manoj for allowing me to borrow this slide. The first step I think we have to keep reminding ourselves is asepsis during cochlear implant surgery. This is not routine middle ear surgery. It is, I tell my juniors that think of orthopedic implants and look at the level of asepsis that they follow. So just a reminder that whatever hair shaving has to be done should be done only limited around the incision and just on the operating table. I beg your pardon, not a day before. Use preoperative surgical scrub, whether it's twice beta scrub or betadine and spirit. Always use prophylactic antimicrobial agent or antibiotic based on your own criteria. Try and use disposable drapes wherever possible. You've got to take real care, and it pains us when we as mentor surgeons go often to other centers and find that this is being treated like any routine middle ear or mastoid surgery. We do not allow Sidex or formaldehyde, steeped instruments for cochlear implant surgery. So it sounds very simple, but I think it's very, very important that we continue to adhere to the principles of asepsis. To prevent things like device extrusion and flap necrosis, there are a few fundamental principles. And the fundamental principles are of incision and flap and bipolar. So whatever device you use, in whichever method you want to use it, you've got to ensure that your incisions are well away from the potential position of your receiver stimulator. Always use a double flap technique, irrespective of what flap you use. It could be a posteriorly based flap, as is shown here, or a superiorly based or a large palva flap. It doesn't matter as long as you use staggered incision, double flap technique, good pre-incision hemostasis with infiltration. Please do not use monopolar cautery. If at all, use bipolar, and that to minimal, because that will reduce the trauma and avascularity to the flap. We are operating now on very young children, and you have to be very, very cognizant. They don't bleed very much if you've got good infiltration beforehand. So do take care of the flap and adhere to tissue handling principles. Device stability. Now, there's a lot of talk about just putting the device in a pocket and making a bed. And I know that a lot of experienced centers surgeons may move away from making a proper bed, but I will tell you that even 1,500, 1,800 devices down the line, we still want to have some sort of a bed. We are in a different scenario, in a different society. These are self-funded implants, resources very, very limited. We cannot afford to have a reimplantation or another surgery if a device gets extruded. So we believe, or I believe, and lots of us who are experienced surgeons do believe that we should still form some sort of a device bed, and I still would like to fix the implant and have a nice channel or a tunnel wherein you can ensure that your electrode array is below the level of the bone, because one of the pictures I showed you is where the exit array is extruding or lateral and has been traumatized by the pressure of the processor. So whether you use the older devices, whether you use the more recent flatter devices, still make a bed. And I think the most important part is having your anterior edge and inferior edge well defined, because the most common areas of device slippage are is more anterior inferiorly. So ensure that you've got a good bed to hold your device. And then I still, as I said, use fixation sutures. We use, for many years, I've moved to using Ethibond, moved away from Vicryl and nylon and Prolene, because the knots can cause a problem. So sounds very simple. You may think it's superfluous, but we are still seeing issues with device migration. So please adhere to those. The next common problem, not common, but next problem that we still see is facial nerve injury. And this is something that we should not, as experienced ear surgeons, be wary of. The facial nerve should be, like we all say, should be considered a friend. We don't have to run away from it. We need to understand the anatomy. We need to understand the radiology. And yes, it's desirable that if you do have access to a facial nerve monitor, please use it. Do not depend only on it. It is only a guide. It's a help. It is not, and I repeat, not a substitute for good image reading, good knowledge of anatomy, and surgical technique and practice. But it's a good thing to have. And if you do have it and intend to use it, then my suggestion is use it in every situation. Don't use it only in the difficult situations, because then your OT technicians and staff would not be accustomed to setting it up. So that's one thing that you can take time. So facial nerve. So this is just a video to demonstrate some simple things that should be followed. So the simplest way to avoid injury to the facial nerve, in my opinion, is to know where it is. So you don't just drill based on the landmarks of the short cross of the incus and the canal wall. You, of course, will thin it. But if you can identify the facial nerve, then you can be more confident. You may choose to go down the digastric ridge and identify it like so. You may choose to identify it along its vertical part of this after the second genu. And once you see the thin bone on the facial nerve with the blood vessels under it, you can see that facial nerve. You can see the chorda tympani nerve when you're drilling. Use slow drilling, use lots of irrigation, copious irrigation, because you do not want heat injury to the facial nerve. But as I said, once you have seen the facial nerve, you can drill right down onto it. You can drill on the chorda. You can get a nice wide exposure through the posterior tympanotomy, and you're not going through a tunnel, and you're not worrying that, should I be drilling more? I might injure the nerve. So look for the nerve, make it your friend, and then you can access the middle ear through that nice posterior tympanotomy with ease. So in that process, yes, sometimes we are scared. We go anteriorly, and this was done by one of my mentee surgeons, and he was unsure. And this is something you need to avoid, that you go anteriorly and you come into the external ear canal, and you get, as Sunil puts it, the dreaded betadine sign. So Dr. Kapil will discuss that in more detail, but this is something you want to avoid. And you avoid it by, again, I'm repeating, identifying where the facial nerve is. Dr. Medicari has already talked about other little tips and tricks to get good access through the posterior tympanotomy, because that is going to get you good access and angle of insertion into your cochleostomy or round window insertion. So thinning the external canal, positioning and tilting the head, and drilling down to the facial nerve if you know where the facial nerve is. Sometimes you don't have good access. You have a very, very anteriorly placed sigmoid, and Dr. Medicari has shown you beautifully how to deal with it. He's talked about the anterior approach, which I'm going to show here. So this is a right ear with the sigmoid sinus completely close to the posterior canal wall. No way I'm going to get the posterior tympanotomy. So here we use the dual approach. So remove the incus, thread, lift up the tympanomeatal flap, identify the round window. This is one of the few instances where I would resort to lifting the tympanomeatal flap. Thread the electrode array through the space of fossa and space here into the middle ear space. And after having created your anterior inferior cochleostomy, you will have to do that because it's not, the angle is not right for a pure round window insertion. You will need to drill away that anterior inferior bony ledge, and then you can gently, using forceps or using a claw, guide your electrode through the small antrotomy and down into the middle ear space and thread it comfortably into the round window. So this suprameatal approach can be used and should be in your armamentarium should you need it. And this is something that you can predict, of course, on your imaging, on your CT scan. If you've listened to the talks of Manoj, Neelam, and Monish, then you would be well versed in reading your imaging. There are situations where you're going to get a CSF leak. Again, if you're aware of the imaging and you're aware of the anatomy, you can anticipate that. A CSF gusher is possible in an IP3, an IP1, a cochlear hyperplasia 2, and sometimes a common cavity. Now, the key factors here, number one, is to be prepared that this is something that you're going to anticipate. The second is that when you do get that, so you're aware of it, I know that I'm going to make the cochleostomy or enlarge the round window, and I'm going to get CSF. So I do that, I elevate the head, and maybe I tilt the head down first, let some CSF drain, then I'll elevate the head, allow some of the CSF to drain. But it's not going to end. You're not going to, this is not a perilymph pulsation, this is a CSF leak, and it's going to continue. So at some stage when the pressure comes down a little bit, you're going to have to be prepared. So you put on your diving goggles, your snorkel, and you're going to dive into that water space with suction. So you have yourself or your assistant holding the suction while you then visualize your cochleostomy. You're prepared with the appropriate electrode array that you're going to use depending on the anatomy that you have. And you, under that, excuse me. Oops. So, yeah, so, and then you sort of gently insert the electrode array. You will find sometimes that the CSF pressure is pushing the electrode out. So you're battling with that pressure, but slowly and gently and surely you will get there, and you'll be able to insert that. Once you've inserted the array, you have to be prepared beforehand with strips of periosteum or with fascia to plug. The cochleostomy must be larger. Now, contrary to intuition, you might think I'll make a small cochleostomy, I'll get less of a leak, but no, everybody will tell you that, and it's been talked of, have an adequate size cochleostomy because you need to have a good plug around your electrode insertion. So you've got to plug it really tight with these strips of fascia and periosteum. You may wish to use tissue glue, which we used in this situation, to ensure that everything stays in place. You may, often some may decide to have a lumbar drain inserted if you want to keep the pressure low. I've never had to use or resort to a lumbar drain so far, and we got away with it. But that's something else. You may want to use medication like acetazolamide to keep the pressure down for the first few days post-operative. There is this, just to mention, the form electrode devised by Levent Şeneroglu, which is also used in these situations, and that conical little plug fits into the cochleostomy beautifully. So be prepared to deal with CSF leaks. If you're prepared and you know what to do, it's not that big a problem. We have heard extensively about electrode misadventures, and I'm not going to go over it, but suffice to say, and I'm going to reiterate what you heard in the previous instructional course, I cannot reiterate it enough, that you need to know your anatomy and you need to know your imaging. So this is not a situation that you need to be in. You know, I've heard of a situation and been wherein somebody just called one of the mentor surgeons, you know, after a few hours of surgery, and there are videos on the internet open looking for the anatomy. This is not a good situation to be in. So the situation that you need to be in is you need to know your anatomy. And as you heard from the previous talk, I think it's a good idea for the novice surgeons to understand this paper by Ved and Manoj on the role on grading your degree of difficulty. In fact, we used it to sort of validate it, if you like. And this was presented a couple of SIGIs ago, and one of my fellows used it on about close to 150 patients, and we found that the predictability in many situations was good, particularly in looking at the facial recess axis, particularly looking at the angle of insertion and therefore ease of insertion. So it's something that we would recommend. It's a good practice. If nothing else, it will give the novice surgeons a very good thought process on reading and understanding the CT scan. So please do look at that. A quick word, Monish has already covered this in the previous talk about cochlear anomalies. You will face it, and I think it's important in those situations where you have an IP3 or a common cavity to use intraoperative fluoroscopic guided insertion to ensure that you get snapshots of video, so that with every few millimeters of insertion, your assistant is looking at the screen and telling you that you're getting a good curve and your electrode is not going to the internal canal. So these are, I've covered some what appears to be basic things, but as I said, my principle is that prevention is better than cure. So if we take simple steps, we can prevent problems. I'm going to stop sharing now because next we are going to get Dr. Kapil Sikka to share some of his experience on how to manage problems. Kapil, over to you. You're muted. Yeah, that's it.
So my screen is visible, sir?
Yes, it's visible and you're audible, Kapil. Thank you.
Thank you so much, sir. And it's humbling to be in company of you and Dr. Medicari, sir. I'll be just presenting few tips and tricks which in my limited experience I found useful and important, and discussion with sir, he had repeatedly reiterated the fact that prevention is better than cure. So my if you may call it take home message to all youngsters here is that invest on your knowledge, invest on your skill, and also invest on your equipment. In ROT, particularly if I am operating, it is must have to have a good microscope and a nerve monitor. But as sir has already said, it's not a must have, but should have a type of thing. So I was given a task on presenting the difficult situations that are three: infected ears, the breach of canal wall, and an unusual case where we had to revise the previous cochlear implant surgery. First things first, if we look at the infections in ear and the cochlear implantation, the one question that comes to our mind is, should we be implanting these patients or in these scenarios? So the simple answer to this question is no if there is active infection, and yes if there is no active infection, then why not? If you look at otitis media with effusion, some might consider this also as an infection in many scenarios. But if we look at literature and our own experience, there is abundant literature, abundant evidence that this is not a contraindication for cochlear implant, except for slightly prolonged surgery that it takes. There is no other problem, there is no other contraindication, and you can go on as usual. The problem arises when you deal with patients who have got chronic discharging perforations and cholesteatomatous disease, whether there is a cholesteatoma. So there are three problems in these scenarios. One, you have to clear the disease. Two, you have to clear it very, very thoroughly. You may talk about CT scan, MRI in post-operative period, MRI compatible implants, but there is no foolproof radiology after cochlear implantation. And third is, of course, that you have to keep that implanted implant free from a future infection. This is fairly standard now. If you are looking at implanting an ear which has active infection, this is more or less the standard norm these days all across the world. You do a subtotal petrosectomy, which according to me and probably most people present here is a well done radical mastoidectomy with a good quality blind sac closure of external auditory canal. Yesterday, there was a video presented on how it is done. I'll be just reiterating a few facts. There are many methods on how you do a blind sac closure. The first one was described by Rambo, where he had elevated the posterior and anterior canal skin from the tragus and sutured it together. We like to do it by this method. We make a post-oral incision, make a palvas flap that is approximately a medium size, not too short, not too big palvas flap, and elevate it across from along the bone in all directions, superior, posterior, and inferior direction. Here we are transecting the posterior canal wall and elevating the anterior canal wall also from its bony attachment. So you have transected the cartilaginous canal and left the bony canal intact. This is one of the most crucial and important and delicate steps. Now you are left with a canal that has whole lot of cartilage on it. So you have to peel off that cartilage with sharp and blunt dissection from all around. So now you only have a skin lying canal there. You put two sutures, one above and one below it. Generally, you use absorbable sutures because these sutures are difficult to remove thereafter. So why we are doing this step is you have to evert the canal very effectively so that all epithelium of the canal goes out. Any epithelium that stays in is very dangerous, particularly in this situation, because if you form a cholesteatoma, then you are looking for a disaster. Two sutures have been put in. You put in an artery forceps from within the external auditory canal and pull this everted canal out and tie these two sutures together. So since we have put two sutures, there was scope of three. So one more suture we are putting here now. And tie it. So we can supplement our closure with the already elevated palvas flap folded on itself. It can act as a second layer of your blind sac closure, making it more than perfect. So we use it routinely in our lateral skull base surgeries, and this technique, if properly executed, hardly fails. Thereafter, you address your disease as you want to. If it is a perforation, it's a cholesteatoma, you do a mastoidectomy, but mastoidectomy has to be better done than a routine modified radical mastoidectomy. You're drilling, exentration, should involve all the mastoid ear cells and all the cells as seen in this particular case from the middle ear, hypotympanum, and also along the eustachian tube area. These are the areas which are of concern and most frequently left behind, because if I may put things theoretically, it is not common to form mucoceles in middle ear. So chasing all the cells, chasing all little bit mucosa left behind is not important, but removing all epithelium and removing as much as visible mucosa all around is important, especially from the eustachian tube and hypotympanic cells. You can use bipolar cautery and diamond burrs judiciously and generously also in these scenarios. After that, you can pack the cavity with many materials. I'll be just showing, I was showing the fat packing, and I'll come on to the choice of materials after this slide. If you do a post-operative CT scan after this blind sac closure, this looks like a fibrofatty tissue closure with the aerated middle ear and eustachian tube. So I'll come on to what material to use for packing. There are theoretically options for using artificial materials and also a choice to rotate the temporalis muscle and obliterate this cavity. What is mentioned in literature and as personal experience is that if you use fat, then it is very easy to go back second time because it can be very easily peeled off from this cavity and it's very easy to elevate. If your previous surgery is well done and you have exenterated all cells, you have lowered the facial nerve canal well, and you have done the middle ear side myotoplasty well, then there is hardly any need to drill the bone in this scenario. But in this case, we were not able to access the round window too well, so we had to drill it a bit. Mind it, we talk about round window and basal tone ossification mostly in the cases where you see meningitis, but CSOM, chronic otitis media, chronic discharging ears are also a cause of round window and basal tone ossification, as was seen in this particular case. So we did encounter some basal tone ossification, but it is mostly limited to outer basal tone. So your job is to blue line the round window in these scenarios and use a right angle pick. I'll take a few more minutes. Right angle pick to break those barriers, and implant insertion is fairly standard as you do in other cases. I am very fond, as I already mentioned.
Just now I put it off and put it on and this happened. I see one answer.
I'm sorry, ma'am, I couldn't hear you. Yeah, so I'll just continue. There are some scenarios which we take lightly. This was a case where the patient had
You are unmuted by the host. What do I do? What do I do? I have to speak next as chairperson now. Huh?
Yeah, no. Carry on, Kapil. I think Dr. Lisa is speaking to someone else. So.
Right. So, I thought that she was.
I can't now understand what you're saying.
So this was a scenario where we had a sclerotic mastoid that was secondary to chronic otitis media. That was safe type. That was chronic otitis media
going on, but
with a central perforation and chronic discharging ear. You can see that sclerosis can involve the area of posterior tympanotomy and can make the landmarks really cramped. Dr. Medicari sir had demonstrated the difficulty in this situation, and he had also recommended and suggested that you can break the canal wall from these two areas and push it.
Why there's no sound?
That's a very doable and good method of increasing exposure. But my experience and experience of my
the audio thing is not coming only. So the other two, the audio came with the head thing.
Organizer to please.
It's only coming mute, unmute. That's all coming down.
Dr. Sandra, could you mute yourself, please? You're being heard in the other session. Dr. Sandra, could you kindly mute your system for the moment? Thank you.
What are you saying?
So the removal of incus has provided additional space in enlarging the posterior tympanotomy and providing good access to
scenario.
So breach of tympanic
Down,
membrane, I
down you
would
always
admit
see
that
audio,
it is
this,
most
that,
commonly a
no?
mistake,
This time
should
there's
not
no
happen
audio
ever.
came.
But while we are in our learning curve, then there is definitely a situation where in one surgery we are more afraid of facial nerve, and in other surgery we are more wary of posterior canal wall. In one surgery we expose the facial nerve, and in another surgery we don't thin the posterior canal wall too much, and drilling in that area can be really catastrophic and can cause damage to your posterior annulus as well as the posterior canal wall. This situation has arisen in our scenario few times. There is nothing to panic. Just go on as per protocols, good wide exposure. Drill the posterior canal wall to as thin as possible, and you will see the defect carefully. This was probably an intact annulus and a very small perforation there. Again, using nerve monitor, chorda can also create stimulus and can give an impression that this is actually a facial nerve sometimes. Check the round window reflex. So here my colleague was questioning whether we should put implant first or whether we should repair the defect and the perforation first. I preferred this thing because I felt that this was more important. We cut a large sized tragal, the conchal cartilage with the perichondrium intact, cut it to size, inserted it so that we could hear that it had well gone in past the bony edges. Over it, we put the harvested small temporalis fascia. After that, standard cochlear implant insertion, no complications, nothing unusual in this. And since we are very fond of glue, me and our team, in these scenarios, I just thought that we'll augment it with glue. And patient, I just checked the check endoscopy, could not put the photograph yesterday. There was no evidence of perforation or exposed implant after this. So an implant which had gone in, but at time of closure, possibly migrated out, could not get good NRT responses, probably in only 9-10 electrodes, a very unusual scenario, which I did not anticipate will be that difficult, that we had to go back in after a couple of days of cochlear implant insertion. So this scenario can arise in your clinical practice more frequently than you think. The gel foam, I personally pack the electrode arrays and the mastoid cavity with gel foam. It tends to elicit some inflammatory reaction, and the mastoid cavity is more congested than I expected. So there has to be a good cycle of good irrigation, decongestion, irrigation, and decongestion, and so on. I want to reiterate the fact that always choose very, very fine instruments for dissecting your muscle and gel foam of the cochlear implant array. The colleague who was assisting me also suggested that why not we take out the implant and then go back in, find the round window and put in the implant. I was a bit skeptical in that, because once you take out this cochlear implant, your identification of round window in this inflamed settings might become difficult. That is what I felt. So we just followed the electrode array in, used the fine, very fine and very delicately the curved, angled picks and the crocodile forceps, and we could remove all the fillings from that posterior tympanotomy cavity, and thereafter the implant insertion was smooth as it should be. So these are the three scenarios that I wanted to discuss, and over to you, Amit sir. Thank you.
Wonderful, Kapil. Thank you very much. Thanks to Dr. Medicary, Dr. Kapil Sikka. That concludes the instructional course that we had. Yeah. Over to you, Sunil.
A final word from you?
Well, the final word is that you need to be very well prepared with good surgical knowledge, good radiological knowledge. Adhere to all the fine principles of surgery, and do not hesitate to phone a friend and seek for help if you have the slightest bit of doubt.
Okay. Amit, really thoroughly enjoyed all three speakers. You had so many tips and tricks to face these surgical challenges. In the interest of time, we will move on now. It's lunch break, and just go pick up your plates and sit in front of your computers while we move on now during the lunch session to e-posters. We have a few e-posters looked at. Again, this will be live streamed. Let's allow all the e-poster presenters to come in along with the faculty who will be asking questions for them. Go pick up your plates and sit in front of your computers while we move on now during the lunch session. We have a few e-posts we looked at. Again, this will be live streamed. Let's allow all the e-poster presenters to come in along with the faculty who will be asking questions.
Dr. Kalpesh,
Yeah,
good
yeah.
afternoon. You are.
Yeah, hi, good afternoon here.
Yeah.
Yeah.
So should we start?
Yeah, we should start. Yeah.
We request you to log out from the delegate link and join only for the faculty link.
Yes, sir.
Yeah, Dr. Sai, are you ready?
Yes, I'm ready, sir.
Yeah.
Should I share my screen?
Yeah, you should share it.
One second.
I think you have a case of acute lymphoid leukemia, right? And
Yes, sir.
which you
Yes,
go for the cochlear implantation.
Yes, sir.
And it was bilateral ossified cochlea.
Yes, sir.
So how much turn of all the cochlea was involved? So where exactly you can put your electrode?
Sir, in as we can see in the CT scan, there was involvement of the basal turn, basically, of the cochlea.
Yeah.
So we were able to insert by drill out technique in the basal turn. And 5 electrodes on the right side could be inserted and around 7 electrodes on the left side were inserted. We confirmed on C-arm intraoperatively, and NRT was also obtained for these implants.
Okay.
For
You did subtotal petrosectomy in 1 year. So it was a stage procedure or a single go procedure?
It was done as a single procedure.
Okay.
Yes.
And how did you convince the patient parents to go for the implantation in case of this acute myeloid leukemia patient?
Sir, the patient was a perilingual child. So at the age of 4, after she developed acute lymphoid leukemia, and she suddenly developed bilateral profound deafness. So, and after the recovery of the facial palsy, we did a pre-operative evaluation of BERA and aided audiogram, where there was around 90 to 100 decibels of sensory neural hearing loss. The parents only insisted, and we did for the other year, which the discharge had stopped and it had the otitis media resolved. We did an implant in that year first, and within 3 months after that, we did for the other year.
Okay, so what is the outcome of the patient in terms of hearing and speech?
Sir, in terms of hearing, the aided audiogram currently of October is suggestive of around 35 to 40 decibels threshold. And previously it was 90 to 100 decibels. And the CAP score has increased to 4 from 1 just within 4 months. And actually the patient is still receiving chemo and radio. She's receiving chemotherapy. So she's not very regular with the therapy. In spite of that, there is a drastic improvement in the speech and auditory outcome.
Okay. Gaurav, do you want to ask anything?
If you just a last question, if you don't find any basal turn there, if you are not able to put the electrode in the basal turn, what are the other options?
Sir, if we are not able to find the basal turn, implant can be done in the middle turn of the cochlea, as Professor Lloyd had also discussed on the first day. So that can be one way of.
Okay, thank you.
Or ABI is the last option.
Okay.
Thank you.
Sir, I think we can move to next poster. Yeah.
I think next one is Mr. Santosh Kumar.
Yeah.
Hi, Santosh. Good evening, dear. Good afternoon, dear. Are we ready? Please unmute Dr. Santosh Kumar mic. Okay.
Yeah.
Yes.
Yes, Santosh, you have operated one case of vestibular schwannoma in adult patient of type 2 neurofibromatosis, right?
Yes, sir. Yes, sir.
So again, the question is, how did you explain the patient about the outcome of the tumor removal and at the same time hearing acquisition?
We explain him with the guarded outcomes. It will initially we explain him it will take a long-term AVT. He need to undergo long-term AVT and with the guarded outcomes, and it will help him in his communication and assisting his visual cues and it.
Okay. So what was the main surgical challenge you found?
Sorry, sir, I didn't get you. Sorry.
So what was the main surgical challenge in that case?
And removing the residual tumor and identify, because already 2 times it was operated. It was a scarred area. Identifying the landmarks was very difficult, and inserting the electrode in the lateral recess of the fourth ventricle was a challenging thing. And obtaining the EABR, intraoperative EABR, was also challenging.
Okay.
Okay. What was the facial now outcome?
Facial nerve was fine, sir. No facial nerve palsy was there.
Okay.
How much was the role of ENT surgeon in the surgery?
Role of creating the bed and creating the area for craniotomy and elevating the periosteal flaps and all, and AVT and all.
Okay, thank you. Thank you, Dr. Santosh.
Thank you.
Thank you.
I think the next poster is from Dr. Shivam. Dr. Shivam, can you hear us?
Yes, sir, I can hear you. I'll just start sharing my screen.
Yeah,
sir.
you just start sharing.
Yes.
Shivam, you need to share. Santosh, you need to.
Yes, sir. Yes, sir. I'm doing it.
Yeah, Shivam.
Shivam.
Yeah, I've started sharing, sir. Are you able to see?
No, we are still.
No, still vestibular
Santosh Kumar.
Santosh. I think you have done a study on the cadaver of about 50 cadaver.
Yes, sir. A cadaveric study of the surgical, cadaveric and radiological anatomy, sir.
So it's seems to be a good cadaveric study, as nowadays it's very difficult to conduct the cadaveric study. So now we can see. So first question, what is the importance of cochleocarotid interval which you have shown, and how to measure it?
Sir, cochlear carotid interval holds importance in cochlear implant surgery, as many a times we have read many reports of accidental insertion of electrodes into the carotid canal. The part where the vertical carotid turns into the horizontal part is very close to the basal turn of the cochlea, and sometimes the bone is very thin. It is actually less than 1 millimeter in few of our cadaveric dissection studies. So in those cases also, sir, it becomes very important that we know this pre-operatively. So first of all, we can decide the side to which we should implant, whether right or left ear, whichever has more distance. Second, we can counsel the patient accordingly, sir, that this can also happen. And thirdly, sir, we can also arrange for an intraoperative C-arm or any other imaging technique through which we can confirm the electrode insertion is in the cochlea only and not into the carotid canal.
One more thing you have studied about this is about the cochleofacial interval distance, cochleofacial distance. So how much is it, and what is the importance?
Cochleofacial distance, sir, in our study was around 0.6 mm, and in few cadavers it was even less than 0.4 mm, sir. So it holds importance, sir, as the labyrinthine portion of the facial nerve is very close to the middle turn of the cochlea. And sometimes when the patient is hearing after implantation, the electrode stimulation can be transmitted to the facial nerve, leading to facial nerve twitching whenever the person, whenever the child or the person hears. And this is more so in the otosclerotic patients, or the otospongiotic bone, because it conducts, the otospongiotic bone is more enchondral and it conducts electricity more easily.
Okay. Dr. Kalpesh.
Okay, so if it persistently gets stimulation of the facial nerve, how often you have come across and what you have done in this type of cases in live patient?
In live patients, yes, sir. Sir, till date, I have only seen a single patient, and in that case, we managed it by switching off those particular electrodes which were concerned with the that part of the labyrinthine portion of the facial nerve, sir.
Okay, so how many electrodes were you shut off?
Sir, around 4 electrodes. The audiologist.
Okay.
Okay.
Okay, fine.
Okay,
Thank you.
Fine. Thank you.
Yeah.
Thank you, sir.
Shivam, you need to stop sharing your screen.
Yes, sir. I'll stop sharing.
Yeah. The next is Dr. Sunaina Saju.
Hi, sir. So I'll just share my screen.
Yeah.
Yeah.
So I hope I'm visible, sir.
Yeah.
My poster is visible. So good afternoon, everyone. Good afternoon, dear judges and all my colleagues here. My poster is presented on the topic Asia Pacific's first, second, and third simultaneous ipsilateral osteoimplantation, which we conducted in skull-based surgeries. And myself, Dr. Sunaina Saju. Our cohort consists of 3 patients who underwent lateral skull-based surgery for various etiologies. One was petrous apex cholesteatoma patient, and there was a skull-based osteomyelitis case, and one was a tympanojugular paraganglioma. We had done simultaneous ipsilateral osteoimplantation, and all of them had single-sided deafness, and they were favorable for the osteoimplantation as well. Patients were serially evaluated after the implantation, both audiologically and subjective evaluation. Pure tone audiometry and speech audiometry was conducted, and the results were actually advantageous. Like preliminary results indicated word recognition score improvement from 3% to 93%, and even a speech perception and noise in the unaided, when aided with Ossia, was good. FAB scores indicated fewer communication problems also, especially in noise environment, which was much more than, the score was better compared to the Baha trial. So compared to that, it was a very good study. And moreover, being a transcutaneous system, aesthetic and non-inflammatory conditions, there are no inflammatory risk associated with it. So that was another added advantage to our patients who ever used Ossia system.
What is the costing of this implant?
Cost, sir?
Yeah.
Yeah, 6 to 7 lakhs is the initial charge, and when we do it simultaneously, we don't charge the procedure charges. So that is an added advantage, that cost-wise, they get a benefit out of it. So.
Okay, Dr. Kalpesh, sir.
What was the outcome of the disease for which you have operated this patient?
Yes, sir. The only patient we were concerned with was the skull-based osteomyelitis case, because we wanted 100% clearance when we were going in for the ossia implantation, but it was a limited skull-based osteomyelitis, and we were 100% sure about the disease clearance, and then that's why we went ahead. Tympanojugular paraganglioma, it was complete, there was no recurrence, and they are under follow-up, but still there are no evidence of recurrence or leftover disease. So 100% disease clearance was one mandatory thing before we went in for a simultaneous implantation.
That is great then. Good outcome then. Yep.
Yes,
Yeah.
thank you.
That's okay. Thank you.
Thank you. Thank you.
I think we have the last candidate, which is Yamini Gupta.
Yeah. Yeah. Hello, madam, please.
Yeah, hello, sir.
Yeah, hello.
So is my screen visible?
Yeah.
Yeah, go ahead.
Yeah. Good afternoon, everyone. So at the outset, I would like to thank the organizers of CIGICON 2021 for giving me the opportunity. So hearing is one of the most important sense that enables us to socialize and communicate. And as we all know that—
I think we can take up the questions first.
Sorry?
I think we'll go for the questions directly. So tell me one thing, this is an established fact that we all are doing CT and MRI before going for a cochlear implantation. So what different finding you got in your study? What is the—
So in our study, it was slightly higher. Like in other studies, when we compared with the other studies, it was around 22% inner ear abnormalities, whereas in our study, it was around 26% that we got.
Okay, that is fine. Anything else? What is the impact of your study for day-to-day practice, means cochlear implantation?
The impact is that basically we should go in for the dual modality, and we should be very well versed with the radiological evaluation of HRCT and MRI in order to avoid the complications in the OT.
Yeah, and anything else, recommendations from your side?
Yeah, we should be really well versed with the radiology.
Okay, fine. That's great.
Yeah, that's okay. I think we have done with all our posters. Yeah.
That's wonderful, Gaurav and Kalpesh. Absolutely fabulous timing. You saved us at least 15 to 20 minutes.
Yeah, welcome, boss.
Welcome, sir.
Thank
Welcome.
you. Thank you so much. And
Thank
thank
you,
you for all our e-poster presenters. And again, I want to congratulate you not just for your presentations, but you've also become CG members last night in the GPM. We made you CG members also. So congratulations once again. We'll see you all soon.
Thank you.
Thank you. Thank you, sir.
Thanks again.
Thank you,
Thanks.
sir.
Okay.
Okay.
Thank you, Gaurav and Kalpesh.
Okay, bye. See you.
Welcome, sir. Thank you.
Bye for now. Bye for now.
Bye.
Bye.
Thank you very much, sir. So let's move on to our next session for today, which is a set of invited lectures. And it's my proud privilege to introduce the chairperson for today, Dr. Sandra Disa Souza. She's a Padma Shri, and she's a pioneer of cochlear implants, having performed the first implant in 1987. This was the first cochlear implant in India and in Asia, and was the first lady surgeon in the world to do so. She has performed about 2,500 surgery, has 40 research papers to her name, and she's a recipient of many, many awards. To summarize all, I would say she's a legendary daughter of a legendary father. With this kind words, over to you, ma'am.
I'm unmuted by the host. Again.
We can hear you, ma'am. We can hear you.
Okay. The onset, I'd like to thank the organizers, particularly Dr. Medicari and Dr. Sunil Dutt, and the organizing committee for having given. Like me to read out the CVs of the three speakers. Very small. Dr. Wolf Dieter Baumgartner was born in Vienna in 1967. He's a specialist in ear, nose, and throat, senior doctor at the Department of Ear, Nose, and Throat Diseases at Med Uni Vienna Hospital. He has worked at the Vienna department since 1992. He has held a chair in otology and cochlear implants at the Karolinska University, Stockholm, since May 2012. He is a visiting lecturer at Rudolf Horst University of Campus Vienna and the Vienna Medical Association. He has been president of the hearing group since 2017. He is president-elect of the Collegium Otorhinolaryngology, Amicetim Sacred. Baumgartner has published 129 original papers, has already delivered more than 1,200 lectures. Wolf-Dieter Baumgartner, an expert in hearing implants at the Department of Ear, Nose, the Vienna General Hospital, has been appointed as honorary member of Austrian Society for Head and Neck or Laryngology, Otorhinolaryngology. I think that's all. Next. Dr. believe that doesn't need any introduction, but I'll read it out. He is currently clinical director, advisor, senior consultant, professor, and senior doctor in the Department of Ear, Nose, and Throat. ENT head and neck surgery at Apollo Hospital, Bangalore, India. He has his MS, DND, PhD, Netherlands, FRCS ORLHNS, Edinburgh, West Midlands rotation, Birmingham, UK, and clinical fellowship in neurology, Canada. He's a founder and the founder secretary and current president of CG. He's the founder secretary and current president of GCIAN. 124 publications, 76 in peer-reviewed journals, and 6 textbook chapters in Scott Brown's otolaryngology. He's the president of Van Pradhan Kendra and secretary Sai Bangalore NGOs. Karnataka State Cochlear Implant Committee member and advisory board added scheme, Government of India. Going to the next one. This is the next one. Anjali Lepcha, Professor ENT, Otology, Neurology, and Cochlear Implants, Department of ENT, CMC below. Special interests are otology, neurology, and audiovascular diseases and their management, including surgeries for hearing loss, cochlear implant, and vertigo. Keen interest in occupational noise health. My work involves clinical work, teaching, and supervision of fellows, postgraduate students, otorhinolaryngology, undergraduate students, and research in related fields. Director of the 2-year fellowship in implantation, Tamil Nadu, Dr. MGR Medical University. Sorry, my screen is jumping. Has several ongoing research projects, and more than 40 publications in national and international journals and book chapters. Welcome all of you. Would ask Dr. Baumgartner to first start and speak on cochlear implantation with the robot.
Doctor, please unmute yourself.
Hello, can you hear me? Hello? My friends, can you hear me?
We can't hear you, Doctor.
Why? Actually, it should work.
Now it's fine. Now it's fine. Thank you.
Hello, super. Good morning from Vienna. It's great to hear you all, and it's a big pleasure for me, to be with you. I'm very sorry not to be personally with you. And greetings to Sunil, you did a great work, perfectly. And congratulations to all my friends in India. I want to tell you a little bit, something new, maybe. We did the very first robotic surgery in Vienna recently. I think it is a long dream that the robot might do a cochlear implantation. And this project started already 2005 in Bern in Switzerland.
Excuse
the
me.
idea.
Your slides are not visible.
Oh, but you should. Okay.
We are seeing your mailbox.
Okay. Hold on. Let's go. Is it better now?
Yeah.
Yeah.
Make
Super.
a slideshow, doctor.
Yeah. So how is it? Okay. So the idea was, can you see it now? Can you see it now?
Very clear, very clear.
Very clear. Okay, good. So the idea was from Marco Cavasaccio in Bern, in Switzerland. And so now I have a tiny problem because the slideshow doesn't work now. Yeah. So I want to start with this very short. It's a new computer. We did together with Switzerland, with Medel and with CIGICON company. You see here, this is the robotic arm. You see the robotic arm, and this is actually the drill. So the patient is placed on the table. I show you later on the surgery. The patient is placed here. Beforehand, you achieve MRI, CT, and digital volume tomography. Those three properties were put together in one 3D visual picture. And then you calculate a small tunnel, a 1.8 millimeter tunnel from retroauricular, from the skull, directly to the scalar tympani. So at the moment, the system works with the flex electrodes only, with all the type of flex electrodes, because the tunnel is 1.8 millimeter. And you make the insertion into the scalar tympani as a surgeon, but the surgery itself, as you see here on the sketch, the surgery itself is done by the robot. So it is a Wolfram zirconium drill. You have permanent flashing, and you have additionally permanent facial nerve monitoring. So the facial nerve monitoring is fully integrated, and you drill in between the facial nerve and the chorda tympani. We also stimulate the facial nerve permanently, like in neurosurgery. And this is the whole thing. So you have no mastectomy, you have no posterior tympanotomy. The procedure lasts at the moment 4.5 to 6 hours, and then you can make the full insertion. So this was just the overview. I will now go a little bit more into the detail, but you see, this is the whole system. It's not a big machine. It's all in this box, that's it. With this box, you can travel from hospital to hospital. It fits on most of the surgical tables, mainly from Maquet company, and it's a CIGICON Med-El thing. And yeah, we had the honor to start with the system. So what is it? The project started in 2005, you all know the suprametal approach. With the suprametal approach, we only did a hole, a direct hole. And then Marco Cavasaccio asked himself, look, if you just have this tunnel, we need to make this more effective. And this started in the year 2005. The very first test were 15 cadaver skulls we did together and just put in the regular standard drill we have for surgery with an industrial robot arm. And then the Swiss Research Fund funded this project for over 5 years with more than 5 million Swiss francs. And the hero is more or less the product. The project ended in the year 2010. And then two companies, the Swiss medical robotic company CIGICON and the Austrian cochlear implant company Med-El, founded a new company. This is the hero company for this cochlear implant robot, which is working now. It has all licenses. I was one of the persons who wrote all the paperwork for the European Union. So it's fully approved as a full medical product within the European Union. So we make a 1.8 millimeter trajectory into the inner ear instead of a mastodectomy. So that means the whole drill hole of about 3 centimeter length, it's just 1.8 millimeter. It's very similar, for example, to the last James Bond movie you have maybe seen. Beforehand is autoplan very important, because with the autoplan, you make all the calculations. Once all the calculations are done, then it's completely automatic. That means this is a very new feeling for us. As a surgeon, you do nothing. You do nothing. You sit on the table beside the robot makes all the work. Actually, theoretically, you don't even need to sit on the surgical table, but because of the legal situation, it is mandatory that the surgeon is there. But from the pure work, the surgeon does nothing. It's all done by the robot and by the computer. I need to say the Indian input in this project is very, very big, because the software is done by Indian colleagues. And Masood Zoka, who is really a wonderful person, is also one of the masterminds. So without Masood, this would not work. So you have only one possibility as a surgeon to control the robot with the foot pedal. You can start it or you can stop it. So in an emergency case, you can stop it. But this never happened so far, I need to say. The planning is based on cone beam CT, on MRI, and on traditional CT. Of course, we have much smaller opening and we have a better insertion angle. This is now the system. You have here the surgical table, but the table can be your table in your hospital. So you do not need to buy a new surgical table. Here you have the system. This is attached to the surgical table. This is the robotic arm with the 3D camera. So these are the eyes of the robot. It's an infrared. We have 5 infrared points. I will tell you later. And this is the digital volume tomography, the XCAT in the surgical room. We make intraoperatively 3 times digital volume tomography. We do one before the start to compare the preoperative settings with the situation on the table. We make one just before we reach the facial nerve, and we make another one after the facial nerve before we reach the scalar tympani. With the digital volume tomography, you have much, much less radiation energy. It's not like a computer tomography. With the digital volume tomography, the radiation is only like a regular chest X-ray. So it's nothing special. Now, very important is the autoplan system. With the autoplan system, you calculate out of the 3D fusion from MRI, from CT and volume tomography beforehand you calculate. And you see, we see here the cochlea, we make trajectory lines, you see the lateral semicircular canal, you see the ampulla. So you can turn the head in a 3D maneuver in all directions, and you can really make linear your tunnel into the scalar tympani. So this 3D construction looks really as here on the screen. It's the 3D construction. So in the 3D construction, we look over to the cochlea. We look to the bony overhang of the round window. We look to the round window, the meatus. We see the ossicular chain, the incus and the malleus. We see the stapes. We see here in yellow the facial nerve. We see the chorda tympani in orange. We see the sigmoid sinus and the whole temporal bone. So this is the crucial point. The preoperative planning before you even go into the OR needs about 1 hour. So you need about 1 hour for the preoperative planning. But once you have done the preoperative setting, like here, the surgery just happens automatically. We need to prepare a patient. It turned out it's good that the patient is not more than 100 kilograms. So in Austria, we had the problem that we had some bigger patients, and in bigger patients, it's not so good. So the patient should not have more than 100 kilograms. Then you make a retroauricular incision, a tiny 3 centimeters, and place five titanium screws, but only for the surgery. So these titanium screws only stay for during the surgery. This is for adjusting the system and for the self-calibration. We already did the pre-op imaging. Then at this moment, we still do a tympanometal flap, although the tympanometal flap is really not necessary, but we do it for our own learning curve and still to control the robot, but actually the flap is not necessary. And then the surgeon does the electrode insertion, and of course we make the post-op imaging. This was our very first patient, an Austrian male. And we started with a difficult patient because he suffered from mumps meningitis many years ago in the youth. And he had a 4 millimeter ossification at the round window. And yeah, we just did the surgery. You see here the CT scan of this particular patient. And you see here actually very nice. You see the basal turn of the cochlea. You see the apical part of the cochlea. And here, if you look exactly, you go into here. Here is the round window. Here is the facial nerve. You see the facial nerve. We see the round window. And here you see about 4 millimeters ossification. Here you see it in another plane. Yeah, so this is another plane in this 3D reconstruction. And yeah, this was a little bit a challenge, but we made it. Now the next step was to planning a safe trajectory. So we want to have a trajectory. You see in blue is the drill hole with the drill, and we want it to come directly. Here's the facial nerve. So the facial nerve is about 0.1 millimeter away from us, and we drill directly with the 1.8 millimeter tunnel from the surface of the skull directly as the robot drills into the scalar tympani itself. So the round window was opened through the drill. This is very important. You see here another trajectory, and in the 3D reconstruction, you see the cochlea, you see the round window region, you see yellow the facial nerve, orange you see the chorda tympani. The drill goes in between the facial nerve and the chorda tympani. You see the incus, the ossicular chain, and you see the stapes. So this is as it looks beforehand. Here again, and then you see here the screws. So we have safety margins. So this is already the surgical theater. So we have here the screws. You see the screws for the system, the facial nerve, and actually this is just for our visualization as surgeons. You do not do anything with your hands. It's all done by the robot. I show you in the video a bit later. So we have a safety margin to the facial nerve in this particular case of 0.5 millimeters, and to the chorda tympani 1.8 millimeters, and the depth of drilling, so the hole from the surface into the scalar tympani was 30.6 millimeters. So this was in this particular case. And the drilling ended 4 millimeter in the scalar tympani. So with our bird this time, we drilled into the scalar tympani. So with the Wolfram zirconium drill, we passed already the ossification. So we passed the robot passed the ossification with the drill. And now the system accuracy. So we know the accuracy from the post-op digital volume tomography. I told you we make a pre-op, we make one on the table, we make one before the facial nerve, we make one after the facial nerve, and then at the end, a few days later, we make a new setup at the moment to control ourselves how well we were working or not well. So far, I can tell you we worked very well. The robot worked super well. The accuracy was 0.02 millimeters. So this is galaxies better than any Da Vinci system or anything you've ever had in your hands. So the accuracy is 0.02 millimeters, the entrance 0.03 millimeters, and the target was 0.1 millimeter. So 0.1 millimeter, we hit the target as intended. What we used, what we could insert was the Synchrony 2 Flex 28, I told you, because only the Flex electrode is small enough to go through the tunnel. The tunnel is 1.8 millimeters, and you need a straight electrode 3 centimeters through the tunnel, and then with a lot of flexibility into the cochlea. We had a full insertion into the scalar tympani. We achieved 619 degrees, that's 1.7 turns, and 200 hertz coverage. And here you see the post-op reconstruction of the electrode. Also here, I think on the right side, very nice visible. So these were all the 12 electrode pairs in the cochlea, and you see how it fits perfectly in the cochlea. This is the post-op analysis. You see the Sonata 2 implant, and you see here the coiling inside the cochlea just with the straight tunnel. So it worked very nice. What the surgeon still need to do is the implant bed. We always do an implant bed. We do the fixation, and we have all together 5 centimeters. And now you see, for example, how it works. This is the surgical setting. This is the surgical table. This is doing the tympanomeatal flap for our control. We control it with the endoscope. This is me, for example. Here, this is for our visualization. We have a small model for ourselves because we are not robots. As surgeons, we need something in our brain to have how should I say, where we used to have it. So this is our model we use for us to make it better visualized. And now I show you this short video. This is the surgical situs. This is the robot arm. We start now. The surgeon is doing nothing. The surgeon just sits and waits. All is done by the robot. The arm is there. So we do it again. So you do nothing. You just sit and wait for 1 hour until the drilling is done, and it's all done by the hero. This is another example. This is the system, and you see this is the drill, 1.8 millimeter, and the drill goes completely automatically. Here is the flash. Here is the drill. Here is the flash. This is the system. Then let's see the next. This is the drilling. It was actually a big challenge. We needed some time, actually some years, to find out the right drill. You cannot use the drills we have in our surgical room right now. You cannot use any striker drill or B&R drill. Those drills will become too hot, and they will not have enough accuracy because those drills will bend in 3 centimeters. So it needed this special Wolfram zirconium drill. It's a very special system to go forward. And this is how it works. You have the flash, and this is it for the patient. So it's the most minimal invasive you can imagine. For you as a surgeon, you have this on the screen. This is the drill. This is the chorda tympani visualized, the facial nerve visualized. This is the facial nerve monitoring permanent, which I show it to you now. And you see the drill goes down, down, down. This is the part where it's drilling. And then you see the facial nerve. And this is the target. This would be our target in the patient. Here you load the drill, so that's very simple. So you load the system by hand, and this is the pre-operative planning. You have always a colleague who also will look that everything is okay during the surgery. So this was the very first time. We have now 2 systems. We have the prototype from Marco Cavasaggio in Bern. We have this system, which is now a real medical product. If you want, you can buy it for a small amount of money. And we have now done all together with the colleagues in Bern, Switzerland, and in Antwerp, and ourselves. We have now done 46 patients together, 46 all together. We have now done 46 patients without any complication. And it really might be that this is a very safe system for the future. We had no no complication, no bad interaction, and it works very well. Thank you very much. And I hope to see you in India in person very soon. Thank you, my friends.
Okay. We'll probably not take questions now. Dr. Baumgartner, that was absolutely fabulous, mesmerizing indeed. Mesmerizing. Thank you so much. And I'm going to go on. Thank you. Really appreciate it. I'm going to go on with my talk. We good? All right. So I've been asked to speak on electrode design, the philosophy of it all. When we are looking at the choice of electrode, I would say different folks have different strokes. From Australia to America to Austria to France, recently China, and hopefully in the future India have cochlear implant manufacturing system, companies, and hopefully there'll be more entries into this. When we are inserting an implant electrode, what is our goal? We want an easy insertion with no complex maneuvers. We want a full and complete insertion until the marker, the ring, the rib, the jog, whatever you want to call them, endpoint. It should be a single shot, no repeats, no reinsertions, unwavering, unshaken, atraumatic, and an immaculate insertion. So what is expected of our engineers by us, the clinicians, both the surgeons and the audiologists? Electrode has to be a surgeon-friendly electrode. It has to be an audiologist-friendly, surgeon-friendly, like I said, all those points in the previous. And also the audiologist has to be happy that the electrode is fully inserted and every electrode point, the contact point, is all intracochlear, and they got a full spectrum of frequencies. So we have this idiom that we kind of keep saying at the end of the electrode insertion and the electrophysiological intraoperative testing. If the surgeon says a thing of beauty, the audiologist doing the electrophysiology should say a joy forever. And this has been a routine for us during surgery. And that's what we need to expect of our engineers. What would define what electrode you would choose? The clinical situation, the radiological anatomy, the surgical approach, and hence the challenges with it, and sometimes the cost as well, because not all electrode designs are available at all slabs of the electrodes, the implants that are available today. The human cochlea, ladies and gentlemen, it is told, is as unique as your thumbprint or an iris scan or even a barcode or a QR code. So my cochlea is very unique to me, and as is every 8 billion humans that we have on this earth. So electrode insertion inherently has its risks and complications in this very delicate cochlea and its intracochlear structures. We can have an incomplete insertion, we can have kinking, we can have tip fold over, we can have scalar translocation, we can even have electrode migration into the lateral wall. Now, insertion trauma has been classified by Eshraki. I don't need to dwell into this. And when we are choosing electrodes, let's have some considerations here. Straight versus pre-curved electrodes, we'll talk a bit about it. We'll talk a bit about electrode length and perhaps about diameter as well, what's its relevance. And finally, about membranous versus bony cochleostomy and how electrode design would affect this approach. A few words on pre-curved versus straight electrodes. Pre-curved are all meant to be perimodular or modular hugging electrodes. Straight electrodes or lateral wall electrodes. We already know what this would mean in terms of excitation. the spread of excitation is smaller in a perimodular electrode compared to a lateral wall electrode. You need to keep that in mind. And the issue with pre-curved electrodes, if it is an issue at all, is that the technique has to be very precise. You have to strictly adhere to the company's the directive as far as the guide book, as we call it, to the surgical technique of insertion. So it could be a stylet-based insertion, advancing off the stylet. There could be loading and reloading options. All these have to be very precisely done. This would affect handling of the electrode. There could be fatigue of the electrode. And the more complex the steps, the more possibility of errors. Believe me, when I say surgeons like it simple, so make it as less complicated as possible. It is told that there is less pitch mismatch, place versus pitch mismatch in perimodular electrodes than in lateral wall electrodes. Understandably, you're getting closer to the modulus. But as far as post-implantation residual hearing is concerned, with the soft techniques that we are following now, either through the membrane, downwind membrane, or with the bonicochleostomy soft technique of insertion, there is no significant difference between straight and recurved electrodes. Scalar translocation is very common with tip foldovers in perimodular arrays. Both these have been reported anywhere from 6% to 10%. And again, it's a technique issue, not so much the electrode issue. It's surgeons getting the technique wrong, not adhering to the strict surgical principles of insertion. No significant difference has been observed after 12 months in both the groups, perimodular and lateral wall electrodes. However, faster acquisition of auditory results were observed in the group with the slim perimodular electrode. Let's move on now to the length of electrode. So when it comes to pre-curved and lateral wall electrodes, I think Anjali will talk a little more about when would you choose what. An example there is, I would perhaps like a perimodular electrode in a IP2 kind of situation when I know the modulus is only about half its length, and I want to exploit the available modulus there to its maximum, and I would like a modular hugging electrode there. Coming to the length of the electrode, which would again determine the depth and the angle of insertion. Again, this is a philosophy. Do you believe in complete cochlear coverage or not? Are you a believer? Are you an atheist? Are you an agnostic? Do you believe that the dendrites and the axons need to be stimulated, or do you believe I can directly go to the ganglion cell bodies and I can stimulate them? Because that would determine whether you believe 2.5 turns or at least 2 turns have to be stimulated for the complete cochlear coverage, or 1.5 turn is enough, where you're looking at the spiral ganglion cell bodies, and that would take care of the full spectrum of frequencies that we need. One size does not fit all. The cochlear duct length, the Indian experience has been studied. Manish has published about it. We have published about it also. We did 3 audit cycles on our evolving radiological protocol for cochlear duct length, and we have made it a regular protocol in our radiological evaluation. Deeper insertion, inherently there is more trauma, and that is understandable, but if you are very careful, very slow, it is recommended, if you're looking at the longest electrode, which is about 31.5, we are recommending as slow as 1 to 2 minutes of insertion time. We do the curved NPR measurements and compare that with the Jolly formula that has been discussed in this conference as well, with the Hardy's A measurements, which, as you know, is from the midpoint of the round window membrane to the outermost wall of the cochlea, and that would give you the cochlear duct length available as the insertion turn, which is 2.5 insertion turn for the longest electrode. All companies I can see, and this is a philosophy, are looking for this sweet spot that we keep talking about. And I think what is an ideal length when we talk about lateral wall electrodes is what it is. And here's a full list of all the different companies that have implants now. And this is perhaps a very good take-home slide for you. I think this message is clear that I think that sweet spot is somewhere at around 24 millimeters, maybe 24 to 26 millimeters at around 450 to 500 degrees for the full spectrum of frequencies that we would like stimulated. And if you see, all companies are focusing around 24 millimeters there. You see, that is where they are in terms of the length. So I think more and more lately, we've also analyzed what's the Indian cochlear duct length, and the average is around 29, maximum 30 millimeters. So we need to keep in mind the full standard electrode may not go in completely. Very quickly about diameters. The diameter of the apical length, apical turn of the cochlea and perhaps a bit of the second turn is relevant when you're putting in a full standard electrode of one of the companies, which is a full 30 plus millimeter length. Because even if you have the length, if the diameter is less than 0.5 millimeters, you will not have a full insertion. You'll have an incomplete insertion. So it's crucial to measure diameters. Again, we put this into our radiological protocol preoperatively. Very quickly about electrode design related to membranous versus bony cochleostomy. I think not all electrodes will go into, even with the posterior tympanotomy technique, will go easily into a round window, pure round window membranous insertion. For example, pre-curved electrodes, you would have a tough time going through the round window membrane. You will need at best extended round window. You will have to drill the crystal fenestra and go ahead. But they're meant to be for bony cochleostomies. More and more lately, there's enough evidence to suggest hearing preservation surgery is best with round window insertion only. We know about the round window axis classifications. There are several available. And what is important is what trajectory this is going to take, and hence the electrode design would determine this. The trajectory that it would take is a little more skew when it is a round window membrane insertion than it is with the bony cochleostomy. And again, it would vary between all the standard posterior tympanotomy approach to all the alternative approaches, surgical approaches that are being practiced today. So there is also electrode design specifically for special situations, and I'm going to let Anjali talk about this. It's not in my remit. And so, in conclusion, ladies and gentlemen, I think we should aim for perfection when we are giving our feedback and inputs to our engineers as clinicians ourselves, both surgeons and audiologists. I think we should aim for perfection, because if we aim for perfection, we may get to near perfection. You'll never reach perfection. Thank you very much for your patient attention. I'm going to let Anjali take over, Dr. Sandra, if that is okay. I'm going to stop sharing, because there's continuity with that discussion. Go ahead, Anjali.
So, good afternoon. I hope you are able to see my screen. Good afternoon. Can I know whether my screen is seen? Hello? Hello? Am I audible?
Yes, you can go ahead, ma'am.
Okay, sure. Thank you. Good afternoon, everyone. At the outset, I'd like to thank Dr. Sunil Dutt and the scientific committee for inviting me to speak at this very prestigious conference. The topic which I was given to talk on was how do I choose an electrode for my cochlear implant patient? So we know that the electrode is a very important tool in the hands of the cochlear implant surgeon, and that has direct implication on the success of the surgery. So the electrode remains a permanent lifelong interface between stimulation delivering CI and the neural structures. The earliest electrodes developed were the straight array electrodes, and they were quite stiff and large, and that was a function of the technology of that time. However, it fulfilled the aim of inserting a multi-channel electrode into the cochlea, which could stimulate the neural elements. And later we had, as scientific development and research showed, we had the development of the perimodular electrodes, which were pre-curved, and this was shown to require less current levels as well as prolonged the battery life as well. But however, there was an issue with these early perimodular electrode, and that was trauma to the basilar membrane. More recently, we have the concept of both soft surgery and combined surgery, that is electroacoustic stimulation, especially when there is residual hearing. And so we have the development of shorter, more flexible lateral wall electrodes that could facilitate a round window insertion. And even more recently, we have the sheath-based perimodular electrode that avoids trauma and also the unpredictability of advanced off-stilette-based insertions. So expanding indications like inner ear complex anomalies, labyrinthitis ossificans, and various surgical approaches make the choice of electrode an important factor in the success of surgery and its outcomes. So before I go on to choosing my electrode, what do I need to consider? So one important factor would be the anatomy, especially of the inner ear. Another factor would be residual hearing, cochlear duct length, and whether this is a reimplantation surgery, and what is the surgical approach or technique that I wish to adopt. So factors that don't seem to matter much in the choice of electrode would be the age of the patient, whether it's a pediatric versus an adult, whether it's a prelingual versus a postlingual patient, or the duration of deafness, and whether I am doing the implant for a single-sided deafness. So head shadow effect or localization are not affected by the choice of electrode. So anatomy, this is the single most important determinant of choice of my electrode. So in order to assess the anatomy, I need to have good imaging with me. So HRCT or high resolution CT scan of the temporal bone with 0.65 millimeter slices or less, as well as an MRI with 3 Tesla or 1.5 Tesla at least, and with T2 drive sequences would give me a good idea of the anatomy of the inner ear. So when it comes to inner ear anomalies, the IP defects are important and we need to consider them in detail. So the IP1 anomaly, as we heard about, is a cystic cochlea is present. The size of the cochlea is usually the same as that of a normal cochlea, but it lacks a modulus and it lacks interscalar septations. So we expect a CSF gusher in these kind of anomalies. In IP2 anomaly, we have a cystic apical and a middle turn of the cochlea, whereas the basal turn is normal and the modulus at the basal turn is usually normal. We don't expect a CSF gusher, but we may get a CSF oozer in these cases. The IP3 anomaly we have is usually an X-linked genetic disorder where we have the interscalar septi present, but an absent modulus, and we expect CSF gusher in these cases as well. So the choice of our electrode need to consider whether there is a modulus present or whether we expect a CSF gusher in these situations. A common cavity disorder is where the cochlea and the vestibule is replaced by an ovoid common cavity, and the IAC opens directly into the common cavity, into the center of the common cavity, and we should expect a gusher in these situations. So when we have an absent modulus or a common cavity kind of disorder, it's good to put in a full banded straight electrode. And the way to insert these electrodes is through a wide labyrinthotomy. And the mid portion of the electrode array is gently inserted into the opening so that it opens out like a coil around the periphery where we expect the neural elements to be. Unlike the standard insertion where we insert it with the tip of the electrode leading the way, because this may lead into misplacement of electrode into the internal auditory canal. So when we have a normal anatomy or even an enlarged vestibular aqueduct syndrome, we could use any electrode of our choice. When we have a mildly malformed cochlea or a slightly hypoplastic cochlea where the cochlea duct length is less than 25 millimeter, we could go for a soft flexible electrode or even a perimodular electrode. In severe cochlear hypoplasia, we could use a short electrode, or we could use one with a silicone cork stopper, which would plug into the cochleostomy opening and help to control the CSF gusher. In an IP1 anomaly, we could use a straight electrode, and preferably that's a little bit longer so that it sits around the perimeter of the cavity. And also we could consider using one with the cork stopper. In an IP2 anomaly, where we know that the basal part of the modulus is intact, we could use a standard electrode of a straight electrode of a standard length, or even a pre-curved perimodular electrode would do well. In an IP3 anomaly, we could use a straight electrode or a one with a cork stopper. In a common cavity, like we mentioned, we could use a straight electrode with a full band, which allows better stimulation of the neural elements, and the length of the electrode that needs to be inserted could be calculated by using the formula 2 pi r, where r is the radius of the cavity. So in labyrinthitis ossificans, which was once considered a contraindication for CI, we need again to consider what electrode we are going to use. And our aim should be maximum electrode placement within the cochlea with preservation of the cochlear structures and neural function. In these kind of cases, it's better to keep a depth gauge ready, which would help us to assess the lumen before we do the actual insertion of the electrode. So in stage 1 cases, where there's limited ossification of a few millimeters beyond the round window, we could use any electrode after drilling out the ossification. In stage 2 ossification, where we have obstruction up to the basal turn of the cochlea, we could, once we get a clear lumen, we could try using an electrode, a straight electrode which is a bit stiffer, or an electrode with a stylet or a stiffener. In stage 3 ossification, either stage 3A or stage 3B, after trying a drill out, we could use a compressed electrode array, or if we are doing a middle turn cochleostomy, we could use a split array or a double array, where one of the arrays goes into the middle turn cochleostomy towards the apical turn, and the other one is inserted into the basal turn through the standard cochleostomy. Another condition that we are doing cochlear implant for more and more nowadays is for far advanced otosclerosis, where we have a severe mixed kind of hearing loss, not benefiting with a hearing aid or surgery. So this affects the endosteal lining of the cochlea, and so we could get ossification in up to 60% of cases. Another peculiar problem which we face when we do implant surgeries for these patients is the facial nerve stimulation. And this occurs due to shunting of the electric current through the abnormal autospongiotic bone. And this could occur in up to 75% of cases. So any ossification we would deal with, like in a case of labyrinthitis ossification, using a stiffer electrode or a pre-curved electrode with a stillet would help. And to avoid facial nerve stimulation, we would try to use a perimodular electrode, because the closer the electrode is towards the modulus, the less chances of the electric current being shunted towards the lateral wall of the cochlea. Or we could use electrode with a monopolar stimulation mode. So when we have the active electrode in the cochlea and the inactive or the indifferent electrode outside the cochlea, we have a wide electric current, which is more specific, which stimulates a more specific region of the cochlea. So we don't have this electric current shunting, which we see usually in a bipolar mode of stimulation, where we have the active electrode and the indifferent electrode side by side inside the cochlea, and there is a larger electric field generated, and the offending electrode here seems to be the ones that is in the upper part of the basal turn, which stimulates the labyrinthine portion of the facial nerve. So it's known that incidence of facial nerve stimulation with perimodular electrodes could be as low as 0%. So apart from anatomy, another thing that we need to consider is, does my patient have residual hearing, or does my patient have low frequency useful hearing? So low frequency useful hearing is important, especially in cases of complex hearing situations and when we and in the appreciation of music. So when we have audible hearing less than 700 Hertz in the lower frequency, we try to use a slim, less stiff, adaptable length of straight electrode, which is directed towards the lateral wall. So an important caveat here is that if we use too short an electrode, we could compromise outcomes in patients and who ultimately lose their residual hearing in the long term. So to optimize this, we have an optimal insertion depth of about 360 degrees. In profound hearing loss adults or in a child with cochlear nerve hypoplasia, we could use a pre-curved perimodular electrode, which could give maximum stimulation to the neural elements. Also, we need to keep in mind when we are doing surgery on patients with residual hearing is that any act of electrode insertion, though it be a soft surgery, could itself release inflammatory cytokines and oxidative stress. And so patients, we have to be prepared that patients may lose their residual hearing in the long term. So cochlear duct length is again considered important by some surgeons, whereas some other surgeons believe that the electrode actually stimulates the spiral ganglion, which only covers about 1.8 turns of the cochlea. Some other surgeons believe that it's important to measure the length of the electrode and appropriate to the cochlear duct length. So this is important, they say, for low frequency hearing, which occurs towards the apical part of the cochlea. So matching the cochlear, the electrode length with the cochlear duct length helps to preserve the tonotopicity of the cochlear nerve. And we know that the average human cochlea is around 25 to 35 millimeters in length. So that gives a cochlear duct length of around 34.55 plus or minus 1.9 millimeters in length. So there are various ways which we can calculate the cochlear duct length, and most of them rely on a repeatable parameter, that is the outer diameter of the basal turn of the cochlea. And this formula was initially given by Escudé, where he calculated the angle theta to be equal to about 720 degrees. And that, he said, was probably the maximum electrode array could reach safely, because beyond that, the lateral wall of the scala tympani slopes rapidly, and you could not insert an electrode anything greater than 0.35 millimeters. So once we have that out of the way, the other thing we need to consider is it going to be a reimplantation surgery? So with the history of cochlear implant surgery growing longer, we may have patients who will need eventually some kind of reimplantation surgery, and that could be device related or medical related. So device related conditions would be due to electronic failure or due to lack of hermeticity, and medical related indications could be due to infection or electrode migration, or even an upgradation of future technology. So what we need to consider is, what was the electrode used in the previous surgery? We need to consider using the same type of electrode, and preferably it could be slimmer than the first electrode that was used. And this is because once we do a cochlear implant surgery, there's a fibro-osseous tunnel which is formed in the scala tympani around the electrode, and this may preclude full insertion if we use a thicker electrode later on. So in this picture, we see that the first time there was a slimmer 1G electrode used, and in the second time round, there was a helix electrode used, which is a bit thicker. And so we have incomplete electrode insertion, and we could land up with poorer speech outcomes. The last thing that we need to consider when we go about choosing our electrode is, what is the surgical approach that I'm going to use? Is it going to be a standard posterior tympanotomy approach, or is it going to be a Varia approach, or do I need to do a middle cranial fossa approach? So in the Varia approach, which is done by a few centers in India as well as abroad, it's a non-mastectomy approach where there is a suprameatal tunnel drilled around 1.4 millimeters in diameter, parallel to the posterior canal wall, and then the electrode is guided into the cochleostomy, either through the bony cochleostomy or through the round window. So the other approach that we use in cochlear implant surgeries could be a middle cranial fossa approach, and that is indicated in some instances where we wish to avoid the middle ear, and that could be for a radical mastectomy cavity or an adhesive otitis media, or even in some cases of otosclerosis. So in these cases, the middle cranial fossa is opened, and the floor of the middle cranial fossa is drilled, and the cochlea is entered at the most superficial and superior portion of the basal turn of the cochlea, after identifying the meatal plane and the superior petrosal sinus as landmarks. So when we come to if you're doing a surgery through a standard posterior tympanotomy approach, we could use any electrode, either a straight or a pre-curved perimodular electrode. If you're using the Varia technique, then obviously we can use only the straight electrode without a stillet or without a sheath. And a middle cranial fossa approach warrants us to use a straight electrode, or we could use a double array as per the indication of the case. So in conclusion, I would say that the right electrode influences the outcome of surgery as well as hearing in special situations. It helps to prevent complications like facial nerve stimulation, a gusher, or a wrong placement of electrode, and a correct scala placement and modular proximity offers us better patient outcomes. So a cochlear implant surgeon should have adequate knowledge of electrode types, the indications, as well as expertise in handling various types of electrodes to make the best choice for his or her patients. Thank you very much for this time and opportunity.
Thank you, Anjali. Can you hear me?
Yes, thank you, ma'am.
That was a very good talk. I don't know, am I allowed to ask questions now or after the first two? what you said was absolutely right, that we need to choose the right type of electrode. I have one question. Supposing you're using standardly two companies or one company that doesn't have the type of electrode that you need to put, what would you do? You would compromise or?
Yes, ma'am. I think that's a very important question, and that sort of situation does arise once in a while. But I wouldn't compromise on the type of electrode. If I need to use an electrode that is offered by a company that I'm not, very familiar with, I would go all out and try to get it.
I see. Sometimes some people like ADIP, they can have a choice of only nucleus or medal.
Yes.
And others have a choice of only nucleus, only AB. So that's when the problem might arise.
Yes.
But it's good that you have the option of trying the company for the correct electrode, especially for Mondini, ossified cochlea, and things like that. Extra slim, flexible electrodes, right?
Yes, ma'am. Thank you.
Would you say you get better results with 2.5 turns than with 2 turns or 1.5 turns?
I think the minimum angular insertion depth we have to keep in mind, ma'am, should be more than 420 degrees. So
right.
If we have the electrode that could cover that, we should use it.
Correct. No, but your results, suppose you have 2.5 turns and you have somebody with 1.5 turn. Would there be a difference in the results, speech, hearing, understanding and noise, all that? Would there be a difference?
Yes, I think so.
Yeah, that is because spiral ganglion are there. There are some recent articles which show that the spiral ganglion are there even at the tip. So that's why you get better results with deeper insertion or full insertion. Thanks for a very nice lecture. Are there any other questions from somebody else? See the question box, please.
Ma'am, we're running short of time, so I think we will move forward with your permission. Thank you so much for chairing this.
Can I ask Dr. Baumgartner just one question?
You can. Yes, you can.
Dr. Baumgartner?
Yes. Yes, I hear you. I hear you, Professor.
How do you put the electrode finally in the round window cochleostomy? Manually? You're not using a robot.
Yes. The robot goes into the scalar tympani, then the robot removes. And then you just put the electrode with your hands in as always, right? The pure electrode insertion is still a pure manual procedure. Yes, this is the only one last thing the surgeon need to do.
That's right. Now you have 40 to 50 cases you've done. So I'd like to know, are the results better than with the regular standard way?
No, that's not true. So we have now 46 cases in 3 departments. So we have Bern in Switzerland, we have Antwerp, and we have Vienna. Those are the 3 departments with 46 cases. We analyzed the clinical outcome, but the honest answer is the clinical outcome is the same as if you would have done manually. So at the moment, the procedure is to prove that the robot can do even the same procedure as a human being, right? But there's no outcome difference.
But you have been using what we call the barrier technique, which I did my first in '94 without a robot.
Yes, exactly. You're right. This was the start. This was the beginning. You're absolutely right. We started with this. And then we thought, look, if this works so well, then this can even be done by robot. But it's absolutely right, correct what you say. This was 16 years ago, the start, in 2005.
Right. And the last question is, do you have to ask the patient first, do you want a robot or without a robot?
Yes, this is, absolutely. This is very interesting. So first of all, the robot is only allowed for persons 18 years older. So it's not for pediatric use. And at the moment, and we ask for consent, and it's really funny. we evaluated exactly. 60% say no problem and 40% say no thank you. And the funny thing is, elderly people, let's say we have a significant difference age 60, people older than 60 would not do the robot. In younger people, 80, 20 years old, the younger the population, the more likely they want to have the robot.
Right. And finally, last question, is there a difference in the cost of the surgery with the robot and without?
I mean, it depends if you calculate. So if you want to buy the Hero now, it's just 2.5 million euro.
Oh.
So it's available on the market now.
I won't see that in my generation. I don't think.
But if you do not think about the Hero costs itself, it's the same. Yeah? There's no difference in price.
Thank you very much for very enlightening talk. It's like this, like we can't go to the moon, but we must know how the astronauts reach the moon. Thanks a lot.
Thank you. Thank you.
Bye.
Thank you, Dr. Sandra. Your blessings to all of us here in CG, and wonderful. Thank you. So pleased to have you here with us. We'll move on to the next section. Thank you, Dr. Baumgartner, on coming to us Sunday morning from Vienna. This was absolutely fantastic for you to be with us this morning. All right, let's move on to the last section of today's discussion. And to chair this session, we have Dr. Baya Srinivasa Rao. Dr. Baya Srinivasa Rao is from Guntur in India, and he's the founder of the Baya ENT Hospital, MS ENT from PGI Chandigarh, trained in cochlear implant surgery at Houston as well. In addition to here, first surgeon to start cochlear implant surgery in the combined state of AP in the coastal belt of Rayalaseema, extensively trained in implant surgeries in Sydney, in Poland, in Zurich, attended several national and international conferences, workshops. He's been faculty. He's had, he and his son as well now, they both have a very special interest in cochlear implants, and they run one of the largest state-supported programs as well in their state. Over to you, Dr. Baya Srinivasa.
Good evening, Dr. Sunil. Am I audible to you?
You're audible, yes.
Good evening, Sunil and Dr. Sankar Mandikari and the organizing committee of CIGICON for giving me this opportunity to chair the next two lectures, guest lectures of Dr. Goyal and Dr. Briggs. So, Dr. Sunil Goyal, he has done MSc, TNB, neuro-otologist, and Dr. Sankar Mandikari and the organizing committee of CIGICON for giving me this opportunity to chair the next two lectures, guest lectures of Dr. Goyal and Dr. Briggs. So,
Doctor, please report from the delegate login.
Dr. Sunil Goyal has done MSc, TNB, neuro-otologist, and Dr. Sankar Mandikari and the organizing committee of CIGICON for giving me this opportunity to chair the next two lectures, guest lectures of Dr. Goyal and Dr. Briggs.
Please report from the delegate login.
Dr. Sunil Goyal has done MSc, neuro-otologist, and Dr. Sankar Mandikari and the organizing committee of CIGICON for giving me this opportunity to chair the next two lectures, guest lectures of Dr. Goyal and Dr. Briggs. The present designation and affiliation of Dr. Sunil Goyal is Professor of Commander Hospital, Eastern College.
Doctor, please mute another system.
The areas of interest: neuro-otology, implantology, skull-base surgery, laryngology, and airway surgery. Major achievements and awards and publications. He is elected a member of National Academy of Medical Sciences, Best Paper Award in CIGICON 2016. Publications, he had many publications. Reviewed journals 15, and they has reviewed about 5 journal 15. He has reviewed journals 15, chapters 5. Professor Dr. Rob Briggs, he doesn't need any introduction to any cochlear implant surgeon across the world. He is from Australia. Professor Robert Briggs is an otolaryngologist whose current appointments are clinical professor in the University of Melbourne Department of Surgery and Otolaryngology and head of otology and medical director of cochlear implant clinic at the Royal Victoria Eye and Ear Hospital. Professor Briggs' major role is involvement in and supervision the provision of otology and cochlear implant clinical services. This includes responsibility for the ongoing clinical research in the cochlear implant clinic and introduction of new clinical guidelines, surgical techniques and devices. So I had that great opportunity to have a training under him in 15 years back in Melbourne. Now, I invite Dr. Sunil Goyal to start his lecture. And 15 years back in Melbourne. Now, I invite Dr. Sunil Goyal to start his lecture. Years back in Melbourne. Now,
Dr. Sunil, can you please?
Good afternoon to all. Am I audible?
No, you have to log out from the delegate link or you have to mute that system.
Years back in Melbourne.
Now,
is it no?
Now you can share your PPT, Doctor. We can't see your slides as well.
Is it seen now, sir?
Yeah, please go ahead, sir.
Am I audible?
Yes, sir.
First of all, a very good afternoon to all, and I would like to thank the organizing committee, especially Dr. Sunil and Dr. Shankar Medikari, for giving me this opportunity. The topic given to me was audit of surgical outcomes in cochlear implantation. So, audit, as we when I was given this topic, I was wondering what is exactly the difference between an audit and a clinical research. And what I could make out of it was a research is to know whether we are doing the right operation, while an audit is, are we doing the operation right? With that, the surgical audit basically means it's a systemic critical analysis of the quality of surgical care carried out by those persons engaged in the activity concerned. It include all kinds of aspects related to the surgery. It can be categorized into various types based on what events are being analyzed and what is the target population. Here I will be presenting the audit of our hospital regarding the cochlear implantation. Why we do an audit is basically to have an introspection into our different aspects of the surgery, which will educate ourselves. Thereby, we can make changes and amend the protocols which we are following, which will improve the patient care, and we can suggest changes to the hospital or our organization where the challenges and deficiencies can be identified and improved upon. The various components of an audit includes the structure, the process, and an audit output. But basically what I'll be presenting is the audit cycle, which will comprise of determining the scope of the audit, selecting standards, followed by collecting the data and the presentation of the results. An audit need not be a very mega audit at the very outset. It can start small, then gradually increase to include various aspects. I would like to emphasize on the fact that the Armed Forces Medical Services was one of the pioneers of cochlear implantation in India. And the focus from the very beginning was pediatric cochlear implantation. And it gathered momentum as other centers got included into the cochlear implantation program in the Armed Forces. And at present, most of the cochlear implantation are being done at the Army Hospital RNR, apart from AFMC and other centers. These are one of the earliest photographs of patient being evaluated at EHRR. So the scope of the study was to do a surgical audit of cochlear implantation at EHRR. The various aspects which we decided, which will include in the study, was duration of the surgery, the length of hospital stay, how long the patient has to stay in the hospital, any unplanned return to theatre before the patient is discharged, any unplanned readmissions, and the surgery-specific complications. So based on literature review, we considered any surgery more than 2 hours to be prolonged. Any stay more than 5 nights would be a prolonged hospital stay, and any other of these 3 aspects would be analyzed upon. All cochlear implantation surgeries carried out our center between 1st September 2018 and 31st August 2021 were retrospectively analyzed with the help of our hospital records department. So when we collected the data, there were a total of 114 years, and which included 111 patients, including 3 bilateral sequential cochlear implantation. Since in Armed Forces, still bilateral cochlear implantation is not a standard of care and not routinely done for all patients, except in special scenarios, bulk of our patients are unilateral cochlear implantations, out of which most of them were prelingual, and 8 were perilingual and 7 were postlingual implantation, out of which 7 years, out of which 3 were bilateral sequential cochlear implantation. The male to female ratio was 1:1.6, and most of the surgeries were done in right ear. The mean age was 6 years because it included the perilingual and postlingual deafness too, with a range of 1.1 years to 56 years. When we distributed the etiology of hearing loss in these 3 groups of patients, most of the prelingual deafness were non-syndromic with an age range, overall age range of 1.1 to 5 years and a mean age of 3.7 years. When we analyzed the inner ear anatomy in our cases, the bulk of the patient had a normal inner ear anatomy of 103 years, while only 11 patients had an abnormal inner ear anatomy based on CT scan and MRI scans, of which 4 patients had large vestibular aqueduct, 3 had Mondenis, 1 had IP2, 2 had IP1, and 1 had hypoplastic cochlea. Among the normal inner ear anatomy, 5 had cochlear ossificans, of which 3 years included cochlear otosclerosis. When we checked whether we were able to achieve complete electrode insertion, apart from 3 cases, one of cochlear ossificans, one of IP1, and the other of hypoplastic cochlea, all the patients we were able to achieve complete insertion of the electrodes. This is one of the patient who was having complete Levithan aplasia with absent cochleovestibular nerve on the right side, while on the left side there was a hypoplastic cochlear nerve with a hypoplastic cochlea. This is the same patient showing the hypoplastic cochleovestibular nerve, Castleman type 2A. The standard route of surgery in our center is posterior tympanotomy, so none of our patients had undergone a Varia technique, while 3 of the patients underwent subtotal peritosectomy with aortic capsule sparing. All these 3 patients belong to the group of chronic otitis media with cholestoma who underwent subtotal peritosectomy. Among the posterior tympanotomy, most of the patients were round window or an extended round window approach, and 19 patients underwent a Basildon cochleostomy. Most of these patients had undergone cochleostomy for the thesis indication, as one of our postgraduate trainee had a thesis to compare the outcomes between round window and cochleostomy. Rest 5 patients were of cases of cochlear ossification where a Basildon cochleostomy was done. One patient had undergone a cochleostomy entry to the round oval window below the process of cochleoformis. This was a patient in which the round window could not be visualized on radiology and intraoperatively and had a hypoplastic cochlea. This is a representative image of one of a patient showing complete ossificans on the right side and Basildon ossificans on the left side. The CT scan of the same patient showing complete ossificans and minimal ossification on the basal delta. This is a CT scan of a patient with hypoplastic cochlea. This is at the level of the posterior tympanotomy where we are expecting a basal of the cochlea, but we see there is no round window here. And the distance of the cochlear lumen from the promontory is around 3.42 mm. When we checked for the distance from the promontory at the level of the processor cochleoformis, it was around 1.84 mm. So in this patient, we did a cochleostomy at this point. When we analyzed the duration of surgery, we could see we further divided the duration of surgery into pre-COVID, post-COVID wave 1, pre-COVID wave 2, and then post-COVID wave 2. As we can see from the box chart, there was an increase in duration of surgery during the post-COVID wave 1 period, and gradually again it decreased to around 68 minutes in the post-COVID wave 2. The main reason behind what we feel is because of the increased precautions which were taken during this time, which included the facial mask and the auto tent used during the surgery. When we compared the length of hospital during the surgery, during the cochlear implantation, the length of surgery during the pre-COVID period was 3.67 years, which increased mildly over the next 1 year, and it has come down back to around 4 days. Two of our cases out of the 114 surgeries required an unplanned return to the theater before the patient was discharged. One of this patient was implanted with the advanced bionic 1J electrode. In this patient, the electrode went into, it was a normal anatomy. Important to note that the patient had a normal anatomy, and the electrode went into the superior semicircular canal, as can be seen on the radiograph. So in the post of day 1, we did an X-ray which showed this position of the electrode. Of course, intraoperative, we did not get any NRT, and we suspected that might be something wrong. And so we took up the patient again the next day, and the electrode was withdrawn, and then it was reintroduced by extended round window approach. Another patient had a partial extrusion immediately on the post of day 1, although we had all the electrodes in and the NRT was normal intraoperatively. But surprisingly, on the post of day, when we did X-ray, there was a partial extrusion, and so again, this patient was taken up to the theater again. When we looked into any readmission revision surgeries required, a total of 5 patients out of 114 required revision surgeries, 3 of which included surgical site infection, and 1 had a gradual partial extrusion over a period of 8 to 9 months, and one of the patients had a persistent CSF leak which had to be re-explored and replugged. This is a short surgical video showing the debridement of the surgical site infection and placement of a temporoparietal facial flap for reconstruction of the implant. The biofilm is being removed here. The soft tissue around the electrodes is also cleared off. The implant is washed with betadine, hydroperoxide, and tea tree oil. The receiver stimulator bed is drilled to remove any biofilm there. The temporoparietal flap is raised anteriorly based and rotated over the implant. Out of these 3 patients, one of the patients had a positive culture report of Burford area, which was sensitive to chlorotrimazole. This was in fact the first patient. So all our 3 post-operative patients, we gave them Ceftan as the antibiotic in the post-operative period. This is the X-ray of a patient who had a partial extrusion of electrode over around 8 to 9 months period. This is X-ray showing the complete insertion of electrode, and this was gradual extrusion, which can be seen on the X-ray. So, talking about the complications, intraoperatively, we had around 11 patients who had CSF leak. Out of this, 11 patients all were managed intraoperatively, and we had control over the CSF leak. Out of this, 3 patients had some minimal CSF leak in the post-op period, which settled down within the next couple of days. Only 1 patient required a revision surgery after around 3 to 4 months. This is the same patient with a hypoplastic cochlea where the cochleostomy was done, entered to the oval window. A wide cochleostomy is done. CSF gusher can be identified here. As was discussed by Dr. Amit Kishore, a wide cochleostomy is required to release the pressure. Only partial insertion of electrode is achieved here. It was sealed in layer with tissue, fascia, and muscle. Among the post-operative complication, other complications were a partial electrode extrusion, where revision surgery was done in both the patients. One of the patients had a House Beckman grade 3 facial paresis, which was medically managed, and the patient recovered within a month. 3 of our patients, all 3 patients with cochlear otosclerosis had facial nerve stimulation, which was managed during mapping by reducing the comfort levels and even switching off few of the electrodes. Out of the 3 surgical site infection, salvage surgery was done with a temporoparietal facial flap rotation. We were able to salvage 2 of the implants. However, one of the implant has to be finally expanded. And this patient was not willing to undergo revision surgery, and so is now without an implant. 3 of our patients also complained of pain with the use of the implant, 2 of which were patients of otosclerosis, which was again managed with mapping. And 1 patient was associated with a partial extrusion, and once we reinserted the implant, the pain resolved. So to conclude, the important thing which would like to highlight is the surgical site infection, which can be controlled with improved surgical sterility. The second thing which you observed was with advanced binding 1J electrode, extended down window approach would be a preferable way to avoid entry into any false track, and use of C-arm X-ray for all patients with abnormal inner anatomy and revision cases. However, ideal scenario would be a hybrid OT where inter X-rays and CT scan can be conducted. To conclude, surgical audit is an unbiased system, and critical analysis of quality of surgical care against recognized standards needs to be done. There should be a culture of no blame, and however, at the same time, it should not become a burden for the clinician to conduct an audit, and so the data has to be simple, however accurate, and we should have an effective feedback loop wherein we can introspect and improve upon the care given to our patients. And it should also provide an opportunity to the surgeons and the team. Thank you.
Dr. Goyal.
Yes, sir.
A very good presentation. May I just ask you one small doubt? See, this post-COVID for the last 2 years, are you doing regularly all the children whom you are operating, or adults whom you are operating, doing any antibody tests regularly?
Sir, we are doing both before the patient is admitted in the OPD itself, antigen test is done, followed by there is a antibody test done on admission. And after the negative report only, the patient is taken up for surgery.
So surprisingly, what we are finding is almost 50 to 60% of the patients whom we are operating, the antibody is positive, IgG, and they never had any history of COVID. So this is a silent COVID effectors. So once you have a IgM, if there is IgM, we are postponing for 1 more month. And once IgM becomes less than 1, we are taking up those cases.
We did not, and we did have few patients who were positive, and the surgery was delayed for those patients. But otherwise, it was okay with us.
Very good presentation, Dr.
Thank you, sir.
May I invite Dr. Robert Briggs to start his lecture.
Well, thank you very much. And good evening from Melbourne, Australia. First question is, can you see my presentation and can you hear me?
Yes, we can.
Thank you. I'll proceed then. It's a great pleasure to join you for the final presentation, I believe, for CIGICON. It's wonderful to see how the cochlear implant services in India have dramatically improved since many years ago when I attended the first CIGICON meeting. So congratulations to you all. Of course, I'm affiliated with Cochlear in Australia and work in Melbourne. The topic revision surgery, you've already heard a great deal about from many speakers, I think, in the last few lectures. And some of what I will show is reiterating what you've already covered very well. Perhaps the indications could be for revision surgery can be classified as where the electrode needs repositioning, either because of immediate or delayed problems, where the receiver stimulator package needs repositioning, which is relatively uncommon, where the magnet needs removal or is displaced, where there is implant failure, either proven or suspected, and those situations where there's implant infection, wound breakdown, or device exposure, which might involve either the electrode in the middle ear or the external canal or the package or the antenna. And the other problematic area is chronic otitis media, which we probably don't have time to cover in any great detail. For electrode replacement, I think the indications are where there's incomplete insertion, where there's extracochlear placement, tip fold over, delayed extrusion migration, which is an increasing problem with the newer thin electrodes, and of course reimplantation and facial nerve stimulation we've covered, or you've covered, where a perimedullary electrode is certainly indicated for otosclerosis, as that facial nerve stimulation is uncommon with the perimedullary electrodes. Here's some slides which just show an example of where an electrode's buckled during insertion, and so there's incomplete insertion. A couple of examples of tip fold over, an example of incomplete insertion with the old straight banded array, and a case here where there's been migration over time from still not a good insertion, but there's been further migration. And it's of interest to note that this is with a straight banded electrode, and that was relatively uncommon, but it certainly occurs more often with the newer, thinner straight electrodes. And you've already also seen examples of extracochlear placement, and this is where case with normal anatomy, it's gone into the superior semicircular canal, as shown well. Or where an example with incomplete partition type 3, an electrode's been placed through the internal auditory canal, almost into the posterior fossa. So considerations for immediate replacement, where there's tip fold over, it's usually, if it's recognized intraoperatively, it's straightforward to remove and replace with the same or a new electrode. If there's been intracochlear obstruction and that's what's caused problems with insertion, then I'd advise considering using a depth gauge or a stiffer electrode to confirm that you can get the electrode in. It's a different situation where it's delayed electrode replacement. In this case, the cochleostomy usually has some new bone and fibrosis surrounding the electrode, which might limit replacing it. And then we have to consider the intracochlear state. It's no longer fluid filled. There'll be fibrosis and possibly ossification. But in principle, I think it's appropriate to replace like with like. So the same type of electrode should be replaced with the same diameter and same type of electrode. When you're reinserting the fibrous sheath that's around the electrode usually facilitates the insertion of the new electrode, but you need to remove the extracochlear fibrous tissue right down to the cochleostomy. And I find that it's helpful to just then inject some Healon after the electrode's removed. If you're putting in a larger electrode, for example, replacing an old straight electrode with a contour electrode, then it will require revision of the cochleostomy. If you've got a perimodal electrode, then I would try to replace that with a perimodal electrode if it's a contour type, but then I would use an advanced soft stylet insertion, so it follows the trajectory of the electrode. But if you have a slim modular electrode, the newer 32 model, then I would replace that with a slim straight electrode because the sheath that's required to insert the slim modular won't fit through without doing a revision of the cochleostomy. And so that increases the complexity of the surgery. Here's an example of the straight banded electrode. You can see it is removed relatively easy. There's some resistance as it comes out. And then just instilling a little bit of Healon to keep that lumen of the sheath open. And then clearing some remaining fibrous tissue that's there. And then the new electrode is inserted in the same trajectory. And in this case, using the claw to gently advance the electrode. And trying to avoid kinking the electrode at all, because if such as that, because if you kink it, then it's harder to get the same direction of insertion. And in my experience, the new electrode usually goes in deeper than the original electrode position. So that is a good thing. It generally means that full insertion is possible where the electrode's being replaced. And here's an example of a contour electrode being replaced. You can see it's a significantly bigger electrode, and as it's removed, the pre-curved coil demonstrates itself. And then you can see, again, instill some Healon into the lumen, although the lumen is, in this case, staying clearly open. And then the new electrode is inserted. Often with revision surgery, there's tendency for more bleeding. So inserted it to the white mark at the back of the electrode sheath, or the electrode silicon. And then an advanced soft stylet insertion so that the electrode itself will follow around the medalis and hopefully lie within the same fibrous sheath that the previous electrode came out from. We talked about, or the magnet replacement was shown earlier. It can be dislodged due to trauma, or it may need to be removed in order for the patients to undergo MRI imaging. And my only suggestion is to be sure to use an offset incision, so it's away from the edge of the antenna, and then there's very little chance of having pressure necrosis problems in the future. And an incision is made down, then the capsule surrounding the implant opened, and the magnet can be removed or if necessary, replaced. And here's a close-up showing the silicon pocket that the magnet lies in, and care should be taken to avoid tearing that silicon cover. And usually it's easy to manipulate it, and I tend to use a relatively blunt instrument such as a Beal's elevator to elevate that silicon. So how do we recognize device failure? Well, typically the common presenting symptoms may be intermittency or loss of sound detection. The audiologists often report loss of channels, increasing loss of channels on mapping. Sometimes there is a sudden cessation of sound, or children start failing to respond. And sometimes there's unusual symptoms such as a shock to the head or just a decrease in quality of the sound reported. And the most important thing is to have good integrity testing available. And this is for modern implants, implant telemetry and measurement of impedance and NRT is possible. And for all types of implants, it's possible to measure a stimulogram. And this is an old CI22 showing the recorded stimulation response in the common ground bipolar and pseudomonopolar modes. In our experience, when the presentation of failure, often there's a so-called prelude phase where initially integrity tests appear normal, but if the symptoms persist, then in our experience, almost always repeated integrity tests have confirmed failure. And so I think these days the integrity testing is extremely effective and sensitive. The causes of device malfunction can be perhaps classified as impact failure, where there's a fracturing of the antenna coil, the case, or the feed-through. Hermeticity failure, where there's a failure of the hermetic seal, often involving the celastic cover, and then the titanium can. Electronic failure, where there's perhaps an open circuit or fracturing or problems within the integrated circuit. Or an electrode array problem where there can be fracturing of wires in the electrode array. And so it's very important that the electrode wires are positioned beneath the cortical bone so that they're protected from any trauma over time. But crucially, if an implant is failed, then or considered to be or thought to be failed, then the device should be returned to the manufacturer so that they can identify and address the causes of failure. And here's an old slide demonstrating the difference between an early model CI22 implant where it was demonstrated that it was an open circuit between the receiver coil and the platinum foil. And here's the corrective action that was engineered into subsequent devices to correct that problem. And this kind of repeated modifications of design based on experience is what's allowed the manufacturers to produce the devices, which are now very, very reliable. There was, of course, a consensus statement, and this is the report you will receive from the manufacturers describing the type of failure or out of specification, whether it's performance decrement or characteristics decrement. But for the sake of time, I won't go into the details of this. But it's interesting, in Melbourne, we previously reviewed 62 cases of reimplantation 30 pediatric and 30 adult. And it's of note that the pediatric patients have a higher incidence of device failure, whereas the adult patients had a higher incidence of medical problems such as wound breakdown or infection. And that was perhaps because more of them had had previous chronic otitis media issues. Whereas the children, particularly in the past, if they've had fell and problems, they're more likely to damage the device. So the auditory outcome for reimplantation is very pleasing. We examined the speech perception test results and compared the results with the best result with the first implant with the results either 6 or 12 months following the implant, and sometimes was incomplete data for young children who didn't have the initial outcome performance or where there had been early device failure. But for pediatric group, you could see here that the more reddy color is the second implant, and results are generally better than that with the first implant. Whereas the adults, the first and the second are rather more similar. But in summary, children show performance gains that are consistent with their learning and brain plasticity, whereas the adult performance appears unchanged after reimplantation. We had a few patients where the implant was removed because it was thought that they had a failure. There was poor performance. And in these ones, there was no significant improvement. And so they had a medical issue rather than a device problem. And pleasingly, for those with infection and wound problems, provided we achieved successful control of the infection, then their performance was the same as the pre-implant performance. There are, of course, significant surgical challenges with reimplantation. This slide shows an old style CI22 implant with the electrode cable embedded in bone at the mastoid cortex. And there's usually fibrous and bone fixation of the receiver stimulator and the cable within the mastoid. And with the electrode, our principle is to avoid early electrode removal, to identify the cochleostomy in the fibrous tract so that it is safe and possible to reinsert the new electrode. There are, of course, risks of reimplantation, particularly that there may be difficulty reinserting the electrode. That may be associated with worse auditory performance. And I think that after any revision procedure, there is perhaps an increased risk of getting wound breakdown or device exposure or infection occurring. Cutting through previous scar doesn't heal as well as going through de novo tissue. But briefly to summarize the surgical technique, I think it's sensible to use the previous scar incision, but that may need to be extended. Then use the usual type of fibroperiosteal flap, mobilize the receiver stimulator, but try to not remove the electrode cable until you've identified the electrode at the cochleostomy. Although if it is being removed for infection or other problems, then you can simply cut the electrode cable and remove the package. Dissect the cable in the mastoid, reopen the facial recess, and then remove and replace the array as I showed earlier. For the sake of time, I don't have a video to go through, but just to show you that this was a 4-year-old who was implanted at 8 months of age, and there's extensive new bone formation once again. And so the external ground electrode is there mobilized, then the mastoid antrum, the mastoid is reopened, it's air-filled. There's extensive fibrous tissue around the receiver stimulator package, and that needs to be cut to mobilize the device. And then the new implant is positioned prior to then removing the electrode and reinserting the new electrode. And if necessary, I would tie down the new implant so that it doesn't migrate. So this is an example where relatively early reimplantation has been necessary. This is 6 weeks post-primary surgery. And you can see the increased challenge where there's certainly no pneumatization within the antrum. or the mastoid, it's an organizing hematoma effectively. And so clearing this out prior to visualizing the round window to reinsert the electrode is more of a challenge. So another area of reimplantation is where there is wound breakdown. And I like to think of what we now have learned from clinical experience and return device analysis is that we understand the role of biofilms. Infection, of course, might involve the receiver stimulator package, or it might be the electrode cable in the mastoid or middle ear, or it might be the intracochlear electrode itself, in which case there's usually been a performance decrease over time. And that often means that it might be an unsalvageable situation. Here's an example of acute otitis media with mastoiditis. And this is an early postoperative picture, a very old one, because you can see it was a long incision. And this required a washout and completely recovered. And similarly here, acute otitis media with mastoiditis, but if the ear can be drained and they have appropriate intravenous antibiotics, complete recovery can occur. And the reason for this is that the bacteriology is usually a streptococcal species or Haemophilus and responds very well to intravenous antibiotics and ventilation drainage, but they're not biofilm forming, and so there isn't chronic contamination of the device. Here's a couple of examples, one not from Melbourne and one from Melbourne, where the device has been exposed. And this is what I would call a salvageable situation. There's dry device exposure without granulation, often perhaps related to pressure necrosis or where there's a scar overlying the implant. And in this case, it is possible to revise and recover with healthy tissue, such as we've seen earlier today with temporoparietal fascial flap. This is the case from the left there. And once again, showing there isn't profuse watery granulation around the implant package. It's white and relatively clean here. So if this is all excised and the implant is washed with antiseptic, repositioned with a generous rotation flap here to get primary closure. And in this case, this was in fact done 25 years ago, and the patient is still using the implant without problem. But in the majority of infection cases, it's non-salvageable. And this is where there's wet infection, profuse granulation. It might be associated with wound breakdown and fistula. Attempts to salvage almost invariably fail, and it does require device removal and then delayed reimplantation if that ear is to be salvaged. And the reason is that the bacteriology is Staph aureus or Pseudomonas. In the past, this has often been culture negative, and then it gets blamed on silicon allergy, and that is incorrect. It's due to infection. Here's 3 cases from Melbourne, all in relatively young people. And in the first here, you can see a couple of areas of breakdown and fistula formation. And then when that's opened up, there's clearly granulation tissue, which is wet and infected around the device. So I don't believe it's safe to try to salvage this. Here's another one, similar situation when it's open, it's wet granulation. And similarly, the third, that although it looks relatively innocuous, when this is opened up, it's the tip of the iceberg, and the device is and the surrounding the implant package is wet granulation. When these devices have been analyzed, what I've previously presented is a study from Cochlear where if an explant is for device failure without evidence of infection, very few, 1 out of 6, had biofilm present on the device. Whereas for 20 devices that were analyzed from around the world where there was explantation for infection, all of them had biofilm present. And I do believe that this is a reason that salvaging them with various types of revision procedures is not possible. And so explantation is the best option. various debridement drainage measures have been used, including things like gentamicin, collagen implants, oral rifampicin, etc., but it's a temporizing measure only. What should be done with the electrode? Well, it is possible to cut the electrode, leave it in position, and if there's no active infection around the electrode, then it can be subsequently replaced. Here's 3 further cases where, not from Melbourne, where you can see there's been multiple surgical procedures and salvage is just not possible. And all end up having delayed removal, and then often it's not salvageable. Here's just a picture showing the electrode. It can be left in situ if the mesotympanium is free of disease. Replace it with a dummy electrode if you're concerned that it might be contaminated. It is probably better to take it out and put in a new one, and then cut off the dummy electrode at the level of the cochleostomy, so at least the prosthetic that's being left in situ is known to be clean. If there's a sign of intracochlear infection, then it's safest to remove the electrode. Sometimes blind sac closure is necessary when implants are removed. Here's a couple of examples. This is electrode exposure into the external canal, and this is the danger of over-thinning the bony canal and not reinforcing it adequately if there has been damage to the canal. Whereas these are complications of the suprameatal approach, where the canal wall at the annulus has been damaged, and we end up with electrode exposure at the level of the tympanic membrane. And so in each of these cases, there's not active infection with granulation, so it is indeed possible to perhaps even do a simultaneous explant and reimplantation. But in each case, blind sac closure of the canal is necessary. Very important to get a good clearance of all canal epithelium. The mechanism of implant infection: early intraoperative contamination, perioperative bacterial seeding, or local wound infection, and delayed maybe perhaps due to hematogenous spread or pressure necrosis or trauma. So I think lessons from clinical recommendations, well, as you've heard earlier today, prevention and prophylaxis is most important, and had to have absolutely sterile surgical technique. The manufacturers are now revising the implant surface, so there's they're smoother, less aggregation of biofilm, and this probably is making a difference to the incidence of chronic infection. Most importantly, though, we need to recognize and manage infection aggressively. A negative culture does not necessarily mean absence of infection. And in my experience, chronic wet infection with granulation requires implant removal. And here's an example, again, of the surgical technique, meticulous technique, both of the instruments, theatres and staff. Perioperative, I don't believe that prolonged oral antibiotic use is needed. It needs to be perioperative. And I would use an offset periosteal incision so that we can separate the deeper incision from the skin incision, so that if there is a minor wound infection, then that doesn't result in infection that tracks to the implant itself. So in conclusion, cochlear implantation with various electrodes is safe and it is effective. I would suggest we confirm suspected device failure by implant integrity testing in all cases whenever you suspect that it is a device failure, and that where there is wound infection or wound breakdown, then aggressive management of the infection allows successful reimplantation. So I do hope that you'll all join us for the APSCI meeting, which is coming up in just a few weeks' time. And if you haven't already registered, then please do visit the website at www.apski2021.com, and we'll look forward to seeing you.
Dr. Prayas Srinivas Rao, if there are one or two questions, you can take them. We have some.
Certainly.
Dr. Briggs, a wonderful presentation, wonderful experience of you, really useful to all of us. So may I just ask a few doubts? One is, you said device failures 23 in pediatric group. So may I know how many out of how many implants there are 23 device failures, and what is the reason more device failures in pediatric population than adults?
Because I think the reason for that is that children tend to fall, and young children have more direct trauma, and particularly, that's an experience from over the past 30 years. And so particularly with the earlier generations of implants, the devices were more prone to failure if there was direct trauma. So I think that's probably the reason.
Yeah. So in cases of wound infection, you're talking about biofilms, all those things. What is your primary antibiotic used regularly? See, you have a methicillin-resistant Staphylococcus aureus and Pseudomonas. They do not respond to many antibiotics. So what is your primary antibiotic?
Well, my own approach is for a healthy ear. We're having a primary cochlear implant. They have intravenous cefazolin as the antibiotic prophylaxis. For adults, I use cefazolin for 24 hours and then nothing further. For children, I'm concerned that for particularly young children, that they might get an acute otitis media. So I would also give children a week of oral amoxil in the hope that that reduces the incidence of acute otitis media. But I don't know that we've got good evidence for that. We could perhaps just give them perioperative antibiotic as well. So the key thing is the meticulous sterile technique, perioperative high-dose intravenous antibiotic that has anti-staphylococcal cover, and hopefully no problems.
Two more doubts, sir. So during implantation, if you have a severe CSF, so sometimes you may not get NRT, neural response threshold, during surgery. So how many weeks or months it will take to settle and to get a normal response?
Well, I think neural response where you've got an abnormal cochlea, sometimes you never get a good recordable neural response. And so you don't know we would still do a switch on at 2 weeks, 2 to 3 weeks post-surgery. And we rely on what the response is from the behavioral mapping. We don't rely on the recorded NRT, because sometimes where it's a abnormal cochlea, abnormal neural anatomy, then you may never see a normal neural response.
Another small question, sir. In your experience, in grossly rotated cochleas, round window, if you are not able to see the round window, the posterior tympanotomy, are not able to see at all, it is totally posterior. So is there any occasion you have to switch, you have to do a permeatal approach to find out that?
In my experience, it's very, very rare. What I find is that if we thin the bony canal wall well, find the facial nerve early, and I think there was cases before showing where the external canal had been damaged going lateral to the cauda. So I do think it's the best and safest technique is to identify the lateral canal, identify the incus buttress, find the facial nerve immediately, find the cauda tympani, and then open through. And if you do a wide cochlea, a wide facial recess dissection, then in most cases you'll find the round window. If you can't, then by all means lift the canal skin and look into the middle ear permeator.
This is a very rare. Thank you, sir. Wonderful presentation.
My pleasure. No other questions?
No, if there are no other questions, I think we will wind up. Thank you, Rob Briggs, for taking over time and being personally present. I'm very happy that you are here physically.
Thank you, Shankar. A pleasure to see you all. All the best.
Yeah,
Take care.
Thank you. And that,
Bye. Good night, everyone.
Yeah. Thank you, Dr. Sunil also, Sunil Goyal and Dr. Bhaiya Srinivas for conducting this last part of the invited talks. Very interesting.
Thank you, sir.
Thank you very much.
Thanks.
So within another 5 minutes, we will be having the valedictory function. We would like people to stay back. So because there is another parallel sessions going on in audiology and habilitation, they are getting completed in another 2-3 minutes. So immediately after that, we will have the valedictory function. Okay. Audiologist ಯಾರು ನಾನು ಹೇಳಿಲ್ಲ ಅವರನ್ನು ಬಂದ್ ಮಾಡಿ
Good evening, everyone. A warm welcome to the valedictory function of the 18th CIGICON at the 6th World Congress. At the outset, I welcome Dr. Sunil Narayana, the organizing chairperson, CIGICON 2021, president of CIGI and GCIN, to give his opening remarks. Welcome, sir.
Thank you, Rashmi. Dear friends and members of both the Cochlear Implant Group of India and Global Cochlear Implant Access Network, the EC, the general body, the steering committee of the GCIN. What an overwhelming response it has been for this virtual conference, our first ever virtual conference. I must congratulate just about everybody who has been part of this organizing committee, and the executive council, and of course the steering committee for all their participations, their inputs. And I think we've had a fantastic 3 days of scientific deliberations, and this should all be available for each registered delegate for the next 3 months, starting hopefully Monday. In spite of these trying times with so many uncertainties, I think we've done extremely well in terms of the scientific content. In fact, we've done much better than we would have had in if this was a physical conference. So we didn't have to take care of travel or stay or bother about food, catering, etc., or even a cultural program. So I think pure science is what we did for the last 3 days. And then as far as food and beverage is concerned, I'm supposed to be on stage here right now for the valedictory function, but I've got my coffee in my hand. You wouldn't allow coffee, sipping coffee on stage in a physical conference. So I don't think I want to say anything more, because I think the brains are all saturated enough with all the inputs. We just need to sit back and reflect on how we did in the last 3 days. But like I said, the first feedback has been absolutely overwhelming and very positive. Thank you, each one of you, for this, for making this possible. Thank you. Thanks, Rashmi.
Thank you, Dr. Sunil. I now invite the Scientific Committee Chairperson, Dr. Shankar Medikari, for his address. Welcome, sir.
Thank you, Rashmi. So now I have the pleasant task of announcing all the awards for both oral presentation as well as e-posters in all the 3 streams. But before doing that, I would like to thank the judges in each and every stream who have been kind enough to spare time and come and assess all these oral papers and the posters on 2 days and give their excellent marking. So we had Dr. Ram Babu and Dr. Sangeeta Verti for the oral paper presentations in surgical branch, and Deepa Walme and Srikanth for the audiology oral papers. They have been kind enough to come and judge. And Dr. Gina Mary Joy and Miss Pratibha Dawson and Anuradha Batwal. So these 3 people did the judging for the rehabilitation oral papers. So I would like to thank on behalf of the scientific committee and the organizing committee all these judges for their efforts in assessing these papers and giving the awards. And as far as the e-poster category, so Dr. Gaurav Gupta and Dr. Kalpesh Patel, who did the e-poster judging for the surgery stream, and Mrs. Fatima Jagmag and Mr. Kannan, so did the e-poster judging for the audiology stream, and Aparna Nandurkar and Dr. Manjula P they did the e-poster judging for the rehabilitation stream. So once again, I would like to thank all these judges on behalf of the scientific committee and the organizing committee of CIGICON 2021 and the 6th World Congress on Cochlear Implantation in Emerging Nations. So now coming to the announcement of the awards. So before that, we have decided some each awardee will get the certificate for that, whatever first prize, second prize, and third prize. Apart from that, the organizing committee has decided to give them an Amazon voucher of rupees 5,000 for the first prize winner and rupees 3,000 for the second prize winner and rupees 2,000 voucher for the third prize winners on behalf of the organizing committee. And another interest, this will be both for the oral papers as well as for the e-posters categories separately. So another interesting thing what has happened now, so whatever judges had marked on that, so we have just totaled the different judges' marks, and without doing any modifications or any interference in that, we are announcing these prizes. So to our surprise, some of these prizes are shared by two people because of the ties, but in spite of the ties, so they will get the same prize what has been announced here. So both of them, if there are two people for the second prize, both of them will get 3,000 apart from the certificate. If it is a first prize, they will get 5,000 each for the first prize accordingly. So now I would like to go and announce the awards. So in the oral presentation of surgery stream, the first prize goes to Dr. Arindam Das for his paper on cochlear implantation, radiological assessment score, a novel scoring system to predict difficult round window insertion. Please give him a big hand. Then we have the second prize in oral presentation surgery going to Lakshmi Ranjit, who did a presentation on cochlear implantation in far advanced photostenosis, the MUF experience, second prize. And the third prize in the oral presentation surgery category goes to Dr. Kranti Bhavana for a study on radiological autoplan based study of intracochlear electrode position through cochleostomy and round window in transcanal varia technique. So these were the three prizes for the surgery oral presentation. Coming to the audiology stream, there were again three prizes. The first prize in the audiology stream for oral papers goes to Saji Muthukaran for his paper on remote check, a new tool for remote assessment of cochlear implant recipients. And the second prize goes to CS Vanaja for a paper on multi-frequency tympanometry in children who have undergone cochlear implant surgery. And the third prize in the audiology stream for oral presentation goes to Megha for a paper on profile of audiological assessment for cochlear implant candidacy in children in India. Okay, these were the three awards for the audiology stream. Now coming to the rehabilitation. So here we have a tie for the second prize. This is for the oral paper presentations. The first prize in the rehabilitation category goes to Pooja Behra for her paper on bilingualism in children with cochlear implants, an assessment protocol. And the second prize, as I say, shared by two people. One is Dr. Aparna Nandurkar for her paper on perspectives of parents of children implanted under EDIP scheme. And the second person for the second prize is Himanshi Sharma for a paper on costs and outcomes of telerehabilitation and in-person rehabilitation for pediatric cochlear implantees in the COVID-19 pandemic era. And the third prize for the oral papers in rehabilitation category goes to Dr. Anuradha for her paper on impact of lockdown on internet addiction, parent and peer attachment and behavior in normal hearing population and cochlear implant users. Okay. So this was the awards for the oral paper presentations in surgery, audiology, and habilitation. So now coming to the e-posters. So there were e-posters in surgery, audiology, and habilitation. So in the surgery stream, the first prize for the e-poster goes to Dr. Shivam Sharma, a cadaveric radiological study of various anatomical parameters in relation to cochlear implant surgery. And the second prize goes to M. Santosh Kumar for his paper on vestibular schwannoma excision with simultaneous auditory brainstem implantation in neurofibromatosis type 2 MRF experience. And the third prize for the oral presentation in surgery goes to Dr. Sunina Saju for her paper on Asia Pacific's first, second, and third simultaneous ipsilateral osseous implantation in skull-based surgery, the Bangalore the Skull-Based Institute experience. Okay, these were the three prizes in surgery. Now coming to the audiology stream, so we had here also three prizes. The first prize for the e-poster in audiology goes to Kirtana for a paper on efficacy of audio-video material on cochlear implant in Tamil about care, maintenance, and troubleshooting. And the second prize goes to Yash Shrimal for his study on 5 years photoacoustic emission data with follow-up protocol in a tertiary hospital setup. And the third prize in audiology stream for the e-poster goes to Dr. Praveen Kumar for his paper on saturation of MAP parameters in children with cochlear implants, effects of time since implantation and age. So these were the three prizes for the audiology stream. And now lastly, coming to the rehabilitation stream. So here, to our surprise, we have found that there are ties for the first prize as well as for the second prize. And there is only one third prize. So we have given these two prizes in each category. So the first prize goes to R. Rajalakshmi, a brief review on parental perspective regarding tele-oral rehab sessions for children with hearing impaired during pandemic. And the second person who got the first prize again is Pragna Bharadwaj for a paper on outcome after cochlear implantation in 2 children with congenital rubella syndrome. And now coming to the second prize for e-poster in rehabilitation goes to Shakti Lakshmi G for a paper on cochlear implants, parent knowledge on the parts and their self-reported knowledge on maintenance and troubleshooting of the processor. And the second person sharing the second prize is the Anuradha for a paper on comparison of generic quality of life measures in 1 year post-cochlear implanted children and hearing aid users. Okay, the third prize goes to Ruchika Mittal for her paper on feasibility of telepractice in post-cochlear implant recipients and lessons learned. So this was the prize or the award announcements for all the papers, both oral as well as the e-posters. So all the awardees, as I mentioned, will be getting a certificate from the office, and the first prize winners will get an Amazon voucher of 5,000 rupees. The second prize winners will get an Amazon voucher for 3,000 rupees, and the third prize winners will get an Amazon voucher for 2,000 rupees. Okay. Thank you. I think that was it.
Thank you, Dr. Medikiri. And we, on the behalf of the organizing committee, congratulate all the winners. We now invite our faculty about the feedback, to give us feedback about the virtual conference CIGICON 2021. We've invited faculty from all three streams. So first, I invite Dr. Javier to give his feedback. We'll need to unmute. Thank you.
Now, thank you very much, Rashmi. Dear colleagues, dear friends, on behalf of the international faculty, I would like to express my gratitude to the organizing committee of this CIGICON conference for giving us all the opportunity to share with you our experience on the field during these last days. First of all, I think I have to start emphasizing the immense effort made by Professor Sunil to bring this conference to a good end. Organizing an event like this was a difficult task before the virus changed our lives. And nowadays, excuse me, nowadays is really a titanic challenge. And thanks God, Professor Sunil has been more successful than the Titanic in its first trip. Therefore, thank you very much, Sunil, and congratulations for a great conference. You really deserve now a good rest. I would also like to acknowledge the participation of my international colleagues, people from all continents, willing to share their knowledge with all of us, no matter what time of the day or day of the week it was. In the times where you cannot start a lecture by saying good morning or good afternoon, because now more than ever, Einstein is right and time is relative, they have been happy to share their knowledge with all of us day or night. As always, the role of partner companies has been crucial. Now that technology is more needed than ever, their support constitutes a keystone for our improvement. Thank you very much to all of them. And with them, I have to include all technical staff that had to deal with inexperienced users like me, trying to share at the same time screens, thumbnails, videos, audios, and be able at the same time to give their speech. The patience of the men and women behind the scene has been tested to the limits, and they succeeded. Thanks a lot, and be prepared. This is just the start. And finally, my biggest set of thanks must go to the participants who are the ones giving meaning to our teaching. Those who are still willing to connect to a screen to learn something new, to increase their knowledge, to improve their abilities, just for the benefit of their patients. On behalf of these patients and on behalf of your international faculty in this Congress, thank you. Excuse me, thank you for being there. I hope life recovers normality soon and we go back to a personal meeting like before, because I must recognize that I miss people. I mean, I miss real people, those you can look in the eye and check what they feel while you are speaking, those coming to you at the end of the presentation with easy or challenging questions that you can discuss with them in person. And I would love to go back to India in the future, in the near future, to see all of you, to meet my friends, to be able to complete the motorbike tour around the Himalayas that we had to cancel due to the pandemic. I am sure that sooner rather than later, this will be possible again. And meanwhile, thank you all and keep safe.
Well, I just want to say, Javier, on behalf of the organizing committee, you have been one of the role model international faculty in terms of technical expertise. Your connectivity was fabulous. You had backup plans. You had sent your video already, and there were no glitches. Your video was absolutely perfect. You were absolutely fantastic. So I think you're a role model, virtual experience international faculty. Thank you so much for being with us all 3 days. Thank you.
Thank you, Sunil. Thank you all. And let's change soon from virtual to real.
Sure. Thank you.
Thank you, Dr. Javier, for your kind words. We now welcome Dr. Amit Kishore from India.
Good evening, everybody. Am I audible? Am I audible?
Yes, Doctor.
Here you are.
Yeah, Amit.
Oh,
Yes,
wonderful.
you are. Sorry about that.
Well, what do I say? You know, as Javier has already put it so beautifully. You know, I'm speaking on behalf of not just myself or the national faculty, but I think I speak on behalf of all the members of CIGI and all the participants who have attended this. You know, addressed to Sunil, Shankar, Dr. Madhuri, Rashmi, Apoor, the whole scientific committee, the whole organizing committee backed by everybody else. You know, Sunil, we all were looking forward to Bangalore a few years ago, and knowing, you know, how well the conferences have been organized by yourself and your team. And then COVID came, and then all this uncertainty about the conference and movement and you know, we've been there. And then this whole you know, situation of having moved from physical to virtual. So we cannot even imagine the trouble, the uncertainty that must be going on in your head, in your mind, at your end. But you know, whatever I say is not enough. I think at the end of the day, what you and your team have been able to put together in this virtual platform is par excellence. It has been a stupendous, excellent, mind-blowing conference, 3 days of pure learning, uninterrupted, backed by an excellent technical team and support by each and every one of you. You know, we've all, everybody, I think without fail, has enjoyed themselves. If you see the interactions, see what all the feedback's coming in through all our CIGI groups, I think that says it. So, you know, hats off to you. You've all come out with flying colors. Congratulations for a great show to all of you. We have had a magnanimous treat, you know, presenting, talking, and listening. You've been able to put together people from all over the country, all over the world, every time zone, everything come together. You know, it's unbelievable. So, you know, thank you very much. I think everybody, without fail, without exception, has enjoyed this, and all of you, you know, put together have really created a wonderful experience for all of us. Now, this makes it very, very hard for me. You know, I'm going to have a very hard act to follow, you know, because as Javier said, we want to meet in physical, in person. So yes, absolutely we do. We are looking forward to that. So we are actually looking forward to Delhi is hosting the next CIGICON, as you know. So on behalf of my organizing committee, Dr. Sumit Mrig, the organizing secretary, Nivita, treasurer, and myself as organizing chairman, you know, we invite all of you to Delhi on the 4th, 5th, and 6th of November next year. Hopefully, you know, we'll be able to run a physical conference, and all this COVID stuff will be, if not behind us, will be just sort of, you know, on the baseline somewhere, and we'll be able to meet personally, physically, and you know, have another good show. It's going to be a hard act to follow, Sunil. We will try our best. But so once again, Thank you very much from all of us. Amazing performance, amazing conference. Congratulations to all of you. Thank you.
Thank you, sir, for your kind words. And we also wish you best luck for the next conference as the organizing chairperson of CIGICON 2022. I now invite Dr. Vanaja as the national faculty from the audiology stream to give her comments. Welcome, ma'am.
Thank you. Can you hear me?
Yes, ma'am, we can.
Like the CG group is speaking about the conference, I think I don't have to say much, but it's really an amazing experience. Truthfully, when I registered for the conference, I did not expect such a big event. I said, okay, CG, we always learn something new in CG. So I said, okay, we always go for the conference. But it was really an amazing experience. It is like as good as what we have done if we had physically met, except that we missed meeting each other and greeting each other and sitting next to each other. So we had to pass messages through WhatsApp if we had anything, but otherwise it was really a very nice experience. The scientific program was very well crafted in all fields, surgery, audiology, and habilitation. And there was something for everybody. There was something for a beginners or something for who are already experienced in the field. So it was really good to have such a good scientific exposure, and it was really a learning experience. The advantage of this was now I could be in two places simultaneously because, example, yesterday, general body meeting, people were saying there no attendance. So I logged on to general body meeting while I was still listening to vestibular issues. So that was one thing. And also another thing is, since the whole thing is getting recorded and you're putting it, so we always had the thing, okay, I missed this in habilitation, but I can always watch this later. So that is one advantage. We're all looking forward. The conference is not ended for us now because whole of next week, we are going to listen to the recordings to make use of the maximum of it. So it was really, really an amazing experience. Thank you very much. It was really packed. It was so packed that end of the day, yesterday I said, I'm very tired now. And we really didn't have time to, I mean, I know we were doing at our own time, so we could have a cup of coffee or we can have this thing, but then we really didn't have time because we didn't want to miss anything. So that was the thing. So I think a small time gap between the sessions maybe would have acted as a buffer and it would have been more helpful is what I would think. Otherwise, it was an amazing conference. Thank you very much for.
Thank you, ma'am. I now invite Dr. N. Bhanumati, who I know has attended each and every session in the rehabilitation session. So I do welcome her to give, so that she can give her comments. Welcome, Bhanumati.
Thank you, Ms. Rashmi. And I really thank the organizing and scientific committee for having jotted down such a wonderful scientific program. I think Vanaja ma'am spoke our minds. Most of us from the audience thought the same because we were glued to our chairs. I really thought physical conference, we would have actually walked up here and there and moved out, but this was like totally glued to the chair that I don't want to miss this now. And this was a situation for most of us, I feel, who are like, hardcore clinicians or researchers or academicians. It was one of the best knowledge sharing virtual platform we have ever seen since the beginning of pandemic, after all the hard work that you all have put in for the last 2 years. Hats off to the whole team. And providing such valuable insights, you name it, you had it in the scientific program. It was like an academic feast, literally an academic feast. We didn't have food and coffee, Dr. Sunil, but it was like everything that you just wanted it, right from speech perception to music perception to play and setting goals to the basic to the advanced. Everything was there jotted down, and hats off to the team. And I was like seeing the audiology also, as ma'am said, I was into audiology as well, looking into the program list and said, oh, I missed it. And thank God it's recorded and it's going to be there. I can see it next week. So the content was chock full of the latest learning and practices from true world-class experts. The speakers were terrific. I literally felt like going and giving them a handshake and a hug for whatever they had presented. The keynote speakers, I can never say anything about. The keynote was fantastic. It was such good topics. The speakers were wonderful. They were so true to the heart, and they had just come out with such minute details of their topics. So it was really wonderful. Overall, a great conference. Speakers were top-notch. Sessions were educational, extremely useful and engaging, with plenty of immediately applicable information. So I think this is what all of us felt. And I think CIGI group is actually loading up with messages. And it's a record break, I would say, with such a virtual platform. Wonderful, sir. Hats off. Thank you so much.
Just add on one thing. Just one more comment. I congratulate the whole organizing committee and the IT team. IT team has done a fantastic job. I'm sure the organizing committee has worked hard for it, but then starting from the website, the way it is designed and everything is very amazingly done. So
in fact, they called us immediately if they had any issues, and they were just on their toes, I feel, to get to know if we are all connected on Zoom platform, and if we are not, just let us know what exactly is the issue. To each and every one of us, I'm sure they have done this for the moderations or chairing or presentation. So they were wonderful. Hats off to them too.
Thank you, Dr. Bhanumati, for those kind words. I now invite Dr. Badri Gore to give the vote of thanks. Welcome, ma'am.
Good afternoon. It is my proud privilege to render the vote of thanks. First of all, I would like to thank the faculty, the international faculty first, because they woke up at 3 a.m. or stayed at midnight or later just to give a talk, and share their knowledge. And cheerfully, they accepted. Thank you very much to the national faculty. Yes. Thank the national faculty. I thank the national faculty who gave equally of their time, though on a better term. But the World Cafes were wonderful, and everyone participated. Everyone worked overtime in the national faculty group as well. And that was a wonderful experience. Thank you very much. I would next like to thank the judges who did a wonderful job. They had to spend a lot of time, and thank all the judges. Thanks a lot. And it is also now my duty to thank our educational partners. So that is educational partners are without them, we will not be able to conduct many conferences. I would like to offer my heartfelt thanks to MEDAL, who is a strategic educational partner, for all their commitment and support. Grateful thanks to the Bangalore ENT Trust, which were our platinum partners, who stepped in at the very beginning without any hesitation. Thank you very much. I would like to thank our Diamond Educational Partners, Sanofi and Abbott, for their strong support. And all our Gold partners, thank you very much. My heartfelt thanks to the CIGI delegates and the steering committee of the Global Cochlear Implant Access Network, this being the 6th World Congress of Cochlear Implants in Emerging Nations, and the scientific committee, of which I'm a part, so it doesn't seem good to thank. But I would just like to offer a few reminiscences, which is really not part of the thanking. So but for the first, one of the rare times that, all the 3 streams of the cochlear implant team have been given equal emphasis. And for this, I offer my thanks to the chairperson organizing committee, chairperson scientific committee, who stood by and, let the whole thing, get equal emphasis. And thank you so very much. CIGI has come a long way since the afternoon one Saturday, when a small group met in a small hall, and we had a mini scientific program and formed a resolution to form an association. Who knew that we would reach this far? And it is the strong commitment of all the members and the seniors in the field, and the idea, Dr. Sunil, that's who all nurtured it and brought it this far. I would just like to offer an analogy from audiology. Now, when we select a person for cochlear implant, we measure the speech perception in auditory mode separately, audiovisual in the visual mode separately, and auditory visual mode together. Now, whenever the sum of auditory and visual is less than the audiovisual mode, then we are sure the auditory visual integration has happened. I think in this conference, the sum was more than the parts summed together. This became, good. And that was very good. It reminded me of my early days in the field when Dr. Sunil and I would meet 1 week in St. John's and 1 week in Dr. Chandrasekhar Institute to meet our patients. And it was like a lot of learning and fun that happened that day. It was also a great learning experience from the start, because cochlear implants have done that to the field of audiology, that they made audiologists bigger, and they made them also, more, more scientific and better clinicians. So that is what I would like to, and I pray that CIGI goes.
What we say as surgeons is audiologists are the scientists. We are just carpenters, the surgeons.
Okay, a long time ago, surgeons in the UK were called Mr., not Doctor. No,
they still are. They still are.
They still are. Okay. So yeah. And so, can I thank all the organizing committee, of which Avyaya is a huge, huge part. I thank on behalf of the organizing committee of the conference, a part of the organizing committee, Avyaya, thank you very, very much, and a great hand to them. We've been sending messages to them at midnight, this one needs to be sent a mail, send this, send the link, send that. Not one day I've heard, ma'am, or no one put off my call, and no one was rude. And yeah, thank you so much, Mr. Prashant, Mr. Anil, Shweta, Diksha, Manasa, Satish and Prashant. Yeah. He's the quietest one. Thank you so very much. They are very professionals, and I think they learned a lot about our field also. Yeah, you did, yeah. So yeah, it's a good managing events, that, and not the least of which Naveen and all they supplied us coffee, tea, food, everything, and kept us spirits. Yeah, it was a great experience being part of it. Thank you so very much for the CIGI members for supporting, and thank you so much. Can I call back Rashmi to this?
Thank you, ma'am, for saying it so wonderfully well. I think ma'am has echoed my thoughts too. This was something that both of us have been saying all through when we were organizing, that this is a conference that we have given equal footage to audiology rehabilitation. So we both were very excited to be part of this organizing committee. So ma'am has echoed our thoughts. So thank you so very much. I would also like to say thanks to Avyaya. I think it's been an amazing experience. interacting with them. So I thank them all. Now, I request everybody to stand up for the national anthem. Wherever you are, I need you all to stand up. So thank you so much.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Over to Dr. Sunil Dutt.
We would also like to thank our partners, the remote technical partners. Mintu, right? Mintu and his team. I don't know where they are sitting, but I think hats off to them too. You can stop live streaming, Mintu.
Yes, sir.
Let us know if when